करून उघडे ठेवले म्हणून मी तुम्हाला सांगितलं की गायब नका करू माझं। तुम लोग अभी इसको हाथ मत लगा, मैंने ओपन करके रखा था ना, वो गायब मत करो अभी, ठीक है तुम लोग? हाँ वो खुला ही है ना, इतने सारे
ये है फाइनल क्विज।
क्या रे ये अब ये क्यों ऐसे हो गया इसका?
मिनिमाइज करूंगा। नहीं कोई नहीं, रहने दीजिए,
ठीक है
बस।
मुझे यहाँ पे सिर्फ बोलना है
बस
ठीक है, ये ओपन है,
अपने लाइव जा रहे हैं ना।
एक्चुअली मैम इधर में इट इज नॉट विजिबल, इट
यस मैम।
इसके बाद जब यहाँ से जगह छोड़ोगे ना तो उधर से घूम के आना।
यस मैम। हाँ
कंडक्ट कौन कर रहा है?
कांचन मैम।
फर्स्ट राउंड कौन सा है?
माझे
यू बी रेडी।
हाँ नहीं पीजीकॉन चाहिए ना, फर्स्ट स्लाइड दीजिए ना सर।
ये चीज
मेरे
वो
इसमें
डला
है ना,
हुआ है, हमने
इसकी पहला
मिनिमाइज करके करे क्या हम लोग? हाँ इसीलिए रहने दीजिए।
होल ऑफ द टीम क्विज।
आफ्टर क्विज विल शो दैट।
होल ऑफ द टीम क्विज।
हाँ
यू वांट टू स्पीक समथिंग?
तुमचं ते झालेले आहेत सगळे स्टुडंट लॉग इन?
तुमचे लॉग इन झाले आणि त्यांना ते टीम्स चिठ्ठी काढणार आहे आणि मग ठीक आहे आय स्टार्ट।
ठीक है।
हेलो गुड मॉर्निंग एवरीवन। हेलो गुड मॉर्निंग एवरीवन। I don't know.
Yogesh, we start.
Good morning, everyone. I am Dr. Rohini Boyer on behalf of NOGS and NKP SIMS. I welcome you all on this fourth day of the academic feast NOGS PGCON 2022.
Hello, I'm Dr. Sanyukta Davale. I welcome you all on behalf of NOGS and Department of OBGY, NKP SIMS and Lata Mangeshkar Hospital on this last day of academic feast of NOGS PGCON 2022.
It's a big event for all of us, and the event is shaped to help the postgraduates to face the exam with confidence and ample amount of knowledge. In last 3 days, we had interesting case discussion, table vivas, and I hope we all are benefited by this. Today's events include the most awaited urogynecology quiz, followed by the inaugural function, then case discussion, table vivas, round cases, and the skill stations. Now, I would like to invite Dr. Kanchan ma'am to begin the most awaited urogynecology quiz. Wishing you all the very best, and please give your 100%. All the best to all the teams.
Good morning, all. All the team members have joined. Please confirm. GMC Akola, please unmute them. GMC Akola is there? Please unmute yourself and start your video. GMC Akola, okay, GMC Akola is there. Please unmute yourself. We'll first do team allotment.
Sanjita, please make them co-host.
All the teams, please make them co-host. And Dr. Buharewala ma'am also. Okay, GMC Nagpur. GMC Nagpur is there? GMC Nagpur, please start your video. Okay. Then IGMC Nagpur. IGMC Nagpur.
Yes, ma'am.
2 members of your team. Okay. Then NKP Sims, are you there? Yes. Then Savangi, JNMC Savangi.
Yes, ma'am.
Then Savangi. Yeah. Sevagram.
Yes, ma'am.
Where is Sevagram? Savangi. Video. Start your video. Savangi team. Your video should be on every time. You should not switch off your video at any time during quiz. PDMC, Amravati.
Yes, ma'am.
Okay, so we have 7 teams. 6 teams, which has been left. So we have GMC Nagpur, IGMC Nagpur, Sevagram, Savangi, NKP Sims, and PDMC. 7 teams are there, and Akola. So I'm seeing only 6 teams. Where is the 7 team? Amravati team,
Yes, ma'am. Yes, ma'am.
Sevagram,
Yes, ma'am.
Savangi. Savangi team.
Yes, ma'am.
Where is Savangi team? Please start your video. Raise
Yes,
your
ma'am. Yes, I'm just starting video, ma'am.
video. Your video. Please start your video.
Yes, ma'am.
Okay, Savangi team. Please, your video is not displayed. Start your video. We cannot see you. Savangi team. Asavari. Sanchita, please make Asavari co-host. Start your video, please, Asavari. Audio and video. Are you there, Asavari? Asavari? Asavari, are you there?
Yes, ma'am.
Check your internet connection. You should have good internet connection. Okay, so Asavari is there? Yeah, we can see you, Asavari. Now, first thing, we'll start with the team allotment. We have made chits and we will do this team allotment here only. Okay. GMC Akola first. So GMC Akola is please introduce yourself, Team Akola.
Ma'am, I'm Dr. Yash Mudina, a third-year resident.
You're not audible.
Hello.
Please be clear and loud.
Hello. I am Dr. Yash.
Please use your mic.
Ma'am, I'm Dr. Yash.
You're not audible, beta. Not clearly audible.
Hello.
Yeah.
Yeah. I'm Dr. Yash from GMC Akola. Yash Babu.
And the other person? Hello, good morning, ma'am. I'm Dr. Sonam from GMC Akola. Team A. Yes, ma'am.
So GMC Nagpur is team E.
GMC Nagpur, introduce yourself.
Good morning, ma'am. I'm Dr. Disha from GMC Nagpur.
I'm Dr. Arya from GMC Nagpur.
Arya and Disha are from GMC Nagpur, and you will be team E.
Yes, ma'am.
Third is IGMC Nagpur, Indira Gandhi Medical College Nagpur. Your team is team F. Please introduce IGMC Nagpur.
Yes, ma'am. You cannot do it.
Logged in with two devices from a same place. Whichever team is logged in with two devices from the same place, please log in with single device.
IGMC Nagpur, please introduce yourself. Your team is team F.
Yes, ma'am.
IGMC Nagpur.
Yes, ma'am. I'm Dr. Achla Singh from IGGMC Nagpur. I'm Dr. Shraddha Dhakre from IGGMC Nagpur.
So team IGMC is team F. As we move ahead,
Amrita Kharode.
Next team is team NKP Sims and LMH. Your team is team B. Please introduce yourself. NKP Sims.
Team B.
Yes, ma'am.
Please introduce yourself.
Ma'am, I'm Dr. Shreya Mogre, JR3 OBGY.
I'm Dr. Anuradha Hun, JR3 OBGY, NKP Sims.
so Shreya and Anuradha from NKP, your team would be team B. So Shreya and Anuradha from NKP, your team would be team B.
Yes, ma'am.
Next is Sevagram team. So Sevagram, your team is team C. Please introduce.
Good morning. I'm Dr. Mihir Ranade from MGMS Sevagram.
You are not audible, beta. Clearly not audible.
Hello. I'm Dr. Mihir. I'm Dr. Mihir from MGMS Sevagram.
Yeah. Second one.
I'm Dr. Nilesh from Sevagram.
Okay, so your team is team C. So MGIMS Sevagram team would be team C. I repeat, team C.
Yes, ma'am.
Next is Savangi. So JNMC Savangi, your team is team G. Please
Good morning.
introduce yourself.
Good
Savangi.
morning, ma'am. I'm Dr. Asavari Dev, and this is Dr. Arju Chadda from JNMC Savangi, ma'am.
So Asavari and
Arju, ma'am.
Asavari and Arzu from JNMC, your team would be team G, right?
Yes, ma'am. Thank you, ma'am.
And team left is PDMC Amravati. Your team is team D.
Yes, ma'am.
Amravati, please
Dr.
introduce
Apurva.
yourself. PDMC Amravati.
Hello.
Yes.
Good morning, ma'am. I'm Dr. Apurva from PDMMC. Dr. Prajakta from PDMMC Amravati.
So Apurva and Prajakta from PDMC will be team D. Apurva
Yes,
and
ma'am.
Prajakta, we are not able to see you.
Is it better now?
Yeah,
Yeah,
that's
yeah.
fine.
Yes.
At every point of time, we should be able to see you on the screen. So keep your
Yes.
videos on. All the 7 teams should be seen at every point of time till the quiz is over. Am I clear?
Yes, ma'am.
So all the 7 teams should keep their videos on and we should be able to see you at all point of time. Okay?
So we will revise the team. Team A is GMC Akola. Where is GMC Akola? GMC Akola team. You are not visible.
Raise your hands. We will adjust the mic. Yes.
Yeah.
Okay.
Then team B is NKP Sims and LMH. Please raise your hand. NKP Sims team. Yes. Team C is Sevagram
Yes,
team.
ma'am.
Yes. Team D is PDMC Amravati. Team D
Yes,
is
ma'am.
PDMC. Where
Yes,
is-
ma'am.
Okay. Then team E is GMC Nagpur.
Yes, ma'am.
Where is GMC Nagpur?
Yes, ma'am.
Yeah. Then team F is IGMC Nagpur.
Yes, ma'am.
IGMC Nagpur. Then team G is Savangi, JNMC Savangi.
Yes, ma'am.
Okay.
Now, just a minute, before we start the quiz, I want to take 1 good minute to spend some time that our mics are well adjusted. All of you are nicely seen and your teams are displayed. So now we have renamed your login accounts as your teams. I hope you can see that. So accordingly, like NKP Sims has been named team B, GMC Akola has been named team A. Please check that that is correct. Second thing is, both of the speakers should be visible full time on the screen. If you are not visible, both of the audience are not visible, then you will be disqualified. So both of you should always be visible on the screen. Try to not to sit in front of the window, just because we cannot see your faces, we can see the glare of the window. So if you can rotate that the screen is adjusted. Now, third point is we will allow you to speak one by one. We'll communicate 1 or 2 lines with each of you. All of you have been made co-host. Understand well? Okay, adjust, team A adjust, then I will talk.
So good morning, students. We'll start with our...
Wait, ma'am, wait. Team A is still adjusting.
Okay.
Okay, now we are set. You have team A is logged in with mobile, I guess. I hope everybody is ready with the charge. Now listen, all of you are co-host and all of you have mic under your control. The teams are co-host and we'll make our judge co-host, Dr. Buhari Wala madam. We welcome you, ma'am. Just a little time to make adjustments. Just a minute, ma'am. We're making you co-host, so the mic control is in your hand. Don't rename her, just make her co-host. Yes. Yes, ma'am, you are co-host now. So mic control is under all the teams and judge and us presenters. All rest of the people will be mute. Whenever you have to speak, when the team has to answer, then only you have to turn on the mic. Don't turn on the mic when others are speaking. At the time of audience question, we will unmute everybody. At the time, or shall we ask the questions in chat box? Answers. So please answer in chat box. That would be great. The first answer will be taken. Okay? Because if we unmute, that will be a problem. So for the audience, you have an announcement that you can answer the audience answers in chat box and the first answer will be taken. Now we will ask each team to unmute yourself one by one and speak to us few lines. Maybe that may be your introduction. So let's start. Team A.
Hello.
Team A. Yes.
Yeah, are we
Are we audible, ma'am?
Yeah.
So
Good morning, ma'am. Myself, Dr. Sonam Shikar, a resident GR3 on GMC Akola, originally resident from Bombay.
So this is team A from GMC Akola. Yes,
GMC
I think the mic testing is done. Do you have any doubts before starting?
no, ma'am.
You're clear, right? Okay.
Yes, ma'am.
If you have any problem, you can text message me immediately on WhatsApp, on your group, on your quiz group.
Or you can call me directly. If you are not, the screen is not visible or there is problem with audio, you directly call me. You have my number.
Okay.
Yes, ma'am.
Yes, ma'am.
Team B.
Team B, NKP Sims. Shreya, Anuradha.
Hello. Good morning, ma'am. Yes, ma'am. Are we
Your
audible?
video is not visible. Anuradha, your video. Okay, now it's visible.
Unmute yourself and speak.
Please test your audio. Anuradha, Shreya.
No, Do we have the internet issue or they have the internet issue? Okay.
Introduce yourself.
They have an internet issue from their side. Yeah. जो ज्वाइन कर रहा है वो नहीं म्यूटेड है क्या? ऐसा है क्या?
Yes.
There was a connectivity issue for some seconds from your side. Please take
There was a connectivity issue for some seconds from your side.
Okay, ma'am. Now are we visible properly?
Okay, the mic testing. Have you logged in from 2 devices?
Have you logged in from 2 devices?
Anurag,
ma'am?
Shreya, have you logged in from 2 devices?
Yeah, have you logged in?
No, ma'am.
Introduce yourself.
Introduce yourself. Ma'am, Dr. Shreya Jayatri OBGY from NKP SIMS.
I'm Anuradha Mon from JR3 OBGY from NKP SIMS.
Okay. Next team is MGMIS
wait.
Sevagram. Team C. Please introduce yourself. Team C.
Good morning. Are we audible, ma'am?
Yeah,
One
yeah,
minute, one
yeah.
minute. We will go back to team B. I was not satisfied with mic testing of. We had an echo with them.
Team B.
Team B, please go again.
Team B, are you still having an echo?
Yes.
Yes.
When we are speaking, we are having an echo.
Yes.
When your mic
There is no device log.
When you're
You are logging from Apurva's mobile. Shreya.
No,
No,
ma'am.
ma'am.
Is somebody around?
No, ma'am.
Apurva का number दिखा वहाँ पे screen पे.
No, ma'am.
Hello. Okay, now it looks fair. Now I think
Still echoing?
back. Team B, speak again.
Is
Now
there
I
still an echo?
Shreya, speak again.
Yes, ma'am. Is there still an echo?
now
No,
not
now it's
not.
better.
It is fine. Yes.
Okay, fine.
Okay,
Go
ma'am.
ahead with team C.
Team C, Sevagram. Please introduce yourself. Team C.
Good morning, ma'am. I'm Dr. Mihir Ranade, JR3 OBGY from Sevagram.
Yes.
Perfect.
Myself, Dr. Nilesh Solanke, MGMS Sevagram GR3, MGMS Sevagram.
Yeah, good.
Yeah,
Team D,
good.
PDMC Amravati. PDMC.
Please unmute yourself, team D.
PDMC Amravati.
They are in poor internet connection. Do we have any pass on rounds or buzzer rounds? No. Okay. Okay.
Are you there? Apurva Mukherjee. Are you there?
Team D is hanged up. Call them. Somebody take the charge of calling them immediately.
Can we take next team?
And team D.
PDMC Amravati.
Okay, by that time we can move ahead with the next team. By the time they join back, we can move with the next team. Team E.
We take next team GMC Nagpur. Team E.
Yes, ma'am.
Good morning, ma'am. I'm Dr. Disha from GMC Nagpur.
Perfect.
Okay.
Then team F, IGMC Nagpur.
Unmute yourself.
IGMC.
Good morning, ma'am. I'm Dr. Shraddha Thakre from IGMC Nagpur.
Yeah, second one.
I'm Dr. Achla Jayatri OBGY GMC.
Perfect. Next team, team G from JNMC Savangi.
Good morning, ma'am. I'm Dr. Asayari Dev from JNMC Savangi.
Good morning, everybody. I'm Dr. Arzu from JNMC.
Your audio is not clear. Speak
It
again.
would be better if you use a mic, mic in the sense, earphones with speakers.
Earphone. You can use earphone with mic. Savangi JNMC, can you
Yes,
speak?
ma'am.
Yes, ma'am.
Yes. Or be loud.
Can you hear us, ma'am?
Yes.
Yes.
There's no echo. This is fair.
Okay. Now team D, PDMC Amravati. Are you there? PDMC Amravati, are you there?
Not yet. We can't see them. They have logged out. Have we in connection with them? Could we call them? With the rest of the teams.
No, we cannot say till all teams join.
We'll just wait for a few seconds so that team D joins in, okay? And then we start. I hope you understand that this was very important and we take 2 minutes extra here, but rest of the quiz would be fine then. So all the teams are relaxed and set. Yes, I see. I want to see the smiling faces from all of your screens, you know. A, B, C, D, not there. E, F, yes. Relax. Enjoy the
Apurva,
quiz.
Prajakta, are you there?
Concentrate. Decide your speakers and enjoy. And then fight with us for marks. Huh? Don't do that. Huh? Yes, learning with enjoyment. Do not speak for other teams, you know, like unmute yourself and speak answers of other team. If you want, you can do that for NKP Sims. Sorry, for fun. Team D is having some problem in logging in. We will wait for a minute. Huh? Ma'am, Buhariwala ma'am, please unmute yourself and speak few words for the budding gynecologists. We can't see your face, ma'am. Yes, ma'am. Ma'am, you are unmuted, but we can't hear you. We can't hear you, ma'am. Are you able to hear us, ma'am? Please raise your thumbs up. Yes, you are able to hear me. We can't hear you. Ma'am, you may please log out and log in again if it is possible.
लॉगिन होते ते हां पण ते लॉगिन होते ना लॉगिन झाला तर परत नेट बंद झालं त्यांनी पुन्हा लॉगिन करतात आणि बंद झालं लॉगिन झालं
मैम मे बी ज्वाइन विद द ऑडियो ऐसा कुछ क्लिक करना पड़ेगा.
Yes, she was telling you that she is unable to log in into the Zoom. I told her to use password and user ID and then try. She's trying.
Hello, everyone, all the teams. I'm sure you all are going to enjoy this quiz and at the same time learn a lot of things. Urogynecology as such is such a wonderful subject and one of the upcoming super specialities as far as gynecology is concerned. It's not only interesting,
yes,
but it's so much challenging. So many things that we can really learn and move ahead with time. Skills that you can develop and so many things that you can really get as you are going to grow over a period of time. Has Team D joined?
Yes, ma'am.
Yeah. Apurva and Prajakta,
Yes,
both
ma'am.
you should see to it that you are going to be logged in for all the time. Otherwise,
ma'am.
all the teams who log out will be disqualified. And at all points of time, we need to see all of you on the screen. The
Yes,
team which is not seen will get disqualified. Please keep this in mind. We have given you a lot of time. We've given you all the instructions to keep yourselves in a place where you have got good connection. So if you are not able to do that, we will see to it that you are, if you're not seen or if you are logged out, you will be disqualified. Okay. So enjoy the quiz and I hand over the mic to Kanchan.
Team D, we could not do the mic testing with you. Could we please do the mic testing?
Apurva,
Hello, ma'am. Are we audible?
please introduce yourself.
Hello, ma'am. Are we audible?
Yes.
Good morning, ma'am. I'm Dr. Apurva from PDMMC. Dr. Prajakta from PDMMC.
Yes, good. So
Yeah.
we'll start with our most awaited event of this PGCON, that is Vidarbha level online postgraduate quiz on urogynecology. The quiz masters for today's quiz are Dr. Savita Somalwar, Dr. Nikita Vijay, Dr. Sheila Jain, Dr. Kanchan Divedmuthe, Dr. Rohini Boyer, Dr. Sharvari Lothe, Dr. Amruta Singh, Dr. Rita Bang, Dr. Snehal Nafde, and Dr. Sayukta Davle. Judges for the today's quiz is our esteemed ma'am, Dr. D.N. Buhariwala ma'am. Scorekeeper are Dr. Sheila Jain ma'am and Dr. Sharvari Lothe. Timekeeper, Dr. Snehal Nafde and Dr. Vishal Raman. Rules, general rules for the quiz are: participants should have a proper printed display of their college names pasted behind them on the wall. Webcam should not be switched off at any point of time during the quiz. The webcam should be at the distance of 2 feet so that all the participants are clearly visible. The mic should be kept mute if not answering. The team will answer the question directed to the specific team only. Please unmute yourself while answering. There are 6 rounds in all. Specific rules for every round will be told at the beginning of that particular round. Each team should identify a spokesperson to avoid the double answer. The first and second round will rotate in a clockwise direction. So we'll start with team A. Third and fourth round will rotate in anti-clockwise direction. We will start with the team G. And fifth and sixth round again will rotate in clockwise direction, that is from team A. For all rounds, if the team asks for repetition of question, it will be done, but clock will remain on and the team will lose time. The answer should start before the time is over. Completion of answer may take longer time. Only answer uttered first will be considered. All the participants are requested not to carry any electronic device like mobiles, tabs, iPad, and any type of books. Keeping a mobile or other device will amount to use of unfair means if found, and that 20 marks will be deducted or even may be disqualified from the quiz. In case of any technical problem related to internet or connectivity, participant can communicate with the organizing team. Quiz masters and judges' decision stands. Rules for audience. Audience will be muted by the admin. Audience is requested not to write or type the answer directed at the teams. They can write the answer for audience question only. The teams for today's quiz: GMC Akola, Dr. Sonam and Dr. Yash; GMC Nagpur, Dr. Disha and Dr. Arya; IGMC Nagpur, Dr. Achla and Dr. Shraddha; NKP SIMS Nagpur, Dr. Anuradha and Dr. Shreya; JNMC Savangi, Dr. Asavari and Dr. Arzu; MGMIS Sevagram, Dr. Mihir and Dr. Nilesh; and PDMC Amravati, Dr. Prajakta and Dr. Apurva. We have 6 rounds in the quiz. First round is crack the case. Second round is sneak peek. Third round is ulta pulta round. Fourth is matinee show. Fifth is beyond horizon. And sixth is fast and furious. Now we'll start with the quiz. All the best to all the teams. Can you see screen? All the teams, can you see screen? Please respond.
Yes, ma'am.
Yes,
Yeah.
ma'am.
Yes, ma'am.
Yes, ma'am.
So already done allotment of team. So all the best. So for the first round, I invite Dr. Sayukta Davle. The first round is crack the case.
Good morning, everyone. The most important instruction before starting the quiz is you keep your backup for charging as well as for internet ready. There should not be any hindrance. So we'll start with our first round of this quiz is the crack the case. You be the detective, seek and solve the case. So we'll start with first question to team A, that is GMC Akola. Rules for this round is it will be in clockwise direction. Each team will get one case scenario followed by 2 questions. You can take second question even if you are unable to answer first question, only if you say pass. Each correct answer will get 10 points, no points for a partial answer. No negative marking, time allotted is 10 seconds. You have to start answering within 10 seconds. Case are not transferable to other group. So our first question to team A GMC Akola is, a 46-year-old lady, para 3, reported to the OPD with the history suggestive of stress urinary incontinence. Your first question is, how will you differentiate between internal sphincter deficiency and hypermobile urethra?
Your time starts now.
Answer is clinical examination, empty supine stress test, Q-tip test, and Boney's test. Your second question for team A is, give at least 2 non-surgical surgical management options.
Ma'am, Kegel exercise.
Yes.
Kegel exercise.
Yes. One more.
And vaginal cones. Like behavioral therapy, you can give a.
Yes, you will get mark for that. You will get 10 points for that.
Thank you.
Answer is behavioral therapy, pelvic rehabilitation like Kegel's exercise and tone device, bladder drill, void by clock, biofeedback, and pharmacotherapy like conjugated estrogen and duloxetine. Okay, so our team A is getting 10 points. Next question to team B, that is NKP Sims.
Are you there?
Are you ready? Please
Yes,
respond.
ma'am.
Yes, so your question is, a 33-year-old lady, para 2, complaining of dribbling of urine on 7th postnatal day and is diagnosed to have 1 into 1 centimeter of vesicovaginal fistula. Your first question is, when will you operate her?
Within 3 months, either after 3 months or within 6 months.
Okay, you will get 10 points for that. It's correct. It should be repaired after 3 months. Your second question is, give 2 indications for abdominal procedure for repair of fistula. Your time starts.
If high vaginal fistula, and if there is a fibrotic perineum and you can't go via perineal approach.
Please repeat your answer, please.
If there is a high vaginal fistula and if there is a fibrotic perineum and you can't go via perineal approach, or the fistula is more than 2.5 centimeters.
And when it is not accessible by vaginal route.
Yes, your answer is correct. You will get 20 points for both the answer. Second answer for second question is supratrigonal fistulas, trigonal fistulas, multiple fistulas, failed previous surgery, and if bladder capacity has been significantly reduced, for bladder augmentation. So you will get 20 points for that. Our next question for team C, that is MGIMS Sevagram. Your case scenario is, a 24-year-old nulli gravida has level 1 defect and stage 3 prolapse. Your first question is, Give at least 2 causes for congenital prolapse. Your time starts now.
Any Marfan syndrome? Any
No points will be allotted for partial answer. You have to answer 2 causes. So the answer for this question is weak and poor development of fascia due to collagen defect, spina bifida, and myelodysplasia with split pelvis. Your second question for this case scenario is, how will you clinically differentiate between prolapse in young and elderly women? Your time starts now. You have to start answering within 10 seconds.
on the clinical examination?
Sorry? Please be clear.
You can complete your answer.
Yes, you can complete your answer as you have started within 10 seconds.
Ma'am, on clinical examination, if we ask on post-speculum examination, if we ask the woman to do a Valsalva maneuver, and then if there is a prolapse.
No, it is not correct. So the answer is the uterocervical length will be more due to supravaginal elongation of cervix because of strong uterosacral ligament, and there will be deep posterior fornix. So you have not answered both the questions, so you will not get any points. So we'll move to our team D, and
Yes, ma'am.
scenario for team D is
PDMC, are you there?
Yes, ma'am.
78-year-old lady, para 5, has level 1, 2, 3 defect and stage 3 prolapse. She is a known case of IHD and is high risk for prolonged anesthesia. So your first question for this case scenario is, give 2 treatment options.
We could do Leafort's operation, or we could do Dani stitch, or modified version of Leafort's operation.
Yes, you will get 10 points on that. Yes, it is a correct answer. Leafort's partial colpocliasis can be done. Goodell's and power modification of Leafort's with suburethral plication of pubocervical fascia is done. Okay, you can do TVT and TOT if there is SY. Okay, so you will get 10 points on your first answer. Second question for this case scenario is, give 2 prerequisites for Leafort's.
The uterocervical length should be normal for Leafort's operation.
Yes.
And
one more.
Second.
As you have started, you can answer.
Uterocervical length. No, ma'am. I can't remember.
So,
sorry.
Is the time up? Yes. So you will not get any points for B question of this case scenario. The answer is pap smear should be normal, no decubitus ulcer, cervical pathology or cervical elongation, prolapse should be reducible and complete. So you will get only 10 points. Okay. So we'll move to team E, that is GMC Nagpur. Are you ready, team E?
Yes, ma'am.
Yes. So the case scenario for team E is 55-year-old lady, para 4, comes with the complaints of some mass coming out of vagina. On examination, there is level 1, 2 defect, stage 3 prolapse, anterior vaginal bulge, wall bulge is seen with rugosity present. Lateral sulcus is not seen. So first question for this case scenario is, what is this condition? Your time starts now.
Displacement cystosis. Displacement cystosis.
Sorry?
Displacement cystosis. Displacement cystosis. डिस्प्लेसमेंट सिस्टोसील मैम।
नहीं, मुझे वॉशरूम जाना है, लेकिन वॉशरूम में कोई है, इसलिए मैं इधर उधर चल रही हूँ, मुझे बहुत जोर से वॉशरूम लगी है।
डिस्प्लेसमेंट सिस्टोसील।
Okay.
Cystocele.
Okay, we'll give you points for that. It is lateral cystocele or paravaginal cystocele. Okay, so you will get 10 points for that. Your second question for the case scenario is, how will you differentiate between lateral and central cystocele defect?
In central cystocele, there will be no rugosities. In displacement it is also known as distension cystocele. In lateral, there will be rugosities, and there will be absence of the lateral sulcus of the vagina.
That will be on examination, but how will you differentiate it from any test?
If we will, by the help of a sponge holder, we will elevate the interior vaginal wall and we'll ask the patient to cough. There will be no prolapse.
Yes.
Thank you, ma'am.
So you will get 20 points as you have answered both the question correctly. The answer is cough test. By keeping index and middle finger to elevate the paravaginal region, ask the patient to cough or strain. If cystocele bulge is not seen, it is suggestive of paravaginal defect. Yes, you are correct. You will get 20 points for that. We'll move to team F, that is IGMC Nagpur. Are you ready, team?
Yes, ma'am.
So the case scenario for team F is a 62-year-old lady who has undergone VH with AP repair for level 1, 2, 3 defect, stage 3 prolapse 15 years back. Now came with walled prolapse. So first question for this scenario is, what is the most likely cause for this? Your time starts now.
Due to uterosacral, due to non-suspension of hold.
Yes. The answer is improper enteroceal repair with no suspension of vault has been done. Okay, so you will get 10 points for that. A second question for the same case scenario is, give at least 2 surgical procedure for managing this condition. Your time starts now.
Abdominal sacropexy and sacrospinous fixation.
Yes. You will get 10 points for that. It's a correct answer. The answer is sacrocolpopexy, sacrospinous fixation, unilateral or bilateral by abdominal or vaginal approach, high uterosacral fixation, iliococcygeus suspension. Okay, so you will get 20 points for that as you have answered both the question correctly. So we'll move to team G, which is our last team. Are you ready, team G? That is JNMC Savangi. Are you ready, team? Team G, are you ready?
Yes, ma'am.
So the case scenario for team G is a 44-year-old lady with para 3 with prolapsed uterus, with history of incomplete emptying of bladder and dragging discomfort in pelvis. Her POPQ grid is, can you, the POPQ grid is visible to you?
Yes, ma'am.
So the question for this case scenario is, what is her diagnosis according to POPQ?
Ma'am, this patient can be classified as stage 3 prolapse according to POPQ scale.
Yes. Would you like to complete that sentence? The diagnosis?
Ma'am, the diagnosis for this patient would be the
prolapse with?
Grade 3 prolapse.
Got a defect.
Defect in the posterior wall.
-1,
this.
We'll give you marks. Okay, your answer is correct. It is a stage 3 prolapse with cervix as a most depending part with level 1, 2, 3 defect. Okay, the second question for this case scenario is, what is the advantage of POPQ over traditional grading system?
POPQ system can be objective, and it can be if somebody in some place draws according to POPQ grid, it can be correlated with results of other people in other places as well. Plus, the site-specific repair also can be performed according to POPQ scale, as it distinguishes between defects at various places.
Yes, you are absolutely correct. Your answer is correct. You will get 20 points as you have answered both the question correctly. The answer is, it is more objective and helps to quantify the defect, allows the use of standardized technique with quantitative measurements at straining relative to constant reference point, that is hymen. Its ability to access prolapse at multiple vaginal sites. Okay. So team G, you will get 20 points for that. There is one question for audience. 46-year-old lady, para 2, complains of increased frequency and urgency of micturition and has to get up 2 to 3 times at night to pass urine. No history of any surgery, medical or neurological disorder. PSPV and per rectal examination was normal, and urine analysis and urine culture was also normal. So first question for this case scenario is, what is her diagnosis?
You can type in chat box.
Yes, please type your answer in the chat box. Next question for the same scenario is, what is the treatment? Please type your answer in the chat box.
We can take it afterwards. Please type your answer in chat box.
Okay, I'll hand over the mic to Dr. Kanchan ma'am.
So the scores at the end of rounds, I request Dr. Sharma and Dr.
Hello everyone. It's a good start. We have 4 points. Team B, Team D, Team E, Team F, and Team G. 4 teams. B, E, F, and G tied at 20 points. Team A and Team D have scored 10 points each, and Team C is yet to open the account.
So all the best, Team E and Team C. You are doing great. So you have more rounds to score. So next round is a sneak peek round. I invite Dr. Amrita Singh for this round.
A very warm morning, everyone. Let me first of all welcome our judge, Dr. Buhariwala ma'am. Ma'am has been the founder member, the creator of this department in the institute. She's been a very great academician, helping out all through years. Yes, audiovisuals, can we have the video of ma'am? Ma'am, our audio testing was also left. Could you please unmute your mic, ma'am? And cheer up our team. Yeah. Could you please speak few words, ma'am? We cannot hear you, ma'am. Sanjayta, could you please make co-host, ma'am? Yes. Yeah, we can hear you, ma'am. Maybe if you could adjust your screen a little bit, ma'am, so that. And audio is also not, yeah. In the meanwhile, all those who had urgencies in the last round can empty their bladder, have their tummy filled with sips of water, the teams. Okay, let us give some more time to ma'am. Maybe some technical issues. We'll start the next round, ma'am. We'll get back to you again. Okay, ma'am, you can show the thumbs up, at least a sign. You're seen. Okay, ma'am. We'll proceed with the next round. It's a sneak peek round. So we are the quiz. Ma'am, would you like, now you have unmuted, could you please speak and let's have a check of your audio from your end? Okay, after the end of this round, ma'am, we'll get back to you. So let's begin. Teams, we are the quiz masters, me and Sharvari. Yes, audiovisuals, can we have the spotlights on our scorekeepers and the timers also once? In the meanwhile, I'll read out the rules for the teams. One picture will be shown to each team. 2 questions will be asked to the team related to the picture. 10 seconds will be given to answer the question. Time will start after the completion of the question. Each question carries 10 marks. Marks will be given individually for each question only after the completion of answer. Only one person will speak at a time. Teammates should coordinate accordingly. There is no negative marking and it is a non-transferable round. So team A, are you ready?
Yes, ma'am.
Yes, ma'am.
Okay. So here goes the first question. Interpretation of the test.
Ma'am, 3-swab test.
No, but what is the
Super.
And yeah. Ma'am, uretro.
Vasaico.
Where is this test used? Why is this test being done?
Ma'am, to differentiate between where the fistula is, whether it is vesico-vaginal, uretrovaginal, or urethrovaginal.
Super. Let's go to the next question. Scorers, they have scored in this. What are the common sites of ureteric injury while performing abdominal surgeries?
Common sites of ureteric injury.
Injuries while performing abdominal surgery. Your time starts now.
Ma'am, at the level of pelvic brim. Ma'am, when the uterine artery, at the level of uterine artery, then at the level of internal os, and when it enters the bladder, ma'am.
Okay, actually your partial answers are not given complete marks. For the first half, we will give you. Let me give you the answers of it. So the interpretation, as you correctly said, 3-swab test for the interpretation at which level the fistula is uretrovaginal, vesicovaginal, or urethrovaginal. So you get the first half, the 5 marks. The second one, 5 common sites of ureteric injury. Cardinal ligament, where the ureter crosses under the uterine artery. So this one you named it. But then there were intramural portion of the ureter, dorsal to infundibulopelvic ligament near or at the pelvic brim, lateral pelvic side wall above the uterosacral ligaments. So now we shift on to the next team. Team B.
Ma'am, we did mention the pelvic brim count.
Yeah, but I wanted complete answers. There were 5 answers.
Okay.
So we had initially told in our rules, we wanted all the answers, then we'll be giving you. Okay.
Thank you.
So halfway, 5 marks we give you. Fine. Let us have the next team, Team B. Team B, NKP Sims. Are we ready? Please say yes, no.
Yes.
Team B, you're not seen. We have initially told you should be visual. Yeah. Fine.
Sorry, ma'am, you are visible.
Yeah, you're visible. So team
Visible, ma'am.
Yeah. The question starts for Team B. Identify the condition and tell the presentation of the patient. The time starts now.
Anterior cystocele, presentation, dorsal lithotomy. What's the presentation?
A hint from the picture.
Anterior cystosine.
Sorry, TB. We got the wrong answer. It is imperforate hymen, the bluish tinge which you could see. है ना?
Actually, we are not able to see the picture, ma'am, clearly.
Not visible. But for anterior cystocele, where is the uterus? Nothing is seen. Na? That bluish tinge, the bulging, thin membranous thing. Okay. We'll discuss it later. We'll shift on to the next question. Okay. What is Werner Wunderlich syndrome? Okay. Let me give you the answers for both the questions. You scored none in this, team B. So first one was imperforate hymen. Patient will present with primary amenorrhea and cyclical pain. Werner Wunderlich syndrome is also called as Ohiwara syndrome. In this, there is unilateral obstructed hemivagina, uterus didelphys, and ipsilateral renal agenesis. So since menarche, the lady will have regular menstrual cycle, and along with it, they will also have pain abdomen. Eventually, the pain abdomen present as a mass abdomen. So now we shift on to the next team. Team C. Are you ready? Let's meet the Amitabh Bachchan of our profession. Oh, we have two Amitabh Bachchans already. Come on, you know only Shah Rukh Khan and Hrithik Roshan? So you need to identify the scientist. Hai na? Your time starts now. Let me introduce it. Okay, I'll tell you the answers. This is Sir Shirodkar, Dr. Shirodkar, sir. Next question, any two entities related to him? Any two entities?
Shirodkar sling surgery, Shirodkar stitch for cervical incompetence.
Correct. So you get the partial thing, you get 5 marks. So,
Sorry, we are not giving any marks for partial answer. You will get marks only if you answer fully.
Ma'am, we said the second answer, Shirodkar sling surgery and Shirodkar stitch for cervical incompetence.
Yes. 5 na madam.
Yeah, you were right. You get the second. We were actually thinking of the first one. You don't get the first question answer. You get the second question since you answered twice. Two, you wrote Shirodkar sling and also you talked about encerclage. So you get 5 marks. So team D, are you ready?
Yes, ma'am.
Yes, ma'am.
PDMC Amravati. So your question starts now. Name the device and the procedure where it is used.
It's a space occupying pessary.
Your time goes.
Hello.
Let me ask you the second question. Actually, it is a mold, vaginal mold.
Okay, yes, like neo-vagina for neo-vagina.
Second question. Time starts.
Ma'am, there's some disturbance. Hello. Hello.
Yeah. Is it clear now?
Yes, it's clear.
Your time starts now.
There is somebody who's unmuted from the audience. Just see a control on that. Everybody's muted.
Hello, ma'am. What is the second question?
Yes.
Yeah. Name any two principles of the procedure.
It's for use for neo-vagina creation.
Yeah.
Many
What are the principles we take care of? Prerequisites, principles you can say. We need to be careful. Okay, I'll give you the answer. Actually, you didn't name any single principle, nor could you identify the device. So you scored 0 in this round. It is a vaginal mold used for vaginoplasties. And the principle is there should be adequate space between rectum and bladder. You need to be careful while dissecting the space, not to injure rectum or bladder. And the very important thing, for the follow-up, you should see that there is a continuous and prolonged dilatation of the vagina. Hence, prior to the surgery, we make sure the patient is getting married within 6 months of the surgery, so that that doesn't heal again. So we go to the next team, Team E. Team E, are you ready?
Yes, ma'am.
KMC Nagpur. So
Ma'am, the picture is.
Name the device. The time starts now.
Okay.
Cysto-ureterometry.
Cysto-ureterometry. ma'am.
Okay. Okay. Now goes the second question. Criteria for surgical management of SUI without urodynamic evaluation.
If there is the proof that it is not a mixed incontinence, it is clear-cut surgical SUI or incontinence and there is no there has been no previous surgical operations done, then it is the first time for the patient to be operated. And
Okay, that's good. That's great. So as you said, firstly, the first answer was Euroflow-meter. And as you said, the symptoms are clear of SUI. There is no mix. So we need not go through this complex urodynamic study. And there are no previous prior history of any anti-incontinence surgeries. So they get full marks for this round. Next, we shift on to the next team. Team Team F. Team F, are you ready? Should I begin my question?
Yes, ma'am.
Yeah. So your question starts now. Identify the procedure.
It is first colpo suspension.
Superb. So we shift on to the next question. The next question is, why this procedure is superior over MMK?
Ma'am, because we do not Ma'am, because we do not enter the retropubic space and doesn't injure the urinary bladder ureters.
More specific. Okay, you give the partial answer. The first is right, Bursch colpo suspension. The second for that, why this procedure is superior, as you can see in the picture itself, the suture, the side, they have been taken to the side wall to the arcus tendinous. In MMK, they take to the retropubic bone. So there are chances of osteitis, periosteitis. Hence, Bursch colpo suspension was better than MMK. So you get 5 marks. Team G. Are you ready, Team G? Savangi? JNMC Savangi?
Yes, ma'am.
Okay. Your question starts now. Identify the procedure.
Is it anterior colporaphy, ma'am?
Please be clear. What? What did you say?
Anterior colporaphy.
Anterior colporaphy. Actually, to be more specific, precise, we wanted. It is a site-specific repair. Paravaginal.
Yes, ma'am. Site-specific repair for
only anterior colporaphy, but this was not anterior. This is laterally going. So you don't get this. What are the 2 advantages of site-specific repair?
Ma'am, the site-specific repair helps in preventing further recurrence of the same pathology as
clear, slow and clear. Yeah.
Ma'am, site-specific repair helps in preventing further recurrence of the similar pathology, and it can help in identifying the specific defect in the particular compartment.
Okay, so you've done a corrected surgery, targeted surgery, hence you were right. Okay, you get the partial answer. Again, you get 5 marks. You could not identify the procedure, but principles you could identify. So this is a paravaginal defect repair. The advantages are the vaginal length is not much compromised, and also the recurrence rate, as you said, because it is a site specific, so it is less compared to traditional way. So they get 5 marks of it. So do we have time for audience, or should we check mic testing for ma'am Buhariwala ma'am? Ma'am Buhariwala ma'am, are we ready? Could you switch on your video or audio? Could you, ma'am? Okay, well, in the meanwhile, till madam gets ready, scorers, timers, do we have time?
Hello.
Yes, ma'am, we can hear you. Please, ma'am.
Yeah. Good morning, everyone. It's lovely being here for this quiz, and it's all going on very well. Hello, you can hear me?
Yes, ma'am, we can. Thank you, ma'am.
Yeah.
Good morning.
It's wonderful to see young people participating and trying their best to answer all the questions. The questions have been very well selected, and I wish you all the best. I don't think I'll take much of your time. Please go ahead.
Thank you, ma'am. Thank you for your valuable inputs. So, Kanchan ma'am, do we have time for audience? I'll hand over mic to Kanchan ma'am for the next round or time for audience. The next question is for one question for the audience, then we'll skip on to the next team. Okay. Identify the picture. Audiences, please write it on the chat box. What is this picture of? Oh, great. People have already started answering. Very good, Arya, Marve. Okay. The next is name any 2 indications of abdominal circle arch. Fast, fast, fast.
You can write in chat box. We'll discuss later.
Thank you.
Thank you, Amruta. The next round is the score at the end of this round.
So at the end of round 2, we have team A at 15 points, team B 20 points, and team C with 5 points, team D with 10 points, and team E is leading with 30 points, team F and team G both tied at 25 points.
So congratulations, team E. Buck up all the teams. We have next round, that is Ulta Pulta round. I invite Dr. Nikita Vijay to conduct this round. Welcome, Nikita.
Thank you, Kanchan. A very good morning to all of you. How is the team Josh? How is the Josh? All the teams? No sound. Okay. So my round is Ulta Pulta. This round is little bit brain teaser round. The rules for the round are, as this is the anti-clockwise round, we will start from the team G and we will go to the team A. Each team will be given a jumbled word. If word is identified without a clue, 10 marks will be given to team. Time will be given as a 10 second. If word is identified after the clue, 5 marks will be given to team. Time will be given as 10 second. Even if word is not identified after the clue, word will be told to the team and team is allowed to answer the next question. One question will be asked related to that word. Correct answer will be given 10 marks. Time will be given as 10 seconds. Incomplete answer will be given 0 marks. No negative marking, and it's a non-transferable round. So team G, are you ready? GNMC Savangi.
Yes, ma'am.
Okay. Your word is? Your time starts now. Identify the word. All words are related to urogynecology.
Ma'am, delancey.
Okay. Absolutely, you are absolutely right. The word is delancey. There is no need of clue. So they will get the 10 marks. So next question is, what defect in which layer of delancey support results in enterocele? Your time starts now.
By the different and first ma'am, level 1 support.
Okay, you are right. You are absolutely right. The answer is level 1 delancey support of vagina. So after this round, team G get 20 marks. Okay. Now coming to the team F. This is IGMC Nagpur.
Yes,
Are you
yes,
ready,
yes.
team?
Yes,
IGMC
ma'am.
Nagpur.
Yes, ma'am.
So the word for team F is identify the word. Your time starts now. Don't worry, we have clue. Swedish anatomists defined the approach for surgical correction of stress incontinence. Your time starts now.
Ma'am, can you again show the word?
Your time will be continue. Your time is over. The word is radius, space of radius.
These are not audience question. Audience, please don't write answer in chat box. Arya Patni, please don't write the answers in chat box. These are the questions for team. These are not audience questions. Please.
The word is radius, that is the space of radius. Next question for the team F is how the mid urethra is identified while performing the surgery in the retropubic space vaginally. Your time starts now. It's a very practical question.
By pushing a bulb of Foley's catheter in upward and backward direction, ma'am.
Okay. We will give you 10 marks. Answer is by gently placing the traction on the Foley's catheter and palpating the lower edge of the balloon at the bladder neck. This is the correct answer. Now coming to the team E. Team E, GMC Nagpur, are you ready?
Yes, ma'am.
The word for the team
Hysterectomy.
E is
Hysterectomy.
you are absolutely right. You get 10 marks for this round. There is no need for the clue. The question for you is mention any two advantages of hysterectomy over hysterectomy for the prolapse repair. Any two advantages?
Preservation of uterus, reproductive function, menstrual function. And preservation
Preservation of uterus, reproductive function, and menstrual function is
Your
maintained.
time is
The
over.
vagina
You
is
will
not
not get any points for this round. The answer is there is the less blood loss, there is the less operative time, there is the more rapid recovery, and there is no risk of early menopause after this.
Ma'am, ma'am, we have answered the question of it.
You have not answered any any point out of this four. No, you have not answered any point.
Menstrual function. Menstrual functions.
No.
Okay.
Which menstruation will be the final. Now the question. Now the question for the team D. Team D, PDMC Amravati, are you ready?
Yes,
PDMC Amravati.
Yes, ma'am.
Okay. Identify the word. Your time starts now.
Ureter. Ureter.
You are absolutely right. You will get the 10 marks. There is no need of clue. The word is ureter. The question for this is clinical. What is the clinical significance of blood supply of ureter? Any one clinical significance? Your time is over. Is the ureter above the pelvic rim gets its blood supply from the medial aspect and below from the lateral aspect? The dissection and the mobilization of ureter during the surgery should be done above the pelvic rim from the lateral aspect and below the pelvic rim from the medial aspect. Now team C. Team C, MGIMS Sevagram. Are you ready? Both boys, are you ready?
Yes, yes, ma'am.
Identify the word. Your time starts now.
Excellent. Sacrocolpopexy.
Sacrocolpopexy. You are absolutely right. You will get 10 marks. No need for the clue. Word is sacrocolpopexy. The question is, at what level the mesh is sutured to the anterior sacral ligament in sacrocolpopexy? Your time starts now. I am afraid your time is over. The answer is at the level of S1 and S2. Why at the level of S1 and S2? Because it reproduces the normal vaginal axis, and it also, if we go down at the level of S3 and S4, there will be more chances of blood loss. Which artery we are able to, we are at risk to injure at this level? Middle sacral vessels. So we should, sometimes surgeon is tempted to do at the level of sacral promontory, but we should avoid that level also, because there is the risk of discitis as well as sacral osteomyelitis there. So we should do at the level of S1 and S2. Now coming to the team B. Team B, NKP Sims Nagpur. Are you ready? Team?
Yes.
Team B. I want to see.
Yes, ma'am. Yes, ma'am.
Team B.
Ma'am, we are visible. We are visible.
No, you are not visible.
Yes, ma'am. Yes, ma'am.
The word for the team B is, identify the word. Your time starts.
Artemis.
Don't worry, we have the clue.
Artemis.
Interposition vascular graft using labial fat pad, using for the complex VVF and RVF repair. Your time starts.
Vascular graft using Artemis.
I am afraid.
Christmas.
The word is Martius.
Dress. Okay, Martius.
Okay, the question for this. Mention 2 conditions where Martius flap is indicated during the fistula surgery.
Please repeat the question.
Mention 2 conditions
ma'am.
Martius flap is indicated during fistula surgery.
When there is a compromise of blood supply, like if there is a VVF due to any radiation exposure.
You are absolutely right. The condition where the vascularity is hampered, like fistula following the gynecological cancer, radiation fistula, or recurrent fistula, or the failed fistula. So team B will get the 10 points after this round. Now question goes to the team A, GMC Akola. Team GMC Akola, are you ready?
Yes, ma'am.
Yes. Identify the word.
Fistula.
Yes, absolutely right. You get the 10 marks. There is no need for clue. Name the technique used to repair external anal sphincter in 3C or the 4-degree oasis.
End-to-end and overlapping techniques.
Okay. Specify the answer. I am asking. You are right, actually. You will get the 10 marks because answer is overlapping repair only. End-to-end anastomosis is done for the 3A and 3B. I have specifically asked for the 3C.
Yes, ma'am.
So, as we know, for the repair of the external anal sphincter, for the primary repair, we have two techniques, end-to-end repair and the overlapping repair. In overlapping repair, sphincter is repaired in a waist over pants fashion. Okay, so we will give you the 10 marks for this. So you get 20 marks after this. Now the question for the audience. Audience, are you ready? Identify the word. Audience, you can answer in the chat box. Time. Okay. Time is over, I think. Clue is any involuntary leakage. Anybody wants to answer after the clue? Okay. The question, word is incontinence. Diaper stands for. Okay, thank you so much. Now I request Dr. Sharwari and Dr. Sheila ma'am to declare the score after the round.
So at the end of the third round, Team A, GMC Akola, had scored 35 marks. Team B, NKP Sims Nagpur, had scored 30 marks. MGIMS Team C had scored 15 marks. Team D, PDMC Amravati, had scored 20 marks. Team E, GMC Nagpur, had scored 40 marks. Team F, IGMC Nagpur, had scored 35 marks. And Team G, JNMC Savangi, is leading with 45 marks.
Congratulations, Team Savangi. You are doing, all the teams are doing great. All the best for next round. The next round is a matinee show. Myself, Dr. Kanchan, will take this round. The rules for this round, this is anti-clockwise round. We'll start with Team G. There will be 2 sub-questions for each team. 10 seconds will be given to answer each sub-question. Please unmute yourself. Audience, please unmute yourself and don't write answers for these questions in chat box. 10 seconds will be given to answer each sub-question. 10 marks for each sub-question. So total 20 marks for each question. Second question will be asked even if participant unable to answer the first question, and you will get marks for that answered question. This round is non-transferable, no negative marking, and quiz masters and judges' decision will be final. So we'll start with the Team G. Team G, are you ready?
Yes, ma'am. Yes, ma'am.
Savangi, Team G, Savangi. So you have to identify the procedure. This is a video round. You have to identify the procedure in the video. Your time starts now.
This is laser procedure by CO2 laser, ma'am.
Yeah, you are not audible. Clear, beta?
Is it CO2 laser?
Laser specific?
CO2 laser, ma'am.
What is the procedure?
Ma'am, procedure is done for vaginal tightening and rejuvenation, ma'am.
Okay, so the answer is vaginal rejuvenation by laser. You have answered it correctly. So 10 points will be given to the team. So the timer will start after the video is over. So after video, they will be given 10 seconds to answer the question. Next question for the team. What is G spot? Your time starts now.
Okay, max only anterior vaginal or maximum nerve ending. Ma'am, point on the anterior vaginal wall where maximum nerve endings are present.
Okay, yes. So the answer is correct. You will be given 10 marks for this. So G spot is also known as a Grafenberg spot. It is a distinct teratogenic zone on the anterovaginal wall. It is located 1 to 3 inches up the anterovaginal wall between its opening and the urethra. So team G, that is Savangi, is getting 20 marks for this round.
Okay. Thank you.
Next team is team F. Are you ready? Team F, IGMC Nagpur?
Yes, ma'am.
Yes. So you have to identify this procedure.
एक सेकेंड टिम्पल थाई से गया हमने ऊपर से टीवीटी ऊपर था ना ऑब्चुलेटर थाई में निकलती है टीवीटी है ना टीवीटी लग रहा है थाई में तो नहीं पता है ना वो तो ऊपर से टीवीटी है टेंशन फ्री vaginal tip.
Your time starts now.
Ma'am, it is tension-free vaginal tape.
Okay, right. It is tension-free transvaginal tape. 10 marks for this answer. Next question is, which are the vessels that can be injured during this procedure? Your time starts now.
Pudendal vessels and genital branch of genitofemoral.
Pudendal vessels.
Pudendal vessels.
No, you have not answered it. The answer is inferior epigastric vessel. Your time is up, better. Inferior epigastric vessel, obturator and accessory obturator, and external iliac vessels. So they will get only 10 marks in this round for the first question. The next team is team E. Are you there? GMC Nagpur?
Yes, ma'am.
The question is, identify the procedure.
ठीक है
Your time starts now.
The video.
Ma'am, video. Can you enlarge it?
It's not showing anything, ma'am.
So your time is fixation for transvaginal repair of apical compartment defect. Your next question is, mention any 3 transvaginal repair procedure for apical defect. Your time starts now.
High uterovaginal suspension, sacrospinous fixation, and iliococcygeal suspension. Sacrospinous fixation, iliococcygeal suspension, and uterosacral suspension.
High uterosacral.
So we'll give marks, 10 marks. The answer is, there are 2 extraperitoneal procedures and intraperitoneal procedures. In extraperitoneal procedure, there is a high paravaginal suspension of apical fornices, then sacrospinous suspension, uterosacral suspension, and macal cardoplasty. Now the question is for team D. Team D, are you ready? PDM
Yes.
Amravati.
Yes, ma'am.
So the question is, identify the procedure.
पूरा red दिख रहा है.
Identify time. Your time starts now. I think you don't know the answer. So the answer is Ori flap procedure used to repair injury to the proximal aspect of mid. The next question is, which is the most common type of ureteric injury occurring during gynecological procedure? Your time starts now. Most common type of ureteric injury.
The pelvic brain.
Your time is up. Sorry. The answer is most common type of ureteric injury is obstruction. Then the most common procedure which is associated with ureteric injury is abdominal hysterectomy, simple abdominal hysterectomy. Most common site of ureteric injury is at the ligation of cardinal ligament and uterine vessels. Most common activity leading to ureteric injury is attempt to obtain hemostasis. And most common type of diagnosis of ureteric injury is 50-50%, that is 50% intraoperatively and 50% postoperatively. So team D is getting, I think, no marks for this round. Next is team C. Team C, Sevagram? Yes. So your question is identify the pathology seen in this procedure or video. So your time starts now. Identify the this pathology. Sorry, your time is over. The answer is vesico-vaginal fistula. It is a cystoscopy and it is showing vesico-vaginal fistula. Your next question is, enumerate any two principles of vesico-vaginal fistula repair. Any two principles. Your time starts now. Sorry, your time is over. The principles of VVF repair are: repair can be done early, that is less than 72 hours, or late, that is less than or equal to 12 weeks. Timing is individualized as per the tissue quality and infection. Highest success rate is with first attempt and decreases success with subsequent attempt. Minimum trimming or no excision of fistula tract unless there is fibrosis or scarring. It should be tension-free closure. It should be watertight closure. Delayed absorbable sutures in an interrupted or continuous fashions use. 2 or 3 layer closure if possible. And post-operative 7 to 10 days of continuous bladder drainage using transurethral or the suprapubic catheter. So you will not get any point in this round. That is team Sevagram team, no points. The next team is team B, NKP Sims. Are you there? NKP Sims team, Shreya, Anuradha. NKP Sims team.
Yes. Yes, ma'am.
Yeah. So your question is identify the procedure. Your time starts now.
Ma'am, urethral bulking.
Injection of urethral
Urethral
bulking
bulking.
agents.
Your answer is correct. You will get 10 marks for this. This is the injection of urethral bulking agents for SUI. Your next question is, what is the treatment of immobile urethra in SUI? Your time starts now.
Urethral singling surgeries.
Pubovaginal surgery.
No, you have time. Answer it.
Immobile.
Tension-free vaginal taping, Marcelin tape, TVT.
Sorry, your time. The answer is retropubic sling and injection of urethral agent. So you will get 10 marks in this round. Next is Team A. Team A, are you there? GMC Akola. Team A.
Yes, ma'am.
Yes. So the question for you is identify the procedure.
But
Labiaplasty.
Yes. The answer is labioplasty. You will get 10 marks for this. The question for you is, second question, enumerate any two techniques used for labioplasty.
The one that was demonstrated is the V-wedge technique. Otherwise, you can use a vertical incision technique as well.
Any two techniques? First is your
V-wedge
V-mesh, and second
is vertical incision, direct vertical incision.
Okay, so answer is correct. You will get 10 points for this. The techniques for labioplasty is W-plasty excision using V-shape or Y-shape incision, Z-plasty excision, composite reduction, linear incision, and de-epithelize reduction. So you will get 20 points in this round. So this is all about this matinee show round. The score at the end of this round are, till we get the score, this is for the audience.
So
This video is for audience.
At the end of round 4, we have Team A with 55 points, Team B with 40 points, Team C with 15 points, Team D at 20 points, Team E at 50 points, Team F at 45 points, and Team G leading still with 65 points.
So your question, audience, is McIndoy's vaginoplasty. And what is Wilson procedure? You can type in your chat box. So next, thank you. The next round is Beyond Horizon. The round, I invite Dr. Rita Bang for this round. Welcome, Rita.
Thank you so much, ma'am. I welcome all the participants. And until now, we had spoken about what was known. Now let us see what is beyond horizon, that is what is not known. So let us all know what is not known. Myself, Dr. Rita Bang and Dr. Snehal Napade. The rules for the rounds are 1 question per team. Each question will have 2 sub-questions. It is a clockwise round. It will start from Team A. Team should start answering within 10 seconds for each question. The timer will start after I complete the question. Each sub-question will be given 10 seconds. It cannot be passed. 20 marks for total question, 10 marks for each sub-question. Partially answered question means only if completely answered sub-question will be given 10 marks. If the sub-question is not completely answered, no marks. Team A. Identify this. Timer starts. Okay, you can go on to the next sub question for this. The answer for this identification is it's KPO needle.
Mention where it is used. Timer starts.
Needle.
Posterior sacro.
Team A doesn't get any marks. It's 0. The answer to this is it's a KPO needle. It is used in sacrospinous fixation. Another important information is the drawback of unilateral sacrospinous fixation is dyspareunia because it changes the vaginal axis and deviates. So it leads to dyspareunia. Team B, are you ready? Yes.
Yes, ma'am.
Yes. What is STAR procedure? Timer starts. What is STAR procedure? Team B, are you with me?
Yes, ma'am. Yes, ma'am.
Timer up.
Ma'am, stapled transanal rectal resection. Stapled transanal rectal resection.
Yes, that's right. You started answering before the timer was up, so you are given 10 marks for this. The next question is, where is it used? Timer starts.
Ma'am, for if there is any external angle or there is obstructed defect, there is obstructed defecation because of any defect in the sphincter.
Obstructed defecation syndrome is the right answer and you were right. So you're given 10 marks for this also. So team B scores 20 points. So it's a posterior compartment prolapse and obstructed defecation syndrome where it is used. And for your knowledge, vaginal approach to rectocele repair is superior to the transanal method. Team C, are you ready? Your question is identify. Timer. Timer started. So time is up. The answer is it's incontinence dish. Yes. The next sub question is mention its use in urogynecology. Timer starts.
Stressing controllers. Stressing controllers. I don't know.
You were discussing amongst yourself. You have not answered anything to me. So I give you 0 for this. So team C scores 0 in this round. The answer is it's incontinence dish used in patients with SUI with first and second degree prolapse or a mild cystocele. You were very near, but you didn't answer it to me. You discussed amongst yourselves. Team D, are you ready? Team D? I can't hear team D. Team D is again logged out, I guess. Shall I? I'm giving 2 minutes time for team D, 1 minute time for team D. If I don't see. आगे चलो. Screen दिखा दो अभी. Yes, team E, are you ready? Team E, I need to see you and hear you before I start the question. Yes. So team E. Your question is identify. Timer starts. Unmute yourself, team E.
Unmute. Hello, can you hear us, ma'am?
Yes. Your timer starts.
Mesh.
Started.
It's mesh.
Okay.
Polypropylene.
Next sub question is mention its 2 uses in modern urogynecology. Sorry, it's a typing error. It's modern urogynecology.
Ma'am, sacrocolpopexy we can do with a mesh. Sacrohysterectomy we can do, and other
Vaginoplasty.
Yes, ma'am.
Okay, I need two, and you have answered it rightly. So you are given 20 points for this round. The answer is sacrocolpopexy, sacrohysterectomy, as you said, and transobturator tape. It's proline mesh. So team E scores 20 points. Next, team F. Team F. Yes. Your question is identify the procedure. Timer starts.
Hymenoplasty.
Sorry?
Hymenoplasty.
Okay, you're right. So you're given 10 marks for this sub-question. The next sub-question is one criteria to decide upon whether you will go for this procedure or you'll go for a perineoplasty. Timer starts.
The perineal distance.
No. So you're given only 10 points. Team F scores 10 points in this round. The answer is it's hymenoplasty. You were right. And 1 point which will differentiate between which procedure you will go for, whether hymenoplasty or perineoplasty, is vaginal laxity or distensibility. You'll do a PV examination, and if you find the vagina is too roomy, then perineoplasty is indicated. And if only introitus is narrow or introitus is lax, then hymenoplasty is enough in this patient. Okay. Next team, team G. Are you ready?
Yes, ma'am.
Team G. I need to see you. Switch on your video.
It's switched on. It's on.
G. Yes. So your question is identify. Timer starts. Sorry, you don't get marks for this sub-question. The identification I'll answer you. It's urethral plug. Okay, the next sub-question. Mention its use. Timer started.
Ma'am, it is used in treatment of stress urinary incontinence.
Okay, you're given the marks for this. It's urethral plug used in stress urinary incontinence. And the additional uses, it blocks the urethra while vaginal device adds on support through the vagina. So this team scores 10 marks in the sub-question in this round. Let's go back to team D. Has team D logged in again? So I think we are done with the teams then. So team D has missed this question. So we are not going to give any marks. Team D scores 0 in this round. So at the end of the round, we'll go for the scores.
The scores are Team A at 55 points, Team B with 60 points, Team C is yet at 15 points. Team D has not scored in this round. Team E is at 70 points, Team F at 55 points, and Team G is still leading with 75 points.
Okay. Now I request Somalwar madam to go for the next round. Thank you. Screen height. Just screen height. Yogesh.
So come on, guys. Still a lot of points to score. A round which will take you up. Okay, show the screen.
There were some questions of previous round. So good morning, everyone. This is the last but not the least round. So it is the round name is Fast and Furious. So now coming to the rules of this round, it is a clockwise round. There will be 7 questions in 50 seconds. Each question carries 10 marks. There will be no points for the past question, or if you answer incorrectly, or if you do not answer. Next question in order comes only on answering, giving answer or saying pass. And if time permits, you can attempt past questions. There is no negative marking in this round. So as it is clockwise, we will start from team A. Team A, are you ready?
Yes, ma'am.
So still there is a scope in this round to score. So all team be attentive. So the questions for team A are, your time starts now. Length of pelvic ureter is
25 centimeters.
Beta receptors are mainly located on bladder base and urethra. True or false?
False.
Arcus tendinous is also known as
White line.
White line of pelvis.
ISC stands for
International Society of Continence.
normally residual urine volume should be
Less than 100 ml.
Moskowitz repair is done for
Pass.
name two anticholinergic drugs used in overactive bladder.
Oxybutynin, imipramine. Anticholinergic.
So your time is over. They have answered 3 correctly. So I will tell you the correct answers. So they have answered 3 correctly, and one they have given partial answer. We will not give them marks. So I will tell you the correct answers. So scorers, they will get 30 points in this round. So the length of pelvic ureter is 13 centimeters. You said 25, that was wrong. Beta receptors are mainly located on bladder base and urethra. You said false, that is the correct answer. And these the area contains alpha receptors. Arcus tendinous, you answer correctly. It is known as white line. ISC stands for International Society for Continence. You said correctly. Normally residual urine volume should be, you said 100. It should be less than 50 ml. That is the correct answer. Moskowitz repair, you did not say. It is done for Enterocin. And 2 anticholinergic drugs used in overactive bladder, you said once oxybutynin, but then you were not sure and you said imipramine. So that is wrong. And the correct answers are, along with oxybutynin, it is tolterodone, trospium, and solifenacin. So they will get 30 points. Now the next round will go to the team B. Okay, team B, are you ready? Team B.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Your time starts now. Bladder sulcus light lies at the junction of.
It is at the junction of the mucosa of the bladder and the anterior vaginal wall, the junction.
Normally, intraurethral pressure at rest and with stress is much lower than intravesical pressure. True or false?
False.
Space of Ritzius is also known as
avascular area.
Another name.
Pass.
PMC stands for
Pass.
During cystometry, first sensation of urination occurs when urine amount is
150 cc. 150 ml.
In Manchester repair, cardinal ligaments are attached to.
Pass.
FDA approved beta agonist used for urge incontinence is.
In Manchester repair, the cardinal ligaments are attached into the cervix.
Anuradha, your time is up. Time is up. Okay, so you cannot answer now.
Yes, ma'am.
And the so they have answered 2 correctly, so they will get 20 points. And the correct answers for this round are: bladder sulcus lies at the junction of anterovaginal wall with supravaginal portion of cervix. Normally, intraurethral pressure at rest and with stress is much lower than the intravesical pressure. Space of Ritzius is also known as prevesical space. PMC stands for Pontine Micturition Center. I did not answer this. During cystometry, first sensation of urination occurs when urine amount is 150 to 200 ml. In Manchester repair, cardinal ligaments are attached to anterior to cervix, and you were saying this after your time was over. And the FDA approved beta agonist used for urge incontinence and overactive bladder is mirabegron. Okay.
Ma'am, I had answered mirabegron. It comes out to be 3 answers.
What?
Yes, ma'am. I had answered mirabegron within time.
Yes, ma'am.
No,
we have
I said
said
mirabegron. It was within time.
Actually, you answered this after the bell rang. Your time was over. Okay. Because you did not say anything pass or something like that, you could attempt only 6 questions in your round. And the time was up.
In this question, after half, I think they said pass.
Yeah.
They did not.
In question 3, the time was wasted.
You said pass. You just started and then you said pass. It was just
So they will get 20 points. Okay. Now the next questions are for team C. Team C, are you ready?
Yes, ma'am.
Sevagram, na team. So your time starts now. Strongest part of urethra is
Pass.
sympathetic system is not responsible for voiding. True or false?
False. False. False.
Painful bladder syndrome is also known as
Pass.
PVR stands for.
Pass.
In cystometry, strong desire to void occurs when amount of urine is
more than 1500.
250.
Kelly's operation is done for.
Kelly's operation. Pass.
One indication of periurethral injection of bulking agents in entrance sphincter deficiency is. So your time is up. They have only answered 1 correctly, so they will get 10 points. And the correct answers for you are strongest part of urethra is mid urethra. You did not answer this. Sympathetic system is not responsible for voiding. This is true because parasympathetic system is responsible for voiding. Okay. Painful bladder syndrome is also known as interstitial cystitis. PVR stands for post-void residual. In cystometry, strong desire to void occurs when amount of urine is equal to or more than 250 ml. You answer it correctly. Kelly's operation is done for stress incontinence. And one indication of periurethral injection of bulking agents in intrinsic sphincter deficiency, either if the patient is unfit for surgery or if there is a failed urethral sling or scarred fixed lead pipe urethra. These are the various indications. So you answered 1 correctly, so they will get 10 points. Okay. So we'll have to hide that. Yogesh? Now next team E.
Hello, ma'am. Can you hear us?
Yeah.
Okay.
Are you ready?
Yes,
Team
ma'am.
E, GMC Nagpur.
Yes, ma'am.
So your time starts now. Length of female urethra is
4 centimeter.
4 centimeter, ma'am.
Does not lead to voiding. True or false?
True.
Iliopectineal
True, ma'am.
ligament.
True, ma'am. Next. Cooper ligament. Cooper.
PCU stands for
pass.
Intervesical pressure
Video
at
system.
rest is
20 centimeter. Ma'am, pass.
high uterosacral suspension surgery is done for
Prevention of wall prolapse.
Ma'am, next question.
the recommended dose of nitrofurantoin in recurrent cystitis is
100 mg QID.
okay.
And
VCU is video cystourethrogram.
Video cystourethropathy.
Your time is over. You answered 4 correctly.
5.
Okay, you answered 5 correctly, so they will get 50 marks. So the correct answers for you are length of female urethra is 3 to 4 centimeter. Detrusor relaxation does not lead to voiding. True. Pectineal ligament is also known as Cooper's ligament. You told correctly. VCU stands for voiding ureterography. So you passed this. You did not say. Intravesical pressure at rest is 10 centimeter. You said.
We said video cysto-ureterography. We said, ma'am, video cysto-ureterography. We told, ma'am.
Actually, now
Body
you
system
did not answer, and then you were both were talking, so I could not hear what you said. Okay, at that time. So you identify. Next team should identify one spokesperson so that the voice is not echoed. Okay. High uterine suspension surgery is done for prevention and treatment of all prolapse, and recommended dose of nitrofurantoin is 50 to 100 milligram in recurrent cystitis. You said correctly. So they have answered.
Normal way.
They will get 50 marks. Okay. Yeah. Yeah. So for team F and G, you identify one spokesperson so that the voice is not echoed. And it has been told multiple times since beginning. Okay, team F. Are you ready, team F?
Yes, ma'am.
So your time starts now. Names of the muscles forming lateral pelvic wall are
Obturator internus, obturator externus, and pelvic fascia.
distal venous plexus beneath the bladder neck undergoes marked changes with age. True or false?
Yes, ma'am.
Yes, true, ma'am.
True.
Urethral intrinsic sphincter deficiency is known as
Pass, ma'am, pass.
TDAVP stands for
Pass.
normally intraurethral pressure at rest is
0 to 15 cent. Bladder.
Should I go to next question?
20 to 30.
In modified Purandara sling surgery, the ends of tape are attached to
Rectus sheath.
So they will not get 7 questions because the time was up. So only one answer is correct out of 7 for you. 7 you could not attend because the time was over. Now I will tell you the correct answers. Names of the muscles forming lateral pelvic wall are, you said only obturator internus, you will have to say all the 3. That is, they are piriformis, obturator internus, and iliopsoas. Distal venous plexus beneath the bladder neck undergoes marked changes with age. That is the false. These are the proximal venous plexus which undergo changes with the age. Urethral intrinsic sphincter deficiency is also known as stovepipe urethra or lead pipe urethra. TDAVP stands for 1D amino 8 amino arginine vasopressin. Normally intraurethral pressure at rest is 20 centimeter of water. You said it correctly. Modified Purandara surgery, the ends of tape are attached to rectus muscle, rectus sheath, and the pessary used for unfit. Okay, yeah. Okay, so there 2 are correct. And 7th question you could not attempt, and it was pessary used for unfit women should be changed every or after 3 months. So they will get 20 marks. Now team G. Are you ready, team G?
Yes, ma'am.
Team G is JNMC Savangi. Okay. So your time starts now. Normally external os lies at the level of
Ischial spines, ma'am.
muscarinic receptors and cholinergic receptors are not same. True or false?
False.
Sphincter urethrae is also known as
External urethral meatus.
OS stands for
obstetric anal sphincter injuries.
Intraurethral pressure with stress is
Intraurethral pressure with stress is more than 20 centimeters of water.
in Marshall-Marchetti-Krantz operation. Paraurethral tissue at bladder neck is sutured to
Paraurethral tissue at bladder is sutured to pubic symphysis.
Okay. Time was up, so we could not grant you that. And 7th question I could not give you because the time was up. Yeah.
ओह, ये तो मुझे आता था.
So as you started before the bell was rang, you will get 5 you are correct for them, and 7th I could not say because the time was up. Okay. So the correct answers for these are, you said correctly, normally external os lies at the level of ischial spines. Muscarinic receptors and cholinergic receptors are not same. It is false. It is, they are same. Okay. Sphincter urethra is also known as rhabdosphincter. OSS you said correctly. Intraurethral pressure with stress is more than 20 centimeter and up to 50 centimeter of water. In Marshall Majetic Krantz operation, the paraurethral tissue at the bladder neck, you said posterior surface, so it is okay. Periosteum of the posterior surface of pubic symphysis. And last question you could not attempt, but the question was 2 side effects of anticholinergic drugs. They are either constipation, dryness of mouth, or dry eye. So that's the end of this. And whether team D is there, team D, I think that is logged out. So I think now we will not, because they have not logged in. So now I will hand over the mic to Dr. Kanchan.
So we have score at the end of this round.
So at the end of all these rounds, we have team A and team B both tied up at 85 points. Team C is at 25 points. Team D with 20 points. Team F is 75 points. And the first runner-up is team E with 120 points. And the winners are team G with 125 points. A very close score.
So we'll announce score. I request Dr. Bhalerao ma'am to announce the winner of this quiz.
Ladies and gentlemen and friends, it gives me great pleasure that we had a wonderful quiz on urogynecology, and it has been carried out so well by all the faculties. All the questions were very, very good. And the winner for today's urogynecology quiz is JNMC Sawangi, comprising of, please tell your names.
Ma'am, Dr. Asavari Dev and Dr. Arzu Chadda.
Asavari and
Arzu.
Arzu. So heartiest congratulations, Asavari and Arzu, for
Thank you,
winning
ma'am.
urogynecology quiz, and hope this helps you in your long run.
Thank you, ma'am, for your wishes.
Thank you. And the first runner-up is GMC Nagpur, and they have got 120 points. And GMC Nagpur comprising of
Arya and Disha.
Arya and Disha. So heartiest congratulations, Arya and Disha. And may you.
Thank you, ma'am.
Time. You all are JR3s?
Yes, ma'am, JR3s.
Okay. So next time you
Yes,
won't
ma'am, JR3s.
participate. So wishing you all the best, and wishing you a very bright future. So I hand over the mic
Thank
for
you, ma'am.
concluding remarks to Kanchan.
Congratulations, winning team. All the teams did well. All the teams are rocking. Congratulations, team Sawangi, and first runner-up team GMC Nagpur. We will be. I thank Dr. Buhariwala ma'am for judging the quiz. You are always there for ma'am. Ma'am, Buhariwala ma'am, can you give concluding remark for the quiz? Ma'am, are you there? Yeah. Ma'am, please.
Can you hear me?
Yes.
Hello?
Yes, ma'am. Very well.
Friends, it's been a very, very interesting and educative session, I would say. Very enlightening session. And I must congratulate the department for constructing such a wonderful quiz with such a wide spectrum of questions. And the presentation was perfect, picture perfect. I must congratulate the participants, the winners, and also the people who have not won. They have been very fortunate to have been selected for this quiz and for the exposure they have had today. I'm sure all of you have benefited from this quiz and you have enjoyed it all as much as I have. My thanks to each and everyone.
Thank you so much, ma'am. Thank you so much for your guidance and encouraging words. So I hand over the mic to Dr. Sayukta for further proceeding. Thank you.
Thank you, Kanchan ma'am. After this mind-blowing and brain-tickling session of quiz, we will proceed with our inaugural function. Now, I would like to invite Dr. Sheila Jain ma'am and Dr. Rohini Boyer ma'am to conduct the inaugural function.
I would request all the audience to please stay back. We will get back in a minute. We'll get back in a minute. Please keep logged in.
बंद करून टाकते मी याच्यात आहे माझं हार्ट टेस्ट करून रिजेक्ट करून टाका पेन ड्राईव्ह रिजेक्ट करून टाका मी यशवंतला
A very good morning to all. On behalf of the organizers, the Nagpur Obstetrics Gynec Society and the OBGY Department, NKP Sadhwe Institute and Research Center, myself, Dr. Sheila Jain,
myself, Dr. Rohini Boyer,
we welcome you all for the PGCON 2022, a conference mainly for the postgraduates.
The PGCON 2022 is a conference made for the postgraduates. This conference is conducted to prepare the students to face their postgraduate exams with confidence. Here, they have valuable opportunity to learn and interact with eminent faculties and examiners from all over the country. This is a very popular academic activity, and we have postgraduate participants from various medical colleges of the region.
To solemnize this occasion, I request all the dignitaries, our today's chief guest, Dr. Mitra Sir, Dean NKP SIMS, Dr. Alka Mukherjee, President NOGS, Dr. Anuja Bhalerao, Professor and Head OBGY Department, to light the Samai. I also request Dr. Prachi Dikshit, Organizing Secretary, to join them.
Recording in progress.
I request Dr. Somalwar and Dr. Nikita also to join them.
पद्मासना या ब्रह्माच्युत शंकर प्रभृतिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा
I request all the dignitaries to take their chair on the dais. Now I request
Professor and MD, Department of OBGY, to welcome our chief guest, Dr. Mitra sir.
Good morning, ladies and gentlemen.
Floral welcome.
Just 2 minutes, ma'am. We would like to welcome our guests. I request Dr. Somalwar to present. I request Dr. Nikita to welcome Dr. Prachi Dikshit.
I request Dr. Kanchan ma'am to welcome our professor and HOD, Dr. Anuja Bhalerao ma'am. I request Dr. Anuja Bhalerao ma'am, professor and HOD, Department of OBGYN, NKP SIMS, to welcome the board.
Good morning, ladies and gentlemen. Honorable Mitra sir, Alka Mukherjee, President NOGS, and all my dear colleagues. It gives me immense pleasure to welcome you to this academic bonanza, PGCON 2022. I'm really overwhelmed by the response that we have got, and have the words will fall short to express my feelings at this juncture. Let me tell you, friends, that programs like this do not happen overnight. The wheels started rolling so many days back, and the whole department stood up to give this conference its form and character that we have it today. I'm extremely thankful to the management of NKP Salve Institute of Medical Sciences and Lata Mangeshkar Hospital, and our Dean, Dr. Mitra sir, for giving us this opportunity to conduct this program at this premises. Thankful to Alka for always being with us in carrying out all the academic activities at NKP SIMS along with NOGS. All my staff members and all my dear students have worked really hard for making this program a great success. Thank you so much. All the organizing secretary, Dr. Prachi, scientific program in charge, Dr. Savita, Dr. Nikita, Dr. Kanchan, who was in charge of the quiz, for making this quiz, today's quiz, a wonderful one. And there are so many names which are coming to my mind, but like Rohini, Sheila, Rita, and all of you, Sanyukta, Amrita, thank you all of you. Thank you so much.
Thank you, ma'am. Thank you for those encouraging words, ma'am. Now I request Dr. Alka Mukherjee, ma'am, President NOGS, to address the audience.
We acknowledge the presence of Dr. Kubre, Secretary NOGS. So please take chair on the dais. I request Dr. Kanchan to welcome him.
Respected dignitaries on the dais, Dean Sir, Dr. Mitra, HOD Dr. Anuja Bhalerao, Chairperson Dr. Prachi, Kanchan, Savita, Sheila, everyone. I can't take everyone's name. And respected teachers, students, and my friends. Special hats off to Dr. Buhariwala, who has joined. I'm indeed very happy to welcome you all for this, on behalf of Nagpur OBGYN Society, for this NOGS PGCON. The theme of our tenure this year is Safe Mom, Safe Dog, which means while safeguarding a maternal interest, how a doctor should safeguard herself and prevent all the litigation. We all know obstetrics and gynecology, they are the two parts of the same coin. Gynec is science, obstetrics is an art. One can carry on work as a gynecologist where 1 + 1 is equal to 2. Whereas it is not the same scene with obstetrics. As there are many, many real-time variables which keep on coming up. Decision making in gynec can wait for a week. We can refer the books, we can ask. But in obstetrics, is it possible to withhold a delivery? Of course, no. You have to take the decision in a split second, and at the same time, you should have an expertise to manage the complications. It's totally a 24/7 job. And today, with norms, with everybody is expecting good news on the front of pregnancy, and they want a mother healthy as well as it's not possible. We won't have any unacceptable or you can say unacceptable outcome of the pregnancy. It is unacceptable. Our profession needs compassion, then understanding and empathy. It is well said by Ivan Isher. You can't do anything about the length of your life, but definitely you can do with your breadth and the width. So an obstetrician can do by adding honesty, integrity, and sincerity and hard work to their life. The most difficult journey that a human being ever takes in their life is the last 10 centimeter journey from the birth canal. And we all should be proud of ourselves that we obstetrician, we facilitate that journey for our patients. The years of residentships are physically and mentally very much tiring. But remember, my dear friends, no pressure, no diamonds, no struggle, no strength. This NOGS PGCON is an opportunity for all of you, to all the postgraduate from different colleges, from this is a virtual one. So we can, all over India, it can be shown off. And to understand the subject in detail and get influenced by the thought process of different teachers, it's very important to organize such conferences. We are very much thankful to NKP SIMS, the entire college, Dean Sir, HOD, Prachi, everyone who made this conference a real success. At the end, I would like to say, you should all shine very bright, just like a diamond. Wish you all the best. Once again, I welcome you all. Thank you so much.
Thank you, Alka Mukherjee ma'am, for those kind words. Thank you, ma'am. I request our Dean, Dr. Kajal Mitra sir, to address the gathering.
Dr. Alka Mukherjee, President, NOGS, Dr. Ashish Kubde, Secretary, NOGS, Dr. Anuja, Dr. Prachi, and my dear friends, whom I can't see right now, but I hope they are listening, sitting in their homes or offices. This is the problem with online events. You can't see whom you are talking to, and you hope that they are listening. Having taught and trained PGs for more than 30 years, I've come to few conclusions. I will share them with you. First is, the PG curriculum across the country is not well structured. When a PG lands up in a department as JR1, nobody knows what to teach him, when to teach him what. He just learns by default, seeing his seniors doing things, or faculty, teachers. Few PG activities are held, and it's mostly a self-directed learning. That is what we say, self-directed learning. One who can do that can do well. One who cannot do that does not do well. This is not how it should be. It should be well-structured plan. as to when a student comes to the department, what he should learn in first 6 months. That should be well defined. Next 6 months, and the 3 years. So the teachers as well as the students should be very clear in their minds as to what they should learn in these 3 years. And at the end of 3 years, which fundamental basic competencies they should acquire. Nowhere it's like that. Keeping this in mind, when I took over as dean, during consecutive college council meetings, I told all HODs to formulate a structured program for PGs, and all the departments did that. So that structure was there in place in our institute before MCI thought of it. Later on, MCI also formulated such a structure, and it's there on the website. But it's also on the website only. I don't think anybody is following this kind of structured program, mainly because I'm coming to the second observation of mine, mainly because there is no formative assessment. At the end of 1 year, if university proposes one exam and we hold that exam after 1 year during whatever he has learned during that 1 year, and those marks are added to his final tally, then it will have some meaning. And then we will be teaching them in a structured manner. So that formative assessment is not there. It's all summative assessment at the end of 3 years. And that at the end of 3 years also tests only few parts of what a PG student should learn. And that is only cognition. Only the knowledge, whatever he has read in books, whatever he has heard his seniors talking, he is supposed to reproduce that in that 1 day. We cannot test his what you call as psychomotor skills. Obviously, we can't ask a student to operate during exam, obviously. So we cannot assess that. How that can be assessed? We can assess that during 3 years. So therefore, again coming back, those assessment during those 3 years also is very important, so that we know who is good in, who has developed, who has acquired the competency, who can operate the basic things, whatever is the department. So in gynecology, it may be, say, hysterectomy or LSCS or whatever. So different departments will have different competencies. So that is one very important aspect which is left. And also his attitude, his communication skills are never tested in exams, cannot be, obviously. And these are very important things in today's world. So these are what are the problems with our current medical education, postgraduate medical education, which I think the policymakers should correct it. And also we should be the persons who should suggest them. Having said that, I can share a few things with you. There are, I was told, and I have seen the brochure, there are very good faculty who are training the students. They did it last 2 days and today, national level faculty. But I must tell you one thing. Day before yesterday, I was in Ministry of Health and Family Welfare, New Delhi. and I was talking to the director. He's a very knowledgeable person. And as soon as I went to his chamber and I introduced myself, he said, "Oh, you're from NKP." I was pleasantly surprised how he knew NKP. He said, "But your faculty is very good." I was again surprised. He said, he was in charge of Nagpur AIMS actually. So he said, many of your faculty have joined AIMS and they are such good faculty. And they keep on telling me how good is NKP Salve. So that's how and he also regretted one fact that he could not take admission for his son in this institute because of the existing rules and norms, which prohibit students from outside the states to take admission. Only students domiciled in Maharashtra can take admission in our institute. So he was regretting that fact that this is how it is. So I was very proud and I was very happy. And I thought that I should share this thing with you, although this may not be relevant to the event. And I wish the organizers, the delegates, all the best for the event. Thank you very much for inviting me here today. Thank you.
Thank you, sir. Thank you for your wise opinion and sharing your experience with us. Sir, we will definitely try to incorporate your ideas and advice in assessing the students. My heartfelt thanks to our Dean, who has taken time from his busy schedule in this Sunday morning. Thank you once again, sir.
I request Dr. Bhalerao and Dr. Alka Mukherjee to present a memento to our chief guest, Dr. Mitra sir. Competition is not only about winning, it's about preparation, participation, nurturing, and sharing ideas. During this PGCON, we had paper and poster presentations on day 1 and a very interesting quiz on urogynecology today itself. So now it's time to appreciate the efforts of all the participants and declare the winners. In paper presentation, the first prize goes to Dr. Charmi Vashi. She's from NKP Salve Institute, and she presented a paper on FCM versus iron sucrose in treating postpartum anemia, a better parenteral iron therapy. So I request our Dean, Dr. Mitra sir, to present her the trophy.
Thank you, sir. And congratulations, Dr. Chami. Keep shining. The second prize in paper presentation is shared by 2 students. The students are Dr. Shraddha Thakre from IGGMC, Nagpur, and she has presented the paper on genital TB in infertility. And the second person is Dr. Priyanka Thakur from NKP SIMS. She has presented the paper on cervical fibroid, a challenge. I would like to request Dr. Ashish Kubre sir to present the trophy. Congratulations to Priyanka.
The first prize in poster presentation again is shared by 2 people. We have Dr. Mansi Jain from GMC. She presented a poster on a rare case of abdominal pregnancy, and the Next winner is Dr. Shraddha Rao, again from our own institute, from NKP SIMS. She presented a poster on acute fatty liver of pregnancy. I request Dr. Alka Mukherjee to present her the trophy. Congratulations, Shraddha. And this should be a motivation for all other postgraduate students to work hard. The second prize again is shared by?
It is again shared by two students, Dr. Neha Tandulkar. She has presented the paper on pelvic actinomycosis mimicking uterine fibroid. Congratulations, Dr. Neha. And she is from Loni, Pravara Medical College, Loni. The second prize is again shared by Dr. Ashwini Najan from our NKP SIMS, and she has presented the poster on a case of MRSA, wound infection, potential outbreak, and its prevention. I request Dr. Alka Mukherjee ma'am to present her the trophy. Congratulations to Dr. Ashwini.
And now it's time to declare the winners of the quiz. The runners-up in the quiz were GMC Nagpur. They scored 120 points. And the winners were JNMC Savangi. Closely, yes, we will show them the trophies. And they were leading just by 5 points. They scored 125 points. These trophies will be sent to them shortly. And I now request Dr. Bhalerao ma'am to present a memento to Dr. Alka Mukherjee also. I request Dr. Prachi to join.
I request Dr. Anuja Bhalerao ma'am to present the memento to Dr. Ashish Kubre sir. Thank you, sir. I request our organizing secretary, PGCON, Dr. Prachi ma'am, to.
I request all the dignitaries to please be seated on the dais. And I request Dr. Ashish Kubre sir to present the vote of thanks on behalf of NOGS.
Good morning, friends. Once you become PG, you become senior resident, lecturer, teacher, academician, or consultant, or whatever step you ride, but your basis is always your postgraduate learning and the teaching what you get. A way back, almost 1.5 years ago, our dynamic president, Dr. Alka Mukherjee, when she conceptualized the program for this tenure of 21-22, she always stressed on 2 factors. First is the PG teaching or learning, and second is how to get connected with the rural people. Therefore, those were very ambitious program of the PG Connect and the Rural Connect. And in this series of this PG Connect, NOGS along with the prestigious NKP Sahave Institute, we have conducted this PG conference. Let me first thank to the Dean, Professor Kajal Mitra, for allowing this course of PG conference, PGCON 3 days online course, and very much thankful from the bottom of heart from all the NOGS to Dean sir for allowing this. The most important, the whole responsibility is been taken by the able leadership of this OBGY department of NKP Sahave under the leadership of Dr. Anuja Bhalerao, Professor Anuja Bhalerao, Dr. Varsha Kose, Prachi, Sulba Joshi ma'am, my own teacher, Dr. Anjali Kauthakar, Kanchan Dvidmute, and whole of her department. And they have conducted this virtual PG course. They gathered, they requested the faculties, well-known faculties from all over India, from Karnataka, from Loni, and from all the corners of India, and the excellent course of this PG conference. It happened. I'm thankful to all the professors and teachers all over the India who has taken this teaching program and given their valuable inputs. Sharvari, Sanyukta, Rita, Amrita, they have taken the responsibility of this logistic for this program very ably. NOGS is thankful to all the persons before front and who work behind the curtain. Thank you very much from the bottom of heart. Thanks.
Thank you, sir. Thank you for those kind words. And I really thank you for being there for our help always when it is needed. Now I request Dr. Prachi, Organizing Secretary and Associate Professor OBGY NKP SIMS, to propose vote of thanks.
Thank you so much. It gives me immense pleasure and pride to present a vote of thanks for the success of this prestigious academic feast, NOGS PGCON, which was served for the postgraduate students across the Vidarbha. This is the 4th OBGY postgraduate review course organized by Department of OBGY NKP SIMS. And this is 3rd one consecutively over 3 years. And we hope we are taking it forward every year for all of you. My heartfelt gratitude to Honorable Chairs of VSPM, Sri Ranjit Babu Deshmukh and Dr. Ashish Deshmukh, to support academic upgrowth of Institute through such programs. Thank you, Professor Dr. Kajal Mitra, sir, our chief guest for the day, and Dean of NKP Salve Institute of Medical Sciences, to keep the trust in us and being with us as chief guest to grace today's function and supporting us unconditionally wherever needed. Thank you so much, sir. I'm thankful to guest of honors, Vice Dean Sir, Dr. Vilas Thombre, and Dr. Nitin Devsale, sir. They could not join us. Actually, all the 3 of our heads were outside the station that they returned late night. So I can understand that it was even difficult for Dean Sir to come for the program, but he took time and took efforts. Thank you so much. Thank you so much to the leader of NOGS, President Madam, inspiring and ever encouraging, Dr. Alka Mukherjee ma'am, for your unconditional support for this event. You have taken NOGS many strides forward, madam. And for the success, and there are many success stories in your kitty. Connecting PG education across Vidarbha was one which touched my heart. Through PG Passion Connect, yes, it is a program which we have launched this year. I mean, NOGS has launched this year. And this is a weekly PG activity across Vidarbha, and one important milestone that has touched NOGS and will be continued. Dr. Ashish Kobre, sir, Honorary Secretary, NOGS, is a walking textbook in himself. So I'm very happy to have you here, sir. Your support for PG education is immense. Thank you, sir. Organizing Chairperson and Head of Department, Dr. Anuja Bhalerao, ma'am. Few people in my life, even a thought of those people fills me with energy to put in my best in everything, madam. Thank you so much, ma'am, for your vision and guidance for this program. Conveners of the program, Dr. Sulbha Joshi ma'am, Dr. Shama Kedar madam, Dr. Rujuta Fuke ma'am, and in the same statement, another name, Dr. Anjali Kothalkar madam, covering the academic overall, provided guidance for Passion PG Connect and this conference. Madam, you maintain the academics of this department to another level. Thank you so much for that. I hope you're listening us and you're getting my words, ma'am. Thank you so much. All words are less for the gratitude that I have for highest learned 43 medical educators across India who accepted the invitation wholeheartedly and enriched our students for past 2 days and will be doing so for 2 evenings also. Cannot miss to take names, Dr. Buhariwala ma'am, our all-time mentor, Dr. Jitendra Deshmukh, HOD GMC Nagpur, Dr. Anisha Gala madam from Fernandez Hospital, Hyderabad, Dr. Reena Wani madam, Professor Cooper Hospital, Mumbai, Dr. Deepti Srivastava madam, Professor JNMC, Dr. Srinivas Gadappa, HOD GMC Aurangabad, Dr. Seema Parvekar, MS Daga Hospital, Dr. Bangal sir, HOD Pravra Institute of Medical Sciences, Dr. Sailesh Kore sir, Professor TNMC Mumbai, Dr. Sandhya Pazai ma'am, JNMC Savangi, Dr. Aparna Vahane ma'am, HOD GMC Akola, Dr. Poonam Verma ma'am, HOD MGIMS Sevagram, Dr. Manju Puri ma'am, Professor Director and ex-HOD Lady Harding Medical College, Delhi, Dr. Alka Patankar, Professor IGMC, Dr. Kshama Kedar madam, Professor IGMC, Dr. Mugdha Jungari, HOD JNMC Shalini Taimeki Institute of Medical Sciences, Dr. Aruna Kekare madam, Professor in CMC Vellore, Dr. Neema Acharya, HOD JNMC Savangi, Dr. Manjushri Vaikar ma'am, Professor GMC Nagpur, Dr. Hemant Deshpande ma'am, HOD DY Patil Pune, Dr. Pushpa Jungre madam, HOD PDMC Amravati, Dr. Aparna Sharma madam, Additional Professor AIMS Delhi, Dr. Anita Yadav and Dr. Avantika Gupta from AIMS Nagpur, Dr. Surekha Taide, and Dr. Shubhada Jaju, Professors, JNMC, Savangi. So I wanted to take all these names because they have taken efforts in giving their knowledge and taking time for our students. So this was important for me, and heartfelt gratitude to all of you teachers. All should be thankful to Savita Sumalbar madam and Nikita Vijay madam for beading all these pearls in one string and presenting us this beautiful scientific program. Thank you so much, ma'am. The academic extravaganza for paper and poster was presented by Dr. Deeta Bang and Dr. Amrita Singh. And our esteemed judges, Dr. Kothalkar madam, Dr. Shuchi Jain madam, Dr. Pushpa Jungre madam, Somalwar madam, Shama Kedar madam, all of them contributed in bringing about the success of paper poster presentation. Thank you so much, Rita and Amrita. The skill videos were compiled by the efforts of Dr. Sheila Jain and Dr. Sanyukta. Thank you so much for the same. And I want to tell you that I've been taking anonymous feedbacks from students, and all of the programs have been appreciated very much. Even the last of skill videos has been logged in by almost 50 audience per day, and they all have received 4 to 5 stars. So thank you. The quiz team, Dr. Somalwar madam, Dr. Nikita Vijay madam, Dr. Kanchan madam, Dr. Rohini, Dr. Amrita, Dr. Rita, Dr. Sharwari, Dr. Sanyukta, Dr. Snehal. All rounds of applause to bring about this fun-based learning of urogynecology, a difficult topic which was made easy. Thank you so much, all of you. Thankful to whole staff of OBGY, faculty, students, and the supporting staff whose support in forefront and background could make this program possible. Whoever is not seen in the world here is taking care of the emergencies. So they are the people who are responsible for we being here. Thank you, Dr. Lokesh Kotmare, administrative officer with whole his team, who made specific that all our requirements were fulfilled. Thank you, Mamirwarji, yes, for capturing these pics and treasuring our memories. Thank you, the backbone of this program, Pooja Graphics, Mr. Jignesh and Ms. Sanjayta, with the help of the IT support, designing, brochure, banner, everything. Thank you so much, Yash Audiovisual, for your audiovisual support and telecasting this program to everybody. So thank you all the delegates for being with us and giving us such appreciative words and feedback. We'll try that we continue with the same good work, and we take up your feedback or whatever was the lacunae, like the lack of time and sometimes the IT support. That is a problem with online. I hope that COVID mar chuka hai, and next year we will have the offline version of this program, and we all will be happy with that. So with this, I conclude my long word of thanks. I'm sorry for taking long time. Thank you so much.
Thank you, Prachi ma'am. It was nice to listen from the powerhouse of our department, Dr. Prachi. Thanks a lot, ma'am. So, dear students, dream is not what you see in sleep. It is something that doesn't let you sleep. So, wishing you all success for fulfilling your dreams. Thank you all once again for joining and participating with us. Thank you.
Ma'am, please wait for a second. I will request Alka ma'am, Dean sir, and Archie sir to please present appreciation to our Master of Ceremonies for the day. Please come, Sheila ma'am and Rohini ma'am. सब लोग आएंगे ना? अलका मैम. शीला. उधर ही आ जाते हैं, थोड़ा सा उधर हो जाते हैं. And after this, I will request everybody to join in for a group photograph. So please present the. Thank you so much, Sheila ma'am, for taking the program forward so smoothly. Keep these memories alive, you know, watering the flowers every day. All of you. Yeah. Thank you. Yeah, knack is in our head. I request all of you to please join for a group.
एक मिनिट हा, आपल्याला हे चेंज करायचं, नवीन वाला टाकायचंय. तो पेन ड्राईव्ह काढून घ्या आणि हार्ड डिस्क मधून कॉपी करून टाका.
मैडम आप क्या बोल रहे हो?
I would request the dignitaries to please stay back for the lunch and just please sometimes.
Perfect. Okay. We'll get up to. हाँ मैम.
People of next session 12 o'clock. Get ready.
Yes. We are ready, ma'am. अनुश्री, फोन किया क्या आरती को? फोन करो फटाफट जोशी मैम, मंजू भाई और अनिता।
मेरे को लिस्ट में मैंने एक्स्ट्रा लिया था आरती मैम आप लॉकडाउन हो ना? बोलो। अच्छा ठीक है, नेम चेंज कर दो ना फिर अपूर्वा।
जब तेरा आरती अपूर्वा केस में से कर मैं करती हूँ।
ठीक है, ठीक है। आरती मैम
लॉकडाउन है ना, जोशी मैम को करो, वाइकर मैम को कर दो, वाइकर मैम और अनीता मैम को कर दो। मंजुश्री वाइकर मैम को करो, यादव हे आता डिस्प्ले होणार ना आमचं? मी काय म्हणते तिथे बसून जाऊ का
पुढे?
एकदा सेशन सुरू झालं की शिफ्ट करून टाकू आपण. नाही मी यांना जॉईन करवते, चालू करते सेशन अँड देन विल शिफ्ट इट अप. हे डाइस वरून करतोय इथे ऍक्च्युली दिसत नाही लॉग इन नाही दिसलं नाही याच्यावर लॉग इन नाही दिसत आहे. Karana, please join.
अब
Conduct the next session, whole session smoothly and happily. Whose meeting is being prepared now?
मैडम आपका नाम लिखोगे?
Dr. Sanyukta, SAN, YU, TTA, DAWLE, WLE.
आपका ये
वैसे कार्ड आ दिया वाई
डॉट SAN संयुक्ता
already 5 minutes. We are already 5 minutes.
देख लीजिए मैडम क्या है कौन सा
आगे कैसे
मैं करता हूँ नाम करता हूँ। क्या नाम से? संयुक्त।
Now we'll proceed with our first case presentation of today. That is on IUGR by Dr. Aarti More, NKP Sims and LMH, Nagpur. Our faculty judges for this session are from prestigious institute, Dr. Sulbha Joshi ma'am, Dr. Manju Vaikar ma'am, and Dr. Anita Yadav ma'am. I welcome you ma'am for the session. Sanjayta, please make Dr. Apurva as Aarti.
मैम प्राची मैम इज होस्ट नाउ प्लीज उनको बोलिए ना मुझे होस्ट बना दे तो
Please make Anita Yadav ma'am and Manjushri Vaikar ma'am and Sulbha Joshi ma'am as a co-host, please. Sanjayta.
मैम प्राची मैम इज होस्ट नाउ मैम हेलो मैम
Apurva.
होस्ट अनम्यूट करें
Anita Yadav ma'am. Aarti, please could you share your slide?
Yes ma'am, I'm doing it. Is it visible?
Yes.
Yes, we can see your slides, Aarti.
Okay ma'am.
Yes.
Just 1 second ma'am. इधर ऊपर इधर ऊपर
One minute, Aarti. We will just stop sharing for a minute. Stop sharing for a minute.
Yes.
ये नहीं है slide. आपने हाइड कर दिए. शेयर होने के बाकी.
Welcome, Manju ma'am, Sulbha madam, and hi, Anita. Glad to have you all here.
ये ना.
Hello, Prachi ma'am.
I would like to welcome our own Dr. Sulbha Joshi ma'am to this PGCON conference. Dr. Sulbha Joshi ma'am is professor and professor in NKP Sims LMH since 20 years. She has a huge teaching experience and she has many national and international publications on her name. Welcome ma'am for this session.
Thank you, Ragini.
Good morning, ma'am. I would like to introduce Dr. Manjushri Vaikar, ma'am. Welcome, ma'am, to this session. She has a total teaching experience of 31 years for undergrads and postgraduate students, faculty in 12 regional workshops on medical education technology, faculty in 5 sensitization workshops on PNDT, 7 publications in indexed national journals, and 1 publication in Lancet. It's nice to have you, ma'am, for this session. I would like to invite and welcome Dr. Anita Yadav, ma'am. She has a teaching experience of over 10 years. She is a recognized PG teacher at AIMS Nagpur, a member of various prestigious societies like NARCHI, JC, AMCI. She has many achievements, and to name a few, she has a compassionate junior resident during her postgraduate in 2009 to 10. And she has received this Mariamma Varghese Memorial Award for this. She has done a Foxy certified course in advanced infertility from IVF Center, Sri Gangaram Hospital, New Delhi. I welcome all the eminent faculties for this session, and we begin with the case presentation. Over to you, Dr. Aarti.
Aarti, start presenting your case and share your slide.
Yes, ma'am. Is it visible, ma'am?
Yes. Please make it full screen.
Yes, ma'am. Yes, ma'am. One second. Close this. मुझे मुख से कहीं दिखना चाहिए. Good afternoon, everyone. Am I audible and visible?
Yes, we can hear you.
Good afternoon, everyone. To all the respected teachers and my colleagues, I'm going to present a case on FGR, fetal growth restriction. I'm Dr. Aarti More. So my case, my patient, 26 years old female, Mrs. ABC, primary gravida, resident of Dhantewadi layout, Nagpur, Hindu by religion, 12 pass, belonging to lower socioeconomic status according to modified Kuppuswamy scale, housewife by occupation, booked case at LMH, admitted on 9th of February 2022 at 1 p.m. Came with history of amenorrhea since 8 months, with calculated gestational age of 36 plus 1 weeks, with ultrasonography suggestive of single live intrauterine pregnancy of 34 plus 1 weeks, with abdominal circumference of 32 weeks, head circumference of 32 weeks, and estimated fetal weight was around 2112 grams, and AFI was 13 to 14 centimeter, placenta was anterior, and Doppler was within normal limit. Patient is perceiving fetal movements well. Negative history. Patient had no.
Excuse me, Aarti. Did the patient tell you all these things? That I have my abdominal circumference is this much. And
that was her USG. She did not have any complaints. She just came for, yes. She only came for routine visits.
Patient came with USG report, suggestive of IUGR.
Yes.
That's all. You need not mention all these things.
Okay.
Okay?
Yes. Okay, ma'am. Negative history. Patient had no complaints of bleeding or leaking per vaginum. There was no history of fever with or without rash, cough, cold, or traveling. No history of trauma, fall, increased BP records. No history of nausea, vomiting, epigastric pain, oliguria, headache, blurring of vision, loose stools, burning micturition, or no history of easy fatigability or generalized weakness. History of present pregnancy. Pregnancy was detected by a urine pregnancy kit done at home after 1.5 months of missed period. It was a spontaneous conception. And for first trimester history, the first visit of patient was at LMH at a calculated gestational age of 6 weeks and was advised routine ANC investigations which were normal. Her first scan was done at 6 weeks and was corresponding to her dates.
So it was corresponding with her detection of urine pregnancy test to be positive.
Yes, ma'am. Yes, ma'am. Her NTNB scan was done at 11 to 14 weeks and it was normal. There was no history of pain in abdomen, fever with or without rash, urinary complaints, vomiting, radiation exposure, or any other drug intake. Patient received folic acid supplementation and patient had 2 visits in first trimester. In second trimester, quickening was felt at 5th month. She received 2 doses of TT at 4th and 6th month. She received iron calcium supplementation and was compliant to it. Patient had 2 visits at 19 weeks and 24 weeks. Her targeted imaging for fetal anomaly scan was done at 19 weeks and which was normal. There was no history of nausea, vomiting, swelling over feet, blurring of vision, epigastric pain, and decreased urine output. No history of acute weight gain or swelling over the body. No history of bleeding per vaginum, leaking per vaginum, or pain in abdomen.
Does this happen at 19 weeks, or you want to say that as the pregnancy progressed, she didn't have all this?
During second trimester, there is risk of all this preeclampsia, and so that's the reason in second trimester I've mentioned this.
Okay.
There's no UTI also, preeclampsia, UTI, PRM, leaking, PV, bleeding, PV, APH, everything can be seen during second trimester. So I've mentioned all the history. Third trimester, she was perceiving fetal movements well. There was no history of nausea, vomiting, swelling over feet, blurring of vision, epigastric pain, and decreased urine output. No history of bleeding per vaginum, leaking per vaginum, or pain in abdomen. Her USG done at 36 weeks was suggestive of SLIUP of 30 single live intrauterine pregnancy of 34 plus 1 weeks with abdominal circumference 32 weeks, head circumference 32 weeks, estimated fetal weight of 2112 grams, AFI was 13 to 14 centimeters, and placenta was anterior. Doppler done was normal at that time. Patient had 3 visits in 3rd trimester. Her obstetric history, she's married since 1.5 years. It is a non-consanguineous marriage. There's no history of any contraception used, and she conceived.
Arti, please go slow. It is very difficult to.
Yes, sir.
Please go slow. Don't be so fast.
Yes, sir. Yes. Yes, ma'am. Menstrual history, it was in regular average flow, so 2 to 3 pads per day for 4 days every 26 to 28 days. Age at menarche was 14 years. Her last menstrual period date was 1st of June 21. Her expected date of delivery was 8th of March 22, and her calculated gestational age at the time of admission was 36 plus 1 weeks. Past history, she had no history of tuberculosis, bronchial asthma, hypertension, diabetes, mellitus, thyroid disorders, major surgery in past, or any known food or drug allergies. There was no history of renal, heart, or SLE, systemic lupus erythematosus. And there's no history of blood transfusion or drug reactions. There was no history of clots in the blood vessels, which we see for thrombophilias. Family history, there was no history of tuberculosis, bronchial asthma, hypertension, diabetes, and thyroid in the family members. There was no history of birth of baby with congenital anomaly or chromosomal disorders. There was no history of thalassemias or thrombophilias in the family members.
If she's a primary gravida, right?
Yes, ma'am.
So what is the relevance of this statement? No history of birth of a baby with congenital anomalies or
Ma'am, in the family, if a sister, if a sister, if a mother is having any then it is seen that chromosomal disorders can be seen in her also, though she's fine.
Yes.
Personal history, her bowel bladder habits were normal. She consumed mixed diet. There was no sleep disturbances, no history of addiction as smoking, alcoholism, or tobacco. Dietary history, as per 24 hours dietary recall method, her calories consumed were 2400 kilocalories and calorie deficit was 520 kilocalories. Her protein intake was 54 grams and protein deficit was 14 grams. General exam.
Just wait, Aarti.
Yes,
yes. Can you tell me from your history, what are the minor or major risk factors which are present in your case?
Yes, ma'am. So,
yes.
I'll explain all the minor major factors or only my positive findings for my case.
In your case, what are the minor or major risk factor you identified in your case?
So major is she's primary gravida, nulliparity is a major risk factor. Then low socioeconomic status, then low diet, her diet intake was also low protein, fruit intake was less. Again,
you go to your history from first, from first slide, you tell, go tell you what are
primary gravida, low socioeconomic status.
Okay. Are you sure the primary gravida is a major risk factor?
Yes, ma'am.
Is it? I don't think so.
I don't think that primary.
Nulliparity is a minor risk factor.
Yes, ma'am. It's minor.
Nulliparity is a minor risk factor, not a major one. Right?
Yes, sorry.
Yes.
Ma'am, I can enlist all the major and minors differentially.
So just identify in your case so that you can, that will help you in monitoring of your case and plan the management, right?
Yes. So primary gravida, it will be a minor risk factor. Low socioeconomic status, again, it will be a minor risk factor. Then,
what is the patient occupation?
She was housewife, ma'am.
She's housewife, okay.
Yes, ma'am.
You said that in first trimester NT was done, double marker study was done?
No, ma'am. For her, we didn't do double marker. She was a booked case.
Any relevance?
Yes, ma'am. To know for chromosomal any anomalies if she's having, we can identify it early. But she did.
Any other relevance? Pape.
Yeah.
Pape. If for Down syndrome, ma'am, if its Pape is less than 0.4 mom, then it will be a risk factor.
Is it a risk factor for IUGR also?
Yes, it's a risk factor for IUGR also. It's a major risk factor for IUGR, ma'am.
And along with Pape, what else? What are the other biomarkers we can do?
Alpha fetoprotein and Pape we do for in dual markers, and if required, quadruple can be done, but we don't generally do. Have done her anomalies also. Anomalies can also, early anomaly scan has also been done. TIFA scan, so quadruple can also be done.
So the biomarkers can be done routinely in.
No, in high risk patients we should do routinely. In India, we shouldn't do it routinely because of the cost if it's considered. But if it's a high risk patient, then we can do.
What do you mean by high risk patient?
Ma'am, if age, different parameters are there. If it's her age is more or less, if more than 35 years, if she's having other conditions like if the mother is having different conditions like hypertension, diabetes, renal disease, renal problems, APLA, different. If she was an SGA
In your setup, are you doing it routinely for every high risk patient, PAPA and alpha fetoprotein?
Yes, dual marker we do. In our college, we do dual marker test for high risk patients.
Okay.
Yes, ma'am.
So your case is low risk or high risk?
So
from your history,
it's a low risk case, ma'am. For more than one major should be present and more than 3 minor should be present to call it.
Complete your examination. I think that will help you more.
Yes, ma'am, definitely. General examination, patient was averagely built, well nourished. Her height was 150 centimeters, weight 45 kg pre-pregnancy. Weight gain in pregnancy was 12 kg. Her BMI was 20 kg per meter square. She was afebrile to touch. Her pulse was 86 beats per minute, regular, normal in volume, equal on both sides. BP was 120 by 80 mm of Hg in right arm in sitting position. Respiratory rate was 12 per minute and it was regular. There was no pallor, icterus, sign of lymphadenopathy, clubbing, edema free. Her skin, hair, and nails were normal. There was no apparent neck swelling or thyroid enlargement. Her breast examination suggested of nipple areolar complex was normal. There was no evidence of dryness, cracked nipple, inverted nipple, or scar marks. On systemic examination, on cardiovascular system, S1 and S2 heard, and there were no murmur. Respiratory system, air entry was equal and bilaterally. There were no adventitious sounds heard. In central nervous system, patient was well oriented to time, place, and person, and she was conscious, and there were no deficits found. On poor abdomen examination on inspection, her abdomen was longitudinally ovoid. Linea nigra and stria gravidarum was present. There was no sinuses or dilated veins. All her hernial orifices seen were normal. On palpation, her abdominal girth was 77 centimeters. Her symphyso-fundal height, which was taken, was 28 centimeters, and her fundal height was approximately 32 weeks. On pelvic examination, first Leopold grid, it was soft, broad, irregular, non-ballotable structure, suggestive of breech. Second Leopold grid, on left lateral, it was smooth, hard, curved structure, felt on the left side, suggestive of back. On right lateral, it is irregular knob-like structures felt, suggestive of limbs. The first pelvic grid, it was hard, globular, and non-ballotable structure, suggestive of head. Second pelvic grid, fingers were converging, suggestive of non-engaged head. And there was no flank fullness. Her lighter was clinically adequate. Uterine size was height was 32 weeks. Her estimated fetal weight was approximately, clinically, it was approximately 2 to 2.2 kgs. She was well relaxed and there was no renal angle tenderness. On auscultation, her FHS was heard in spinoumbilical region, 140 beats per minute, and it was regular. On post-speculum examination, her cervix and vagina was healthy, and there were no other anomalies found. So my provisional diagnosis is 26 years primary gravida with single live intrauterine pregnancy of calculated gestational age of 36 plus 1 weeks with excellent dates with cephalic presentation with late fetal growth restriction.
Aarti, why you label your case as a late fetal growth restriction?
Ma'am, according to the new classification, early fetal growth restriction is when it is less than 32 weeks and late when it's more than 32 weeks.
Okay.
But
so
what is the relevance? In this case, it was gestationally 36 weeks.
Yes.
And you are saying ultrasound age was 34 weeks.
Yes, ma'am.
So is it IUGR? Liker is also normal.
Ma'am, clinically, because of her fundal height was clinically she is late FGR. When I investigate it further, then I can say this is my provisional diagnosis.
Okay,
but your clinical diagnosis has to be substantiated by ultrasound diagnosis.
Yes,
Ultrasound
yes.
is in IUGR.
Yes, ma'am. So on ultrasound also they have mentioned that Barcelona classification they have mentioned, and according to that it is a small for gestational age. So it is not an FGR. It will be an SGA fetus. That will be my final diagnosis after the USG confirmation.
What is the difference between SGA and fetal growth restriction?
Yes, ma'am. So SGA, basically if the birth weight is less than 10%, then we can categorize it as SGA or FGR. The difference is FGR should have other parameters also. For example, early onset FGR is when birth weight is less than with 10%, birth weight is less than 3 percentile along with absent end diastolic flow in the umbilical artery or umbilical artery PI more than 95.
Wait, Aarti, you
See,
want
if it is
to?
less than third percentile, there is no need of Doppler study.
Yes.
It is a severe IUGR.
Yes. And if
Isn't
it's less than third percentile, and if it's less than 10 percentile, along with that, Doppler is required. Two things are there.
Don't be in hurry, Aarti.
Yes.
Be in hurry.
Don't lose your cool. Don't
Yes,
take it. There's so many deficits which we will be coming as the case would progress. Okay.
Yes.
Okay, go step by step. This is a rehearsal for your final.
Yes, sir.
Okay.
Ma'am, I'll start it again. So early onset FGR is when her estimated fetal weight is less than 3% or estimated fetal weight is less than 10% along with Doppler changes in which
Say it percentile. Okay. It is not percent. Percentile. The difference.
Yes, ma'am. Percentile. And if it's less than 3 percentile or if it's less than 10 percentile along with Doppler changes in which umbilical artery PI is absent and diastolic flow in umbilical artery. Sorry, ma'am. Ma'am, did you say anything?
No, I didn't say anything. I was just, I was looking at my notes. I had to ask you some questions. Go ahead. Go ahead.
Less than 10% with umbilical artery PI or uterine PI more than 95% or MCA ratio less than 5% if it's there, along with 10 percentile, less than 10 percentile if estimated fetal weight, and late onset will be if it's more than 32 weeks, but if the estimated fetal weight is either less than 3% or if it's more than 10% along with Doppler changes will be there, and her MCA and CPR ratio will be reduced. It will be less than 5% or 2 percentile growth difference is seen on the growth chart.
So Aarti, in your case, what are the positive findings which except the fundal height, is there any other things why you label your case as a IUGR?
Yes, ma'am. Actually, symphysis-fundal height, it is not, we cannot rely on it totally. But initially, we used to, there's one classification according to the fundal height, we can label as mild, moderate, and severe IUGR. But that was, they used to use it initially. Now we don't use it. So, in which it is said that if mild IUGR is said to, on the basis of the symphysis-fundal height, mild IUGR is said if there is a lack of 2 to 4 weeks. Moderate is if there is a lack of 4 to 6 weeks, and severe if there is a lack of 6 weeks. So in my case, my symphysis-fundal height is 28 weeks, 28 centimeters, while my patient clinically she is 32 weeks. So it is a lack of 4 weeks. So I can say it's a moderate IGR if I decided on the fundal height based on that.
But you said your SFH is 28 centimeters,
yes,
and the fundal height was 32 weeks.
Yes, ma'am.
Is it corresponding or is okay? Your statement is right.
Ma'am, that is what, if there is a difference, if there is a lack of 2 to 4 weeks, then we can call it according to the fundal height classification. According to that classification, we can call it moderate IUGR. But it is not reliable. SFH is not 100% reliable. That's the reason we don't use 100% for that right now. Other classification we are using to label it IUGR or FGR.
Was there any follow-up after, I think, 24 weeks of gestation till the patient came to you, and how was the growth occurring clinically during that time? How many visits did she have after 24 weeks?
Ma'am, she had 3 visits in third trimester. So she came at 24 weeks, she came. After that, she again came at 30 weeks and 32 weeks. And last, when she was admitted. So when she came at 24 weeks, she was corresponding. Also 30 weeks also she was corresponding clinically, and the USGs, when we have done the USGs to see the growth, that was also normal at that, as in corresponding that time. When she came at 32 weeks, at 32 plus 6 weeks she has came. So at that time, clinically she was only 30 weeks. And at that time, we have advised her a scan plus Doppler at that time at 32 plus 6 weeks, which was not corresponding, and it showed Doppler was normal, but her AC and HC was a bit reduced at that time. And in 36 weeks, so it was of very less, as in 32 weeks only.
So you did catch her IUGR around a month or 5 weeks earlier than the time that she got admitted to you.
Yes.
Okay, and what you have told that the total weight gain was some 12 kg. So how was it distributed?
So during normal pregnancy, the weight distribution is like during first trimester it should be one.
I'm not asking you what happens in normal. I'm asking you in the current case, what happened?
Okay, so during her first trimester, it was around 1 kg. During her second trimester, it was around 5 to 6 kgs, and the remaining was in a third trimester. 6 kgs was around roughly, it was around 6 kgs in second trimester.
How much is the normal weight gain in pregnancy?
Ma'am, during
Was-
first trimester, it is 1 kg approximately. In second trimester is 5 kgs, and third trimester 5 kgs. But it depends on BMI also. It's not always fixed this. If BMI is less, then more weight gain can be allowed, or it is normal. If BMI is more, then less weight gain will be there. So if it's less than 18.5 BMI, then approximately 13 to 16 kg of weight gain is allowed. If it's between 18.5 to 24.9, approximately 11 to 13 kg weight gain is allowed. If it's between 25 to 29.9, then 9 to 11 kg is allowed. And if it's more than 30 kg, then 5 to 9 kg is allowed, or approximately 7.
Okay, Aarti, in your case, patient has already reached 36 weeks. Management is not a problem. You tell us the management in patients who develop early IUGR.
Okay, so early IUGR basically there. So first we should rule out what was the cause of our early IUGR, so that we can treat it accordingly. So causes of early IUGR. If it is early IUGR, it means there's problem with the fetus. It is initial classification. According to that, it will be a symmetrical IUGR. So basically, there's problem with the fetus. So there might be infections or other fetal problems, chromosomal anomalies, structural abnormalities, other problems which must have led for this. So we should rule out can we treat it, or whether it is treatable or non-treatable. If it is infections, if it's infection or other infections which we can treat it, then we should treat it accordingly. If we cannot do anything, then we'll have to wait for that. If it is having chromosomal anomalies or some abnormalities which got detected later on, as in after second trimester, then we have to wait and do only minimal we can do.
Okay, what are the recommendations for the monitoring of early onset IUGR?
Sorry, ma'am, I couldn't hear it properly.
Recommendations for monitoring of a patient with early onset IUGR.
So if it is an early onset IUGR, like I said, we first have to rule out all the things. Then we'll do her.
How frequently you will call her? What are the complications?
Yes, ma'am. So according to RCUG, the major and minor risk factors are there. If she is having more than 3 minor and more than 1 major, then we'll do her uterine Doppler at 20 to 24 weeks. If it is normal, then we'll do her.
Before that, any intervention if you have identified major or minor risk factors? Any intervention that can be carried out to prevent, which is a recommendation?
Yes.
I did not.
The only drug which can help.
Early onset IUGR, you must be prescribing this drug routinely.
This drug should be routine. Before 16 weeks, we have to start.
Low dose aspirin. Low dose aspirin will give her. Before 16 weeks, we'll give her low dose aspirin. It will help to prevent. The blood supply will be increased, and it will also help to prevent help in preeclampsia also, if she later develop, which is one of the cause for IUGR also.
Okay.
So I will continue. We'll see for 3 minor and 1 major risk factors. If any of them is present, then we'll do an uterine artery Doppler at 20 to 24 weeks. If it is not, it can be either normal or abnormal. If it is normal, then directly in third trimester we can do her umbilical artery Doppler. If it is abnormal, then in 26 to 28 weeks we have to do her umbilical artery Doppler. Also, other indications to do it in 26 to 28 weeks are, if we are not able to clinically, we are not able to correlate, like in case of fibroids, large fibroids, where her SFH will not correlate. In that cases also, we'll do her umbilical artery directly in 26 to 28 weeks. If umbilical artery Doppler done, now whether there are 2 situations, it can be either normal and abnormal. If it's normal, then serial assessments we'll call her twice weekly. We'll do her Doppler again just to see if it's IUGR and umbilical artery Doppler normal. Then we'll call her twice weekly, and we'll do her BPP once weekly, and CTG if required. Once weekly we can do that. If it is abnormal, now in abnormality there are different things. If there is an absent end diastolic.
Aarti, wait. You detected IUGR at 24 weeks of gestation. At present, the Doppler findings are normal. How will you proceed? And how frequently you will call? And what are the parameters? And how frequently you will repeat those Doppler, or like how you will do the monitoring?
If she's 24 weeks right now, and if her Doppler is normal, like I said, I'll do a direct third trimester umbilical artery Doppler. I'll do, and I'll call her routinely. I'll call her. But
third trimester means she's at 24 weeks at present. Then you will leave her.
Ma'am, I won't leave her. I'm saying for Doppler, just only for Doppler, repeat Doppler I'll do in third trimester.
Apart from the Doppler, what else you can do?
Yes,
for
ma'am.
monitoring?
Yes, ma'am. I'll call her routinely and I'll do her normal interval USGs. I'll advise her a proper what all of the risk factors which we can help here.
That you have already done. She's a suspected case. She's then
Low dose, if she has come, if I have identified at 24 weeks, then there is minimal role of giving aspirin at that time, but still we can try for it because it should be given less than 16 weeks. Then her diet, I'll explain her diet, good high protein diet, I'll explain her. Then other multivitamins I can give her. USG
Recent recommendation is give fruit, increased fruit intake.
Yes, ma'am.
Okay, so that is also one of the recommendation. Then
high protein diet I'll give her. Then interval, to see the interval growth, I'll do her USGs also after every 3 to 4 weeks to see the interval growth. Without Doppler, I can do it. NST after 32 weeks, I'll do to see it. And I'll rule out other, I'll after examination, I'll rule out there should not be any infection like vaginitis or other UTI. If it is present, I'll treat that because that will also ultimately lead further problems.
How frequently you will do Doppler in this case?
Ma'am, if her Doppler at 24 weeks is normal, then I can do it in third trimester. 32 to 36 weeks, I can do it in third trimester to look for umbilical artery Doppler. And if there
not every 2 weekly?
Ma'am, not required. If it is normal in 24 weeks, if it's normal, 20 to 24 weeks, if the Doppler is normal, where at that time we see uterine artery. If it is normal, then directly it's according to RCOG guidelines, directly I'll do it in third trimester. Only if it's
trimester means at what gestation is 36 weeks?
32 to 36 weeks, I can repeat, ma'am.
According very long.
Everybody agree with that? I mean,
it's given in RCOG guidelines. Recent RCOG guidelines.
32 to 36 weeks is a very long duration.
32 weeks is cut off. After 32 weeks, she should do.
As per RCOG, they say repeat the Doppler every 1 to 2 weeks and do the growth, check the growth every 2 weekly. We cannot leave at patient 24 week, then directly calling her at 32 week. In between 8 weeks.
Sorry to interrupt. That is what I meant to say. I'll also see her clinically. If I feel he's worsening, I'll decide to do it earlier. But whatever, sorry, obviously it must be given, but it's proper written that we can directly go it in third trimester. It wasn't given 32 to 36 weeks, but approximately at that time, that is what I meant. But it's okay, less than 30.
When you're talking of third trimester, it begins from end of second trimester till 38, 39 weeks.
No, yes, right, ma'am. Yes, ma'am.
Okay.
Please conclude the case.
Okay, so my patient, she's a primary gravida. I'll give her what are the positive findings. She's a primary gravida with 36 plus 1 weeks with normal BMI she's having, with her symphysiofundal height, which is not corresponding, and her uterine height is 30 weeks, but Liker is adequate. And after her USG, after all investigations and after looking at her USG, I'll say that it is a small for gestational age case.
Arti, you presented your case well. I just want to tell you, you plan the management as per your case. I know you all know theory quite well, but we need to plan. We need to manage our own patient which is in front of us. So just have a just plan for your case how you will investigate her, how frequently you will call her. Otherwise, the presentation and everything is good. All the best, Arti.
Thank you, ma'am. So for my case, ma'am, as she's 36 plus 1 weeks, and clinically I have seen that I feel that clinically she's late FGR. So obviously I'll tell her to get admit just to rule out other things also. So I'll admit her, I'll do her counseling, I'll take her consent, I'll explain her all possible risks, what can happen, what are the pros if we wait and what are the cons if we don't wait. And as according to RCU, according to recent guidelines, it is said that we can also give steroids before 36 till 36 plus 6 weeks. According to RCUG, I guess it's 36 weeks, and according to ACUG, it's still 36 plus 6 weeks. So I want to give her steroid coverage for 48 hours. I'll give her steroid coverage, and I'll wait. And I'll do her Doppler also. In my case, I'll do her the Doppler which was done. It was at 34 weeks. So I want to repeat it because she's admitted and it is convincing. It is easy for me. So I'll do her USG plus Doppler. If I find there is any problem with it, then if I see there is umbilical artery, what are the factors on which I'll decide a termination will be if I see if there is absent umbilical artery flow or reversal of umbilical artery flow, or MCA is hampered or CPR ratio is less, then I want to terminate it immediately. If I find everything is normal, or if it's I can wait, then I want to terminate it after 37 completed weeks. And at 37 weeks also I
Any role of magnesium sulfate in your case?
Ma'am, in my
you would like to give?
No, ma'am, not in my case. Magnesium sulfate, according to recent guidelines, it should be, according to RCOG, it is given less than 29 weeks, I guess, and according to other guidelines, it is given less than 32 weeks. So in my case, there is no, as such, there is no rule.
Any role of cardiotocography?
Yes, ma'am. At our institute, if I think according to me, at our institute, CTG is readily available. So I want to, if I'm admitting her, it will be very good if I do her CTG. It's not recommended to do it twice a day, but as it is available at our institute, I want to do it. So CTG also can be done.
So if CTG is not available, what else can you do?
Ma'am, BP every weekly, if a Doppler is normal, then it is given. If a Doppler is normal, then BPP can be repeated every weekly, or NST can be done on the Doppler or fetal Doppler also. We can hear
any role of fetal kick count?
Yes, ma'am. Definitely there's a role. That is the very important thing which the mother should do, because the mother can understand well more than the machine. The mother can understand it well. So that will be a very important aspect. I'll tell her to do her daily fetal movement count. That will be very important for her to do. And also I'll keep in mind if I give her steroid, there might be reduction in her fetal movement count. Also, I'll keep in mind that also. So that will be one of the things to keep in mind in my case.
Sorry to interrupt you, ma'am, but we are running out of time. Can we please conclude?
Last question.
Actually,
from...
we started very late, na? We started 10 minutes late. Isn't it? Okay. But still, Aarti, because you are a postgraduate student, can you tell me a few trials which are going on IUGR?
Yes, ma'am. There are different trials. I'll first rename them, which I have read about: Infant trial, Grid trial, Truffle trial, and
I am not interested in name. What is going on IUGR? That
yes,
we should
yes.
know.
So
What are the results?
Yes. So one by one. So infant trial, it has seen that there's infant trial is done to see for the role of CTG and fetal monitoring. So it has seen that in cases where the FHS was less on CTG, and if we have terminated them, and other thing was that we have waited and then we have terminated. So the result was similar. There wasn't any indication that because CTG in 80% of the cases, it can give wrong results also, as in false negative, it can be false positive, it can give. So infant trial is for that. Truffle is trial of fetal and umbilical flow. Truffle trial is basically for that. So in this, we have checked for the umbilical artery Doppler, and if there was a problem in umbilical artery Doppler, and then we have seen for the ductus venosus artery Doppler, and we have decided delivery according to that. And when we have seen the results with that, if we have checked for her ductus venosus and then we have terminated, then the results were good. Rather than only depending on umbilical artery, in later trimester we should also look for ductus venosus Doppler also. Other is
of sildenafil.
Yes, ma'am. Yes, ma'am. The
Strider trial is there.
Yes, ma'am. Sildenafil. So it was done in 2017 and it ended in 2018. In that trial, that given two groups were there. One with
placebo. Is it useful? Sildenafil has any role?
No, ma'am. It's not useful. It's not used recently because of other problems also. And we have to. There were many problems with that. That we have contraindications. We have to rule out all the contraindications. Then we have to give it. And we have seen that there was not much good result with it. So we are not using it now. It was done in 2000. It was ended in 2018 itself.
Okay. Last question from my side.
Sorry,
last question from my side. If there is polyhydramnios and you are suspecting fetal growth retardation, what are the different possibilities?
Ma'am, she can have poly with IUGR. Sorry, ma'am.
Mostly IUGR is associated with
preeclampsia. Preeclampsia, because normally with IUGR oligo will be there, but if it's poly and IUGR, then it is preeclampsia. Also, there can be congenital anomalies which can be seen if it's poly and IUGR.
The preeclampsia, I have not understood. What is preeclampsia and IUGR? What is the relation of preeclampsia, IUGR, and hydramnios?
Ma'am, in preeclampsia, there is a problem in the trophoblastic invasion. So basically, the invasion won't be proper, and the blood supply to the
I think you are deviating. Please don't give maybe any explanation. If there is growth retardation and polyhydramnios, you must suspect there may be anomaly, aneuploidy should be suspected, or neural tube defect should be suspected, which is the cause of IUGR. Okay?
Yes, ma'am.
From my side, how should you monitor the baby once you have delivered the baby? What are the problems when the IUGR baby is born?
And there are short-term problems and there are long-term complications which have been seen.
The baby is with you currently. Long term, we are not discussing, only short term.
Yes, ma'am.
The mother and the child is in your hospital. What do you do?
Yes, ma'am. So during before the delivery, during the delivery also, we have to keep in mind certain things. As the baby is small, we have to make sure to give a proper oxygenation to the mother. We have to look for her FHS anytime if we feel that there is a distress or other maternal.
That the child is already born. The mother and baby, the child has delivered. Then what?
The child has been delivered, the most common complications which we see are hypoglycemia, as the low glycogen storage is less. Hypothermia will be there. Again, the same reason as the fat is less. Hypothermia will be there. Respiratory distress can be seen in the babies. Meconium aspiration syndrome can be seen in the babies. Intracranial hemorrhages, periventricular leukomalacia can be seen. Sorry, ma'am?
Right.
Okay.
Go ahead.
Interventricular hemorrhage, periventricular leukomalacia, also fetal wasting syndrome. It is also seen because the fat is not there. All the muscles and that will also be thin, and fetal wasting can be seen. Short-term complications.
And one more thing, if some anomaly is missed, that anomaly can be manifested in the neonatal period. That also should be kept in mind in IUGR.
Yes, ma'am. Ma'am, long term will be the baby will not be able to cope up like the normal babies. In terms of appetite, the reduced appetite, diarrhea will be there, absorption will be reduced, neurodevelopmental delay, milestones can be delayed in certain cases. It has been seen, but this has seen only till 2 years. When we have studied late, some studies are there which have seen that after 13 years they were okay. And there is also a role of Barker's hypothesis in this, because the baby is small and it had went through a very stressful delivery. So later on in the baby's life, baby can develop other metabolic syndromes also, diabetes, hypertension, cardiac diseases. The baby can develop that also.
Sorry to interrupt you, but we need to summarize this case as we are running out of time. Can we please summarize the case?
So Aarti, your presentation was good, but you were very, I think you should go slow.
Yes.
The case was very nicely presented. And what is the take-home message now? There are minor and major risk factors, and 90% of the cases of IUGR, you can identify from history itself. History taking is very important in IUGR, and intervention whenever required. Okay, then serial ultrasonography has to be done, and your management depends on serial ultrasonography and your findings.
Yes.
There are very few drugs which are available for management. It is the surveillance which is important. Timely management is very important. So timely detection of abnormal Doppler, timely detection of abnormalities, and delivery. And most of the times the delivery, the babies are compromised, and most of the time the delivery is by cesarean section. One should always see to it that the baby is salvageable. For example, in Western countries at 26, 28 weeks, even if they find that the baby is normal, they can take out the baby by cesarean section. But at our place, we have to find out whether we can really save that baby at 26 weeks. Otherwise, you are going to just convert an intrauterine death into the
neonatal death.
So that is very important.
As it has been rightly said, don't fear for facing failure in the first attempt, because even the successful maths starts with 0 only. Nice case presentation, Dr. Aarti.
Thank you so much,
judges, for guiding Viva right from the very basics. And thank you for giving your precious time and judging this session. Thank you so much, ma'am.
Thank you so much to all respected teachers for all the questions. It is really good. It is really helpful for us, ma'am. Thank you so much, ma'am.
Yes, we wish you all the best, Aarti.
Thank you so much, ma'am.
Yeah, okay.
Wish you
Thank
all
you,
the
madam.
best, all PGs, and thanks the organizers for inviting for this prestigious case discussion session. Thank you so much.
Go ahead with our next session, that is a case presentation on prolapse in young patient by Apurva Mukherjee, PDMC Amravati, and our judges for the session are Dr. Hemant Deshpande sir, Dr. Pushpa Jungare ma'am, and Dr. Anil Humne sir.
You can start.
1 minute, 1 minute, ma'am. Yes. It is not working.
The faculty for this challenging cases are Dr. Hemant Deshpande, Dr. Pushpa Junjare ma'am, and Dr. Anil Humne sir. Dr. Hemant Deshpande sir is professor and HOD of OBGY department, Dean DY Patil Medical College, Pune. He is a chairperson of Medical Education Committee FOXY 2016-2018. He has written and edited 5 books, which includes textbook of high-risk pregnancy, polycystic ovarian syndrome, A clinician's manual, male infertility problems and perspectives. He has many publications on his name. I welcome you, sir, for this session. Sir, are you here? Our next judges is Dr. Pushpa Jungare. Pushpa Jungare ma'am is professor and HOD, Department of OBGY, PD, MMC, Amravati. She is a member of UG and PG Board of Studies of Surgery and Allied Subjects, MUHS. First visiting professor sent by FOXY to Cuttack Medical College, Odisha. Faculty in many national, state, zonal conference, CME and workshops. Past president, Amravati OBGY Society. Organizing secretary, state conference of NOGS in 2005. She has many.
I think that should be fine.
Yes, ma'am. You have a wide.
That should be fine. You can go ahead. Dr. Anil Humne.
Is Dr. Anil Humne, sir. I welcome you, sir. Sir is associate professor and unit head, Department of OBGY, GM Nagpur. He has experience of 25 years. He runs endoscopic unit at OBGY GMC Nagpur. He has 20 publications, both in national and international journals. He is a master trainer in collaboration on World Endometriosis Research Foundation. I welcome you,
Hello. Start presenting your case.
Am I audible, ma'am?
Yes, yes.
Good afternoon, teachers. Today I'll be presenting a topic on pelvic organ prolapse in a young female. My patient, Mrs. XX, is a laborer by profession, 26-year-old. She is a resident of Rahadgaon, Amravati. She is wife of Mr. X, who is also a laborer by profession and age of 28 years old. She is Hindu by religion and qualifications of standard 12. She belongs to a low socioeconomic status as per the modified Kupuswamy scale. She has a 4-year marriage, which is non-consanguineous. She came to the gynecological OPD with these complaints of something coming out of the vagina since 1 year and feeling of looseness during coitus. Patient was apparently all right 1 year ago when she had complaints of something coming out of the vagina. It was insidious in onset 3 months after her vaginal delivery and gradually progressed to the present size. It is aggravated on exercise, straining, lifting heavy objects, and on defecation. It is reducible on lying down. Patient is sexually active but complains of feeling of looseness during coitus. No history of increased frequency of urination, burning sensation, urgency, involuntary leakage of urine with coughing or straining. No history of chronic cough. No history of constipation, incomplete defecation, or fecal incontinence. Menstrual history. The last menstrual period was on 2nd of February 2022. She attained menarche at the age of 14 years. Her past menstrual history, she has regular cycles with no clots or dysmenorrhea. Sexual history, patient is sexually active, no complaints of dyspareunia. Coital difficulty associated with feeling of looseness and decreased frequency of coitus has been told by the patient. Obstetric history, my patient is para 1 living 1. She has a female child of 1.5 years in age, which was delivered at a PHC of 3.5 kg. It was a full-term normal vaginal delivery with right medial lateral episiotomy. No history of prolonged or difficult labor was given by the patient. No history of instrumental delivery or postpartum hemorrhage. No history of episiotomy gape or episiotomy site infection. Patient resumed her work 3 to 4 weeks after her delivery. Past history, my patient is non-diabetic, non-hypertensive, no history of thyroid disorders, asthma, tuberculosis, chronic constipation, or connective tissue disorder. No history of previous pelvic surgeries or blood transfusion. My patient has a mixed diet with normal bowel and bladder habits, normal sleep pattern, no known food allergies or substance abuse. Family history, no family history of asthma, tuberculosis, connective tissue disorder, hypertension, diabetes, or thyroid. On examination, my patient is moderately built and well nourished. No pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema was noted. Her height is 143 centimeters and weight of 50 kilograms, which gives us a body mass index of 24.6 kg per meter square. Her vitals are stable with a pulse of 86 beats per minute, temperature of 98.4 degrees Fahrenheit, a blood pressure of 120 by 80 millimeters of mercury, and a respiratory rate of 16 cycles per minute. On systemic examination, no abnormalities were detected. Cardiovascular system, S1 and S2 were normal. Respiratory system, air entry was equal on both sides. Breast and spine examination were normal. On abdominal examination, on inspection, the abdomen is flat. Umbilicus is in midline and inverted. No visible scars, dilated veins and sinuses seen. On palpation, all inspection findings were first confirmed. Abdomen is soft, non-tender. No organomegaly is noted. Abdominal muscle tone is normal. On percussion, tympanic note heard all over the abdomen, and on auscultation, vowel sounds were heard. On gynecological examination, after taking a verbal consent from the patient, she is examined in dorsal position with flexion at hip and knee joint. At first, the patient was examined with comfortably full bladder, and later for the examination, she was asked to void for further examination. On inspection, the external genitalia is normal and the episiotomy scar is seen. At introitus, cervix is seen protruding 1 centimeter beyond the introitus. The cervix appears edematous, hypertrophied, and congested. No keratinization or decubitus ulcer seen. Since patient was inspected first with comfortably full bladder, on Valsalva maneuver, no spurting of urine was noted. After this, the patient was asked to void her bladder. On post-speculum examination, the cervix is visualized, external os is slit-like, vagina is healthy, pink in color, moist, rugosities are present. No cystocele, rectocele, or enterocele were demonstrated. On per-vaginal examination, mass is completely reducible and findings of post-speculum examinations were confirmed. The uterocervical length is of 10 centimeters and bilateral fornices were shallow. On bimanual examination, uterus is retroverted, normal in size, firm, and freely mobile. Levator and eye tone is moderate according to modified Oxford grade 3. Perineal body tone is slightly reduced. The anal sphincter tone is good on per-rectal examination. Bulbocavernosus and anal ring reflex were elicited bilaterally. As per the pelvic organ prolapse quantification 3x3 grid, we can see that the genital hiatus is slightly widened to 4 centimeter and the perineal body is reduced to 2 centimeter. C being the leading point is at +1, D point is at -4, and the total vaginal length has been reduced to 8. Thus, to summarize, a 27-year-old para 1 living 1 married woman belonging to a low socioeconomic status, admitted with complaints of something coming out of the vagina and feeling of looseness during coitus with BMI of 24.5 kg per meter square, with no associated comorbidities, shows grade 3 uterine prolapse or pelvic organ prolapse quantification stage 2 or Baden-Walker stage 4 of prolapse. My provisional diagnosis is a 27-year-old para 1 living 1 married with 3rd degree uterine prolapse with cervix as the leading point corresponding to stage 2 of POPQ classification with no cystocele or rectocele. Thank you.
I was missing the initial period of this particular discussion. Can you tell me your name?
Good afternoon, sir. I'm Dr. Apurva Mukherjee from PDMMC Amravati.
Now, Apurva, what do you think? What could be the cause of this particular prolapse in a young patient? 27 years, only one delivery?
Yes, sir. So probably it's an obstetrical cause, or the patient could have had a congenital prolapse which he had not understood before, and after the vaginal delivery, it is now more prominent. So these are the two
Suppose this
provisional.
would have been congenital prolapse. Would it
Yes.
not had been affected in last pregnancy?
So it would have affected the patient in the last pregnancy. Yes.
Right? In the first few months, even after delivery. So that means at that time,
Yes.
she has not shown any problem to you. So do you still think it is congenital? What
No, sir,
obstetrical
no, I
problem
do
you expect in this para 1 patient?
So
One delivery
probably
only.
she
Do you
must
think
have.
single delivery can cause the prolapse?
So
Was
if
she
the patient has
Apurva?
yes.
Apurva, was she with you during her first pregnancy or delivery? Had you seen her? What do you expect? Suppose patient had congenital defect. She may not have noticed, but what you as an obstetrician might have noticed when she came for antenatal checkup or just prior to delivery. How did this patient present?
We would have noticed cervical incompetence, ma'am, if she would have come with a congenital prolapse in the start.
No.
Incompetence? No.
No, sorry. It's post-surgery.
Incompetence hardly occur in a patient who is having long
With
cervix.
prolapse, yes.
Incompetence
patient
is a
might have
problem
had
when the
this.
cervical length goes on less and less.
Yeah.
Apurva. And in
Yes, sir.
patient, your
Yes.
patient, you said UCL is 10 centimeter.
So maybe it was of less extent, but still on examination, if she had come to you for antenatal checkup, what you would have noticed? It may not have been realized by the patient herself because she may not be incapacitated or she didn't notice herself.
Yeah, could be.
But you on examination, what could have been the findings? If it was pre-existing.
Elongation could have been. If it was pre-existing, cervical
So
elongation.
in this
could
stage
have
of
been
pregnancy,
there.
this will be most prominent. Cervical descent or prolapse. In first trimester, second, third.
In first trimester, it would have, first or second trimester, it would have been more prominent.
And then?
And then during the third trimester, if the, sorry, ma'am?
Size of the cervix increases. It becomes hypertrophied.
Hypertrophy. Yes.
But then why you said that it is noticeable in first or second trimester, not in third trimester? What is the difference?
In third trimester,
what happens?
In third trimester, the lower segment starts to develop if the patient goes into labor. So maybe we could not have been able to see it.
No. You think and tell. What happens after 12 weeks of pregnancy? What happens to the uterus? Where does it grow?
The uterus remain as a pelvic organ, Apurva?
No, it becomes abdominal organ.
When the uterus goes to the abdomen, when it becomes an abdominal organ, definitely all these problems are going to be less. Yes. So that means either in the puerperium first few weeks, the problem will be more, or definitely it is more in the early trimester before the uterus becomes abdominal organ. Right?
Yes, sir.
Okay. Now you told your patient is.
Did you ask her the
congestion and hypertrophy? And you,
sorry, I couldn't.
Your patient is having cervical elongation, hypertrophy, and congestion. Why do you think why this would have been happened? Is it a feature of uterine prolapse or uterovaginal prolapse?
So it's a feature of uterine prolapse only, sir, because of the stretching, because of reduced, it's because of the venous congestion. There could be edema, and hypertrophy could be because of the previous vaginal delivery also, since the os becomes a little hypertrophied and slit like after one vaginal delivery. So those could be the two reasons combined, that it could be a prolapse plus a previous vaginal delivery.
Dr.
Why
Umesh
you
sir
are not
was going
expecting a
fast.
cystocele along with the rectocele?
So the
When you are
patient on
saying she is a
examination.
congenital prolapse,
Yes, sir.
she is not having at least minimum grade 1 cystocele.
No
And did you ask her
cystocele.
the precipitate labor in this case?
Yes, sir. I asked her if there was any
Precipitate
prolonged
labor?
labor or yes, sir. I asked if there was prolonged labor or it was a she had very early bear down in the stages of the labor. The patient had not given me such history of sorts.
No, precipitate labor.
No,
Do you
sir.
think
Patient
that
did not
precipitate
give me.
labor?
How does precipitate labor affects this incidence of prolapse?
Ma'am, there could be sudden dilatation and effacement in a shorter span of time instead of being proper eventful dilatation and effacement, which lead to the stretching of the ligaments.
Apurva, how much should be the total duration of the labor? First stage, second stage, third stage combined. To label it as a precipitate labor?
So less than 6 to 8 hours in a primary gravity.
Less than
It is
6
not
to 8 hours.
precipitate.
Correct, it's still lesser than that, no? Okay. So what labor problem this patient, was she having hospital delivery first or she delivered at home by some guy?
No, she was delivered at a PHC, sir, nearby PHC at Rahadgaon.
Primary health center. Maybe A&M could be there or maybe PSC medical officer. What problem you expect in this patient? What problem, what might have gone wrong? Suppose this would have been with labor, then do you think only uterus, the cervix would have come out, or there would have been some problem with enterocele, rectocele, cystocele also?
Yes, sir, there could have been if there would have been any lacerations or tear which would have gone unnoticed, or fistula would have been created because of certain.
You're going haywire. You're going off the track.
Off the track. Just tell us the labor problem that can cause or that can cause some prolapse, either uterine or combined uterovaginal.
So early bearing down by the mother, or there could be dystocia which could lead to the compression of the head on the perineal body. That could lead to such complaints.
Any iatrogenic cause?
Still more?
Any iatrogenic cause?
Lacerations or episiotomy could.
Episiotomy is a preventive measure.
That's a preventive.
Iatrogenic means whatever we do or in hospital, whatever intervention was carried out, that might be responsible for overstretching of the ligamentary supports muscles. So what is such event?
Probably fundal pressure.
Okay,
Apurva,
anything
what do you
else?
think about Apurva?
Yes.
What do you think about as she is a laborer by occupation? What is the importance of postnatal care in relation with in your case?
Her occupation, her socioeconomic status.
Yes, sir. Since the patient is a laborer by occupation and she returned to her work also within 3 to 4 weeks after her delivery, she did not take adequate postnatal rest. So her perineal muscles did not get the proper time to go back to their normal stage just a little bit. She must have overworked, straining, increase of intra-abdominal pressure while lifting heavy objects could have been the cause of more laxity of the muscles, as well as overstretching of the ligaments could have been there, since it at least takes minimum 6 weeks for the uterus to get involuted properly, and she returned to the work even before that. And we don't even know if she took proper perineal care, perineal hygiene, or sits bath, or all those things, if it was given to the patient, or she took that much care of herself. So those could be the combining factors which must have led to it. Nutrition as well.
And nutrition.
Have you heard of maternal depletion syndrome? Postnatal, it is really important, no? anemic mothers, malnourished mothers, poor diet, and poor socioeconomic status. So all these things, they are going to cause maternal depletion syndrome. Probably that could be responsible. And laborer occupation, sitting in a squatting position and work in the either in the farm or even on the stone breakers by the side of the road. So wherever she works as a laborer, her position is in squatting position for hours together. So that could be also one of the responsible factors.
Yes, sir.
Okay. Was there any decubitus ulcer in your patient?
No, sir, there was no decubitus
There was
ulcer.
some congestion, there was some elongation.
Yes, sir. There was edema and venous congestion, but no decubitus ulcer was present.
What is the cause for decubitus ulcer?
Because of venous congestion and stasis, it could lead to decubitus ulcer formation.
Where does it appear? Which part of the cervix?
Most dependent part of the cervix, it will appear on the most dependent site.
And how do you treat this decubitus ulcer?
Decubitus ulcer, we could do vaginal packing of the patient using MgSO4 and glycerin, which is a hygroscopic agent as well. So that will, as well as it will keep the uterus inside the vagina while we pack it. So it will also help us give us the blood re-establish the blood supply, which could have been there, and reduce the congestion. That is how we could reduce the decubitus ulcer or treat it.
Is it the packing that will help to heal the ulcer, or is it the repositioning of the uterus and cervix will help to heal the ulcer?
So reposition would help it.
See, right? Why repositioning is much more better, much more effective?
Because venous congestion is reduced since the prolapse is hanging down. There is a lot of venous stasis and congestion. Once we reposit it inside the introitus, the blood supply is established a little bit better.
See, near the interlos, the uterines, artery and veins.
Packing.
Right? So when the uterus descend down, there
So
will be
in your case,
uterine, artery and vein. So both of them, they will get king. Uterine vein will get king more because the pressure is merely 10 to 15 millimeters of mercury. And uterine artery is thick walled, elastic. So the kinking will be much more less, but there may be slightly. So venous return will be hampered first with little reduction in the blood supply from the artery. So oxygenation and nutrition will be hampered by arterial supply, compromised slightly. But venous return will be 100% compromised. Right? So that's the reason there is an ulcer formation. How is this? Is it superficial ulcer, deep ulcer? How are the ages of this decubitus ulcer? Are they undermined edges? Are they everted edges? Are they clean-cut edges? You see the lesion of the cervix and you must differentiate what type of ulcer it is. Because we never take every time a pap smear from decubitus ulcer until less. If it doesn't heal even after 7 days of packing, then only we take it.
Yes, sir.
We know this is because of the... So once you repose the uterus back, the venous return will be established, the arterial supply will be established, and the healing will start. No? So it is always a superficial denudation of epithelium with a clean-cut edges. You see undermined edges in the cervical tuberculosis and everted edges in the malignancy. Here the edges are clean-cut. Here the edges are clean-cut. Okay. So repositioning as well as some antiseptic application as well as some hygroscopic material application like glycerin or even MgSO4 that can take place. That can heal the ulcer. Okay.
The advantage of having Dr. Hemant Deshpande as examiner
so in
is
patient of packing,
you get a lot of information.
So
sir, please continue.
So the patient Apurva, so
Yes,
your patient is need to get admitted in patient where the packing is required. So suppose patient is not willing to get admitted, or then in patient of decubitus ulcer.
Any alternative?
So we could
Is there any
advise her or
alternate?
teach her how to use pessaries for the amount of time she at least wants to not get admitted. That will also help us keep the ulcer back into the position.
How to select and what type of pessary you? How to select the pessary and
Either we could use space occupying pessaries or we could use ring pessaries. Usually we prefer ring pessaries. We could teach the patient how to insert it. First, we'll have to measure the exact size of the pessary that could be needed, as it varies from patient to patient. We'll measure the D point and then till the introitus, the length, and minus 1.5 centimeter. That could be the diameter of the pessary that could be used for that particular patient. The patient will be taught how to squeeze the pessary and then relax the muscles, insert the
Apurva,
pessary.
wait. Is it the patient who is supposed to put the pessary? How long it is supposed to be kept once it is inserted?
The patient is taught how to put the pessary. As an obstetrician, I'll first
who is going to
insert
insert?
as an obstetrician, I'll first insert the pessary and teach her how to do it on
So
her
how
own.
long it is
The
going to be
pessary-
retained? How long it
the
is to be
pessary,
kept?
the pessary could be inside for like a minimum amount of 1 month, and then it should be taken out or at least cleaned
And
with
how
hot
long the
water.
decubitus ulcer takes to heal?
7 to 8 days is the
Why do you want to put her on pessary for 1 month or even more than that? And why do you want to teach her all these things?
If she doesn't want to get admitted, it could be an alternative for a certain amount of time. Not exactly 1 month, but for a
No, it
certain
was
amount of
only a
time.
palliative for time being, but when we were talking about decubitus ulcer healing, and she is not ready to be admitted for say 7 days prior to surgery. So that was the question. So you are not supposed to teach pessary insertion to the patient. In fact, you will have to learn for a number of times so that the pessary remains in place. Okay, so the purpose is healing of decubitus ulcer. The question was for that.
You judges.
Yes.
What other preoperative
is left?
What other preoperative management is required apart from repositing the cervix to take care of the decubitus ulcer? What other preoperative measures are taken before posting off for
Basic
surgery?
blood investigations along with a focus on basically urine routine investigations should be done in order to rule out any UTI if it is there. And accordingly, antibiotics should be started to the patient preoperatively as well. And if the patient is anemic or from a poor condition, all those things also have to be corrected as per the blood investigations and the reports.
And what surgery do you plan? Is it always surgery that you are going to offer to this patient or any other line of treatment?
In her case, I would either we could go for, if the patient is not willing for surgery, we could ask her for physiotherapy or Kegel's exercises to be done, but that will not completely be the cure of the prolapse in this condition, in this patient, particular patient. So we'll have to opt for surgery if the patient gives consent for the surgery.
What type of surgery you wanted to do?
So
Young
since this
patient, 27 years old.
Since her family is not complete, I'll first ask her about future childbearing and her needs. Accordingly, we'll plan the surgery. We would opt for a sling operation in this particular patient.
Okay. What are the ideal prerequisites of any sling surgery?
So the uterocervical length is, there is elongation of the, in sling surgeries, we prefer that the patient has a good abdominal muscle tone if we are planning sling surgery for the anterior compartment surgery, like Purandare's sling. There should be a good abdominal tone. And
we are asking about the uterus, local genital organs. Preferably, the uterus should be of absolutely normal size, with a normal uterocervical length. There should not be any cystocele, rectocele, entocele. If it is there, that should be minimum 1. And if at all it is there, you have to repair that and then you go for a sling surgery. Okay, there should not be any other uterine pathology like a fibroid or adenomyosis or that type of thing even. It has to be a normal, because this sling surgery you are doing for conserving the or preserving the fertility of the patient. So what type of sling is more ideal? And this is the only one place where the Indian contribution is maximum, rather I will say 100%. Sling is the only, otherwise everywhere. Ward-based hysterectomy we all do, that has come from somewhere else. But slings, yes, 100% contribution by Indian gynecologists.
Yes, sir.
So what do you think, which sling is ideal?
Shirodkar's posterior dynamic sling could be the option, or Virkud's sling.
most ideal sling is which keeps the uterus in its normal position, antiverted and antiflex and its normal site. The surgery which is going to preserve all these three things, the position which is normal, the uterus is antiverted and antiflex. Any surgery which is doing 1, 2, 3, that's the most ideal. And this is done by one operation that is called as Schrodinger's posterior sling surgery. That's the most ideal operation because this is the only operation that keeps the uterus antiverted, antiflex and absolutely in its original anatomical position.
Sorry to interrupt this interesting discussion, sir, but only 2 minutes are left. And on behalf of all exam going students, I would like to ask Dr. Deshpande, sir, to give us some few questions so that our students will have edge over the other students. Sir, please.
Okay.
This was only for 30 minutes. This was for only 30 minutes.
Short case because it's a nulliparous. Okay. I mean, see, slings basically we divide them into three types. One is dynamic sling, which we hardly do now. That's a Purandare's one. Second one, there is a static sling, which is the Schrodinger's posterior sling operation. Complete Schrodinger's basically, with creating a sauce muscle loop on the left side and passing the Marcelin tape through that, so that absolutely 100% suspension of the uterus without any problem or compromising function of any other pelvic organ. Again, most important thing, the bowel, the ureter, nothing is going to be disturbed by this sauce loop formation. That's most ideal one. And the third one is composite. This is by Dr. Ajit Virkud sir from Mumbai. So Ajit Virkud, on one side he has done the static sling and other side he has done the dynamic. So instead of sauce loop formation in the left side, he has done the same way what Dr. Purandare has done. So Schrodinger's on right side and Purandare on left side, that's a combination, is by Dr. Ajit Virkud, and this becomes a composite sling. Dr. Khanna's sling is also static sling because you are going to tie this particular cervix posterior part with Marcelin tape to the anterior superior iliac spine. Dynamic sling is only one. That's a Schrodinger's, where you are tying it to the rectus as laterally as possible and passing the tape through the rectus abdominis muscle. So the moment patient cough, laugh, sneeze, automatically when that rectus abdominis become tight, the cervix is going to be lifted up. And just put a speculum, ask the patient to cough, you can make out that the Purandare sling is working very well. But initial Purandare's problem, it was attached either the fascia strips or the Marcelin tape anteriorly. And obviously when the patient become pregnant and she need a section, dissection of the bladder, at times detachment of this particular tape, everything that they were problem. So attaching the Marcelin tape posteriorly to the cervix was the best option, and that has been achieved by many other people who are doing the sling. Even Schrodinger's also attached the Marcelin tape to the posterior part of the cervix, right? So problems with sling. One more sling is there, that is by Dr. Vivek Joshi, a very close friend of mine from KEM Hospital, Pune. Attaching this particular cervix to the iliopactineal ligament, retropubic space dissection, which he does very routinely, along with birch corpus suspension wherever needed. Actually, Vivek is very much famous in Pune for his birch corpus suspension. The golden surgery, I always say, wherever it is needed. And then obviously Dr. Neeta Varati's laparoscopic sling, which eventually everybody is going to perform in the future. Because opening of the abdomen will be restricted only for cesarean section. Rest of the all things, they are going to be done by laparoscopy in the future, remember. So do laparotomy for cesarean and do scopy for rest of everything. So even sling can be done by Dr. Neeta Varati's sling. In fact, it goes on her name, but many people have modified it. That is a different story. So many laparoscopic surgeons on their own, they have modified some steps and it becomes on their name sling surgery, either for the nulliparous prolapse. Sir and Pushpa madam, please take over.
You have covered it well, sir. Best wishes from us.
Thank you. To you also, ma'am.
Yes.
Because
it was a blessing.
The committee which I enjoyed for 3 years, please take over it.
Thank you. Thank you.
Thank you.
Yes, due to time constraint, we have to wind up. Thank you, Tejas, for chairing this session. Thank you, sir.
Thank you. All the best to all
Thank
exam going
you.
students.
Thank you very much.
Thank you.
Thank you, NOGS and NKP Survey, for involving me
NKP.
in this talks.
Thank you, the organizers,
Okay.
NOGS team. I always say they are the most dynamic people I have seen in it. Forget that it is Nagpur is my Sasurwadi, and you have to praise your Sasurwadi. Other than that, I always say yes.
Thank you, sir.
NOGS
Thank
is
you
the
so
best
much.
team.
Thank you, sir. Thank you so
Yes.
much.
Thank you. Thank you so much for inviting.
Thank you, Anil sir.
Thank you, sir. Thank you.
Thank you.
For students, we would like to share our POPQ classification video. Okay. Due to time constraint, time restrictions, we would share it in the evening. Now, moving ahead, we have our next session, which is on table viva. Participants are Dr. Vaidehi Chaudhary from NKP SIMS Nagpur and Dr. Shreya Singh from IGGMC Nagpur.
Hello.
The faculty for this session are Dr. Shubha Jaju ma'am, Dr. Savita Somalwar ma'am. I would like to invite Dr. Shubha Jaju ma'am for this session. Dr. Shubha Jaju ma'am is Associate Professor at MGIMS Sevagram, worked as a unit head in OBGY, presented papers in national and international conferences and published many articles in national and international journals. She has many achievements. To name a few are, she has got a presidential rotating trophy of Foxy for 2010-11 Varanasi, Dr. D.K. Tank RCH Services in Rural Area Trophy for the year 2010-11, Save Girl Child Trophy 2011, Hyderabad prepared CD for the same, and Savitribai Phule Award in 2010. I welcome you, ma'am, for this session.
Yes, thank you so much.
Welcome, ma'am.
Thank you so much.
Our next judge is Dr. Savita Somalwar, ma'am. She is Associate Professor in Department of OBGY NKP SIMS. She has many national and international publications to her credit. A certified instructor of American Association of Family Physicians for basic life support in obstetrics and advanced life support in obstetrics. Received award for CIMP examination. Trainer of PPIUCD program. I welcome you, ma'am, and we can begin with the session. Dr. Vaidehi, are you there?
Yes, ma'am. Yes, ma'am.
Slide for you. Dr. Jaju, ma'am, please, please start with the session, ma'am.
Yes, I have supposed to show you the two instruments. One, I should ask them to identify.
Yes, ma'am.
Yes, for the students.
Vaidehi,
ma'am.
This instrument.
Yes, ma'am. This is an angulated scissor, metallic scissor, known as the episiotomy scissor. It has two blades. That is the one is the blunt blade and one is the sharp end. The blunt blade is basically between the fetal head, between the presenting part and the perineum, so that there is no injury to the fetal head. And it is angulated because so that it doesn't come against the bulging membranes. So it is being angulated, and it has also the finger rings at the proximal end.
This is not the ideal. What is the difference? Ideal finger rings should be
actually in the same direction, so that it doesn't comes against the near and against the bulging membrane.
So when you will give the episiotomy? Ideal episiotomy?
Ideal timing for episiotomy is when there is just prior to the crowning, that is 3 to 4 centimeter, the fetal head is being seen. If we give prior to the, if we give early episiotomies, so there can be bleeding, there can be excessive bleeding, and if we give late, so there can be some perineal tear also, as well as it can extend to the rectum end also.
So what if it is if it extends to rectum? What is it called as?
It is type 4 perineal tear. If it
Okay.
extends.
Then what are the types of episiotomy? So prevent it. How will you prevent these tears? By giving episiotomy. So what are the various episiotomies?
The types of episiotomies are the median episiotomy, then we have the mediolateral episiotomy, then the lateral episiotomy, and the J-shape episiotomy. Most commonly, we use the mediolateral episiotomy and the midline episiotomy. In the median episiotomy, we give the episiotomy from the midpoint of the foresheet, and it extends at least to 2.5 centimeter from the anus downwards. And in mediolateral episiotomy, it starts from the midpoint of the foresheet, and we go either to the left or the right, 3.5 centimeter away from the anus. Whereas
what
in
structures cut? What are the structures cut with this instrument?
First of all, we cut the perineal muscles, the vaginal mucosa, then the perineal muscles, and the fascia covering these muscles, then the pudendal.
They are
Yes.
cut simultaneously. So suturing is in layers, but all structures are cut simultaneously. So what are the structures then? Cutting vaginal mucosa, pretty good. That is correct. Then
the transverse perineal muscles like bulbospongious muscles, and then the pudendal vessels also are being cut, and the vaginal epithelium, and the skin and the subcutaneous tissue.
pudendal vessels are at what level?
At the
they will come in this area.
The ischial.
Okay, that is at the ischial spine level. So, so how will you now suture the what anesthesia is given, and what are the layers sutured, and which are the material used for suturing?
Yes. First of all, we in prerequisites we have to look for all the we give the local anesthesia, that is 10 ml in of 1% dignocaine solution is being infiltrated, and with the antiseptic solution we clean and drape the perineal area. And then after the infiltration, we give an episiotomy just prior to the crowning, that is 3 to 4 centimeter the fetal head when it is seen. And when there is at the height of uterine contraction, we give the episiotomy. And afterwards, then for the repair, we just remove all the blood clots from the vagina. And again, we clean and the area with the antiseptic solution, and it is being sutured in 3 layers. The
So
first
vaginal-
is
Hmm.
yes, ma'am. It is sutured and closured in the 3 layers. The first is the vaginal mucosa is being sutured. The apex is being secured by the chromic catgut suture, absorbable suture, and the apex is being above the apex, that is 1 centimeter above the apex. We secured the by the suture, and then we close the vaginal mucosa by the continuous catgut sutures, and then we till the foresheet. And then afterwards, we take the muscles, then we suture the muscles interruptedly by the chromic catgut. And then we at the end, we close the skin and the subcutaneous tissue.
With
The
skin
mattress.
mattress, not
the mattress.
continue. Now what is there?
But can we move to next slide because of time restriction?
Okay. Now which is this instrument?
Episode.
Sponge holding for
This is the grasping instrument, long metallic scissor, forceps. Sorry, forceps. This it has the proximal end and the distal end. This is then sponge holding forceps, And it has in the proximal end, we have the finger rings, the rachet, then the shanks, then in the middle locks, and then the jaws and the tips. The rachet are basically for the locks and unlock the thing, and the serrations are present
at the tip. What serrations are there? What is the purpose of serrations?
Serrations are due to for the to grasp the thing what.
Yeah. So though it is called as sponge holding, but it is used for many purposes. So what are the other uses of this instrument?
It is mainly used for to clean and drape, to hold the sponge or the gauze piece to clean the surgical area, surgical site, to clean the vulval and vaginal perineal area also with the antiseptic solution what we use, and also to hold the anterior lip of the cervix. Mostly in the gravid uterus, as the cervix is very vascular and soft, so we use the help of the sponge, as it is not as it doesn't have any pointed edges. And also then for the post placental PPIUCD insertion also we can use the sponge holder. And
when there is cerclage, and two times it can be used for the cerclage as well as to explore the uterus cervix for any tear.
For any cervical.
Then
also in for the packing of the omentum and the intestine, we can use sponge holding forceps. And
when the green hermitage is not available by chance.
Not available, yes.
Green hermitage is not available, that time also you can use it. Then any other use in hysterectomy?
In hysterectomy, to hold the infundibular pelvic ligament, we can use as a clamp for holding the infundibular pelvic ligament.
And we cut the fascia, utero-vesical fascia, and then
we can clamp it.
Yes, you can take down the bladder with this, and the surgery can be proceeded. Anything else? Can it be used to take out the products of conceptions?
Products of conception, sponge holding.
Yes. Then how it differs from ovum forceps?
Ma'am, it is actually the ovum forceps is oval in shape, and it has the midline.
It is oval in shape. Then the most important difference. What is the most important difference?
It does not have the ratchet.
Yes, that is it. Does anybody want to ask?
Ma'am, can we please summarize the thing from exam point of view for PG student?
Yes. So these two instruments are very commonly used. First was for episiotomy. That is angled, we know, and the purpose of angle is also known. And then this sponge holding instrument, this is many purpose instrument, though mainly used for cleaning and draping. The general use can be for that, and in gynec purposes, this is used if there is we are doing something and there is a brisk bleeding. We can for some time, this can be the bleeding can be stopped by pressing it. So these are the various instruments. These instruments are thus very useful, and you should know them thoroughly. That's all. If you can add.
Thank you, ma'am.
Thank you so much. Welcome.
Our faculty judge for our next session is Dr. Somalwar ma'am from NKP Sims, and
Dr. Shreya, I think, is the student, na? Dr. Shreya.
Our presenter for the table Viva is Dr. Shreya Singh. She is from IGMC Nagpur. Shreya, are you there?
Yes, ma'am.
Ma'am, we'll go ahead with our first slide. Shreya, you have 10 minutes, 5 minutes for each for the specimen. Okay. Can we proceed with the table Viva, ma'am?
Yeah.
Sumal ma'am?
Yeah. You display the slide, na, please, Sayukta.
Sorry, ma'am.
We are not able to see the slide. Yeah.
Ma'am, is it visible now?
Okay. Yeah, it is visible.
Shreya,
Yeah.
can you see the slide?
Yes, ma'am.
Yeah, we can see. Yeah. Yes. So, Dr. Shreya, we will go one by one for the each drug. Okay. So first, tell me regarding the norethistron. Okay. Which is the class of this drug?
Ma'am, it belongs
Norethistron.
to a synthetic progesterone group, also known as progestin.
Okay. What is the difference between progesterone and progesterone?
One is the natural progesterone and one is the synthetic progesterone.
Yeah. So progesterone is synthetic progesterone. In which group of the means it is 19 non-testosterone derivative. Okay. Norethistron is a synthetic progesterone. No? There are two groups. It can be progesterone derivative or 19 non-testosterone. Okay. So norethistron is 19 non-testosterone. Can you tell me mechanism of action of norethistron? How it acts?
Ma'am, it inhibits the estrogen receptors on the endometrium. It also converts the more potent estradiol into less potent estriol. It also has antimitotic activity, and it also helps in anti-estrogenic action. It also has an anti-estrogenic action.
Okay. So as you rightly said, it converts it into less potent estrone. Okay. It also prevents angiogenesis, na?
Yes.
Angiogenesis, and it leads to endometrial atrophy. Okay. Can you tell me the indications of its use in gynecology?
Ma'am, in gynecology, we use it as in cases of abnormal uterine bleeding, as an oral contraceptive, in premenstrual disorders, in patients of endometriosis. It can also be used as a part of hormonal replacement therapy in menopausal women, and also to delay menstruation.
Okay. Can you throw some more light on AUB? Which AUB? AUB is a broader terminology,
yes.
Na? So in which AUB?
It is useful in endometrial causes of abnormal uterine bleeding.
Any other?
Using this drug helps in reducing menstrual blood loss by approximately 40%. And
so in abnormal uterine bleeding, ovulatory dysfunction, either it can be ovulatory DUB or anovulatory. Okay. So it is said to be a second line drug, first line drug in cases of ovulatory AUB. Okay. It can be used in both ovulatory as well as anovulatory, both things. Can you tell me what is acute AUB and chronic just mentioned?
Acute AUB is the presentation is within a short span of time. There is a heavy menstrual flow. And for that, we give conjugated equine estrogen. And chronic AUB occurs over a period of time.
Okay. Acute requires immediate intervention to arrest the bleeding. Okay. And chronic patient may have a history of 6 months. Okay. So it decreases the blood loss by around how much percent? 40 to 50%. You said. Norethistron?
40 to 50%.
What is its effect on lipid? Okay. What is its effect on serum lipids?
It is known to increase the LDL levels and decrease the HDL levels.
Okay. Increase the LDL, na? Increase LDL and decrease the HDL. So any other progestogen you know which does not alter the serum lipids, although it is not displayed here in the slide?
Ma'am, 4th generation progesterones.
4th. Any other option? Like 4th generation, whether we use mostly it is for the oral contraceptive pills, na? Like 3rd, 4th generation. So medroxyprogesterone, have you heard medroxyprogesterone? So that can be used, but commonly we use this in cases of acute AUB. What is the dose in AUB, acute AUB, to control the hemorrhage?
It can be used in the dose of 5 to 10 milligram given TDS for a period of 21 days, starting from day 5 of the cycle till day 25 of the cycle. And this is given for 3 cycles.
So in acute cases, the dose started usually is 5 milligram, 2 tablets, 3 times a day. 10 milligram 3 times a day. And then you usually give for 7 days and then you decrease the dose. No, you decrease the dose. Okay, because the bleeding will be stopped and because of the side effects, the same dose will not be required for continuation. Can you tell me what are the contraindications for use of norethistron?
It should not be used in thromboembolic states, in patients of breast cancer, or wherever we have undiagnosed vaginal bleeding.
Okay, so if you are suspecting pregnancy, if the patient is having a breast cancer, liver disease or tumor, again this drug is contraindicated, or if there is a history of IHT. Okay, what are the side effects?
It could lead to weight gain, water retention. It could lead to androgenic side effects like acne, hirsutism, virilism, loss of libido. It could cause breast engorgement or mastalgia.
Breast pain. Okay. Again, mood swings.
Irregular menstrual cycles, mood swings, depression.
Okay. Okay, so this drug is, to summarize, this drug is usually useful for treating the acute AUB cases, that is ovulatory dysfunction. That is very, very important drug to control the bleeding. Apart from that, you did not say, but in again fibroid, no? If the patient comes with the acute episode of bleeding, again this drug can be useful. You said menopausal hormonal therapy, but we usually prefer medroxyprogesterone acetate in that. Apart, not the norethistron. Okay. And as you rightly said, it can be used in endometriosis. And one indication you did not mention is endometrial hyperplasia without urticaria. This is the drug of choice in perimenopausal women. Okay, we will go ahead to the another drug. So we will go to the tranexamic acid. So which class of drug this is? Tranexamic acid?
It is an antifibrinolytic agent which helps in preventing bleeding. Its mechanism of action is that it inhibits the plasminogen activators, which cause inhibition of plasmin. So thereby preventing bleeding.
Okay. Indications of its use?
We used to control bleeding. It is used in gynecological as well as obstetric purposes.
Very good.
Gynecology, we use it for controlling abnormal uterine bleeding, or in IUCD-induced bleeding, or in patients where who have undergone surgery or trauma. It is also used in the treatment of von Willebrand's disease. For obstetric purposes, we use it for the management of postpartum hemorrhage. WHO has recommended the use of tranexamic acid in intravenous form within the class of
dose of
dose is 500 milligrams to 1 gram, given thrice a day or 8 hourly per day. For AUB, we give it for the duration of menstruation, usually for 5 to 7 days. And for preventive purposes, we first start in the IV form. Later on, we switch on to the oral.
So this is US FDA approved second line agent in cases of ovulatory AUB. So it is approved by the US FDA for ovulatory AUB. Okay. Can you tell me the contraindication? Very important to know the contraindication of using tranexamic acid.
Sorry to interrupt you, ma'am. Can we please summarize it?
Yeah. So I will tell that it is contraindicated if there is a history of thrombosis in the patient, and if there is impaired color vision, then it is contraindicated. Okay. And another thing I wanted to tell is it can be used in fibroid uterus also to control the bleeding. Shreya, that is an important thing. Now coming to the last drug, we will cover it very shortly. Yeah, Sanyukta.
Yes,
mefenamic acid.
Mefenamic acid belongs to non-steroidal anti-inflammatory drug agent. It helps by decreasing the levels of progesterone by inhibiting cyclooxygenase enzymes. Because bleeding is endometrial bleeding is mediated by prostaglandins. It also reverses the ratio of vasodilatory and vasoconstrictive prostaglandins, thereby helping in preventing bleeding.
How much bleeding is reduced by mefenamic acid?
Ma'am, 25%.
25 to 50%. The bleeding will be reduced by use of the mefenamic acid. Dose used is how much the dose?
500 milligram TDS.
Okay, for 3 to 5 days during the menstruation. Then what are the uses apart from AUB?
For dysmenorrhea, we can use it.
Very good. So it can be used for the dysmenorrhea in cases of ovulatory abnormal uterine bleeding, as well as also it can be used in fibroid uterus to decrease the pain also, like there may be spasmodic dysmenorrhea or congestive, and for also decreasing the bleeding, not only pain, but bleeding in cases of the fibroid uterus. Can you tell me the common side effects first, Shreya?
Nausea, vomiting, gastrointestinal symptoms.
Okay. Yeah. Gastric ulcer, some perforation, gastrointestinal bleeding can be there. Contraindication? Where we will like to avoid commonly.
And where in patients who have bleeding disorders.
Yeah, very good, because it leads to thrombocytopenia. And bronchial asthma also. It may exacerbate the bronchial asthma. If the patient is an already known case of peptic ulcer, then you should not be giving this drug. Okay, so mefenamic acid is again the good drug along with the tranexamic acid in cases of ovulatory abnormal uterine bleeding, and it also has the advantage of treating the dysmenorrhea also. So I hope we have covered all the things because the time is short, and norethistone, as I have already said, is a good drug for the controlling the acute abnormal uterine bleeding. Okay. Thank you, Shreya.
Thank you, Shreya, for good table viva. Thank you, Dr. Savita Sumalwar, ma'am, for sharing your guidance and for giving your precious time to judge this session. Thank you so much, ma'am.
Thank you.
We'll shift to our next session, which is a case presentation on heart disease in pregnancy by Dr. Bhagyeshri Bhanushali from GMC Yavatmal. And our faculty judges are Dr. Surekha Tayde, ma'am, Dr. Ashish Zararia, sir, and Dr. Rujuta Fuke, ma'am. I welcome you all, judges.
I would like to welcome Dr. Surekha Tayde, ma'am, for chairing this session. Surekha Tayde, ma'am, has a vivid CV, and she is a professor and unit head at JNMC Nagpur, Savangi. She is West Zone Coordinator of Practical Obstetrics Committee, FOXY. She has many publications, around 108 in national and international journals. She has chapters in books, publications, and she is past president and secretary of Sevagram OBGY Society. I welcome you, ma'am, for this session. Our next judge is Dr. Ashish Zararia, sir. He is associate professor OBGY at GMC Nagpur. He worked as a unit in charge at Kama Hospital, JJ Group of Hospitals, Mumbai. He has 20 national and international publications. Is practicing critical care obstetrics since 50 years, is a member of advisory committee to Ministry of Health and Family Welfare, Government of India for developing and expanding obstetric ICU and HDU facilities in India. We welcome you, sir. Our next judge is Dr. Rujita Fuke, ma'am. She is an associate professor in GMC Nagpur. She has undergone training in colposcopy at CNCI Kolkata, fetal medicine training at BFMC Bangalore. She has many achievements and awards on her name. To name a few, she has received Dr. Rangilal Singh Memorial Award, Dr. Late Sundrabai Kunwar Memorial Award. She has delivered prestigious UA NOGS oration in 2015. She has worked as a nodal officer for facility-based maternal mortality review committee for 5 years. Her areas of interest are high-risk pregnancy, fetal medicine, preventive gynecology, and oncology. I welcome all the judges for this session.
Thank you. Thank you so much.
Welcome, ma'am.
Dr. Bhagyashree, are you there? Please share your screen and start presenting your case. Dr. Bhagyashree, are you there? Bhagyashree, please unmute yourself.
Yeah, yes, ma'am.
Start sharing your screen and start your presentation. Stop sharing.
शेयर नहीं कर पा रही हूँ इधर से.
Bhagyashree,
Hello.
could you share your screen?
Yes, ma'am. Just a second.
Recording in progress.
Hello. Hello.
One device.
Hello, ma'am. I'm not able to share this screen.
Your sound is echoing, Bhagyashree. Please log in from one device.
Hello, ma'am. I'm not able to share the screen.
Yes. Please. There is an option on share screen.
Yes, ma'am.
Open it in your background and then share your screen.
Okay, ma'am.
Open it in background and then start sharing your screen.
Yes, ma'am. Yes, ma'am.
Hello, Surekha ma'am. Hello, Rujita.
Hello. That's what I was saying, that we should start commenting. I think Bhagyashree, if you have problem, you can send it by mail also to the organization.
Okay,
Or you can just read it out. No
Okay,
problem
ma'am.
that you can't share the screen.
Okay, ma'am.
Read out कर ले फिर मैं. Read it out. Read it out.
Is it fine if I read out? Ma'am?
Yes,
Hello, ma'am. Is it fine if I read out?
Yes, yes.
It's
Okay.
fine.
Sorry, ma'am, for the
No problem. But you open your video, no worries.
Okay,
Don't
okay, yes,
be afraid.
Yes.
Yeah.
Yeah.
Yes,
Good afternoon, everyone. I'm presenting a case on heart disease in pregnancy. My 20 years old patient, Mrs. XYZ.
You can also say pregnancy associated with heart disease.
Yes, ma'am. A 20 years old patient, Mrs. XYZ, married since 2 years, homemaker, resident of Yavatmal, educated up to 8th standard, belonging to lower socioeconomic class by modified Kupus Farmer scale. Primary gravida with 8 months of amenorrhea, with last menstrual period had on 27 June 2021. EDD is 3rd April 2022, according to Nicholas formula. At present, gestational age is 33 weeks, 6 days. Presented with chief complaints of breathlessness on doing ordinary work since 15 days, palpitations on doing ordinary work since 10 days, swelling over both the legs since 15 days, easy fatigability since 10 days. History of presenting illness. Patient gave history of feeling breathless and palpitation on exertion since last 1 month, and she was able to do her daily ordinary activities without any difficulty.
So because you're not having any screen share, read it little slowly, okay?
Okay, ma'am. Sorry, ma'am.
Yeah.
Since last 15 days, those complaints have increased to an extent that the patient is not able to perform a routine activity, which is also associated with easy fatigability since 10 days. She also complains of swelling over both the legs since last 10 days. No history of chest pain, giddiness, syncope, loose discoloration of extremities. No history of nocturnal cough, paroxysmal nocturnal dyspnea, orthopnea. No history of fever, cough, cold, or any bowel or bladder complaints. No history of pain in abdomen, fetal movements, leaking per vaginum, bleeding per vaginum. No history of headache, blurring of vision, epigastric pain. Past history. History of occasional episodes of fever associated with joint pain in childhood, revealed on some medications. Details not available. No further evaluation was done for the same. No history of similar complaint in the past. No history of any major medical surgical illness. No history of blood transfusion, previous hospital admission.
Major surgical illness, you said she is not a known case of heart disease?
Ma'am, she don't know anything about it. She just had fever, which is suspicious of rheumatic heart disease and joint pain.
She's 36 plus 6 weeks. Did you say that?
33 plus 6 weeks.
33, and primary, you're saying that she's having acute rheumatic fever presently.
No, ma'am, she had.
She had in the past. How many in the childhood?
In the childhood, she had a history
of.
But
Wasn't diagnosed. Is she a booked case?
No, she's not a booked case.
So initially in your demographics, you have to tell us that she is booked or not booked. Okay, that's very important when you talk of any demography or clinical presentation. So that means the patient has come to you for the first time. She is undiagnosed, not a diagnosed case.
Not a diagnosed case, ma'am. Not a booked case and not a diagnosed case. She was booked at PHC, but not to any tertiary care center.
Okay, go ahead.
Yes, ma'am. Menstrual history. Age of menarche is 13 years.
What about her whole history of her pregnancy? What is the course of her pregnancy? Like you said, she was booked in the PHC. What all happened after that?
She has an ANC registered at PHC at 16 weeks. She had given tetanus toxide and calcium and hematinic supplements. An anomaly scan was done, which was at 18 weeks. It was in normal limits. ANC profile was done, complete blood count and routine investigation, URM, urine routine microscopy and urine culture sensitivity, which was normal.
Okay.
At PHC, ma'am.
Tell me one thing, is it usual, do you think that it is usual that the pregnancy and the cardiac disease which is associated with pregnancy is masked till 33 weeks of gestation? What are the gestational periods when these kind of cardiac lesions will be revealed? And what is the reason?
Ma'am, starting at 12 to 14 weeks in second trimester, and then 28 to 32 weeks. Majority.
Why? What are the reasons?
Ma'am, the changes in plasma volume and cardiac output starts at 12 to 14 weeks, and it gets acute at
12 to 14 weeks, not 12 to 14 weeks. Prior to that also, you will find that the plasma volume has started rising.
Yes,
so any lesion which is there, a cardiac lesion, is bound to get revealed if you auscultate well, if you look for the signs. Okay, now tell me, what are the physiological changes which resemble a cardiac disease, and because of which you may miss the cardiac lesion, or you are in a dilemma?
Okay, ma'am, there is a history, breathlessness, syncope, exertion, pedal edema, which is normal in pregnancy, and it is associated with cardiac lesions also.
Signs?
Signs, ma'am, raised jugular vein.
What are the common signs which mimic? They are there in pregnancy and they could be in cardiac disease also. Commonly, they are in pregnancy.
Venous hum can be murmur.
Rutuja, your mic, you're on mute. You want to say something?
Yeah. Sorry. I was asking, are there any auscultatory findings that resemble physiological changes and that resemble
loud S1, splitting of S.
Usually loud S1 is pathological. See, is there anything?
Ma'am, ejection systolic murmur can be there because of plasma cardiac output, increase in cardiac output.
Right.
There can be S3 sound can also be heard in pregnancy. Rare possibility, but it can be
S3 gallop.
S3 gallop can be heard. Grade 1 and 2 systolic murmur can be heard, but if it's diastolic, then it's always a pathological thing.
So that comes the next question. How will you differentiate between these physiological changes with the pathological changes of heart disease, I mean pathology of heart disease?
In auscultation, ma'am?
Yeah.
See, you have to start with the
apex. You have to start from the examination.
Yeah,
symptoms,
start
then
from
signs,
general examination, go to your cardiac examination. In cardiac examination also, you have to start with the apex beat, the shift of the apex beat laterally and upwards. What happens to the systolic the systolic murmurs, where they are seen. Okay, right heart border, left heart border, presence of diastolic murmur. So go systematically so that you don't miss anything.
Okay, ma'am. In inspection, there can be
I think 2 devices are working. Your 2 devices are working.
Only one is working.
Okay. The sound is.
Yeah, so because we are having an echo from your side. So if you have a computer and a mobile phone, you switch off your mobile phone.
It's only computer, ma'am.
Okay, let it be. Just continue.
Okay, ma'am. In inspection, there can be
yeah, go ahead.
Hello, ma'am.
Yeah.
There can be thrill can be present. Apex beat is shifted towards lateral to mid clavicular line. Generally, it's medial to mid clavicular line. If it's
apex beat. You are saying apex beat.
Yeah, ma'am.
Okay. Thrill is usually on palpation, not on inspection. Right. So all the symptoms, start with symptoms. All the symptoms of physiological changes during pregnancy that will be exaggerated in the heart disease.
In the heart disease.
Right.
Pedal edema, which is not subsided on breast, ma'am.
Right. That is pathological.
That is pathological. Generally, it's subsided on breast in normal pregnancy, but it's subsided on rest, then it's a.
Right.
There can be a cyanosis in cyanotic congenital heart disease, which is not a normal finding in pregnancy.
So cyanosis is the definitive sign of some heart disease.
Some heart disease.
Right.
Yeah.
So systolic murmurs, grade 3, diastolic murmurs.
Sorry, ma'am.
Systolic murmur, grade 3, diastolic murmurs.
Right.
Presence of atrial fibrillation or flutter. These are all then definitive enlargement of the heart, the cardiac enlargement.
And
these are all cyanosis. These are all definitive signs of heart disease. Okay. Now let's go ahead with you complete your history and then we can quickly.
Ma'am, obstetric history. Patient is primary gravida, spontaneous conception. ANC registered at PHC at 16 weeks. Received 2 doses of injection tetanus toxide and calcium and hematinic supplements regularly. Routine ANC profile within normal limits. Anomaly scan done at 18 weeks with normal limits. Total weight gain in pregnancy is 9 kg with pre-pregnancy weight of 47 kg. In pregnancy, in present pregnancy, first and second trimester were uneventful. Third trimester, patient developed complaints of breathlessness, palpitation, easy fatigability, and was referred to tertiary care center for further evaluation. Person history: consume mixed diet with a total intake of 2,500 kilocalorie per day. Sleep, bowel, and bladder habits are normal. Appetite good. No history of any addiction. No history of drug allergy. Family history: no history of hypertension, diabetes, asthma, TB, heart disease, and pregnancy. General examination: general condition is fair. Patient is conscious, cooperative, time, place, and person. Average build, adequately nourished. Weight 56 kg. Height 155 centimeter. BMI 23. Patient is febrile at present. Gait is normal. Orodontal hygiene is maintained and no signs of nutritional deficiency. No stigmata, evidence of fresh rheumatic activity. No pallor, ictus, clubbing, cyanosis, thyroid swelling. Bilateral breast normal, soft or no discharge at present. Bilateral pedal edema fitting, type grade 1 is present. Pulse is 84, regular, good volume, equally felt in all 4 limbs. No radial or no radiofemoral VA. BP is 120 by 80 mmFg. SpO2 is 98% in room air. Respiratory rate is 16 per minute. We'll go to systemic examination now. Cardiovascular system inspection. Test symmetrically bilaterally. No dilated veins, scar seen. No visible pulsation seen. Palpation apex beat felt in fifth intercostal space. Just medial to mid clavicular line. No thrill present. Auscultation loud S1 and normal S2 is present. Mid-diastolic murmur heard in mitral area. Weight 2 increase in expiration. Opening snap is present. Respiratory system. Bilateral vascular breath sounds present. No adventitious sound heard. For abdominal examination, ma'am. Done in supine position after emptying the bladder and correction of dextral rotation. Linea nigra and stria gravidarum is present. Umbilical is flat. Uterus 34 weeks in size. Symphyzofundal height 34 centimeter. Abdominal girth 86 centimeter. Longitudinal lie. Cephalic presentation. Vertex and epictus is 140 per minute regular. Summary of my case. 20 years old primary gravida with 33 weeks 6 days gestation by date and 33 weeks 4 days by dating scan. Complaint of breathlessness, palpitation, easy fatigability on ordinary physical activities and persistent swelling on both the legs. This is not relieved on rest. NYHA grade 2 with childhood history of occasional fever and joint pain. CVS examination suggestive of loud S1 and mid-diastolic murmur. Diagnosis: primary gravida with 33 weeks 6 days gestation by date and 33 weeks 4 days by dating scan. With single live intrauterine gestation, with cephalic presentation, with heart disease under evaluation, most likely to be rheumatic in origin, at present not in failure, and not in labor for further evaluation and management.
Okay, so according to you, at what stage of this NYHA classification
I'm grade 2, ma'am.
Great. And what is the management for grade 2? What do you do for these grade 2?
Generally at 34 weeks, we admit the patient. We do all ANC routine examination like complete blood count.
Now, but what should be their antenatal period? And how should be their antenatal visits and everything? Hello?
She's logged off.
Yeah, she's logged off. I think some internet problem.
So we can answer the questions, whatever we are asking. I mean, that's
Whoever,
what is expected,
yeah,
I think.
Who are the other PGs who are attending, they can answer.
I think, ma'am, she must be having.
Sorry, ma'am, my loss of network, ma'am.
It's okay.
In there.
Yeah, ma'am.
Continue.
You said there are NYHA classification. How many grades do you know of?
1, 2,
NYHA
3,
classifications?
1, 2, 3, and 4. There are 4 grades.
What is grade 5?
5.
So do you know of a grade 5 in NYHA classification? Till now, everybody was knowing about grade 4. So for all PGs, there's a grade 5 also when your patient is on any ventilatory support and needing assistance for respiration. If she is having a kidney or other organic failure, that's considered as a grade 5. So please go and read grade 5. How do you do a risk assessment, and tell me Seuss index of risk assessment of cardiac diseases?
3 times we can do risk assessment. NYHA classification.
So say functional grading of the heart.
Functional grading. There is risk score, CU's risk score in pregnancy, and WHO.
Yeah.
Classification.
Right.
Yes, ma'am.
So tell me the risk assessment. What all do you do in CU's index?
Sorry, ma'am.
What all do you do in this risk scoring system? One is functional grading. Any other thing?
From WHO grading.
Yeah, tell me what are the characteristics which you see? One is functional state. Then you see the left ventricular systolic dysfunction. What should be the ejection fraction?
Ma'am, ejection fraction, if it's more than 40, less than 40%, grade 3 and 4, NYH grade 3 and 4, and mitral stenosis, mitral stenosis less than 1 centimeter area, and
Less than 2 centimeters. Less than 2, not 1.
Okay,
Aortic wall.
Aortic less than 1.5 centimeter, ma'am.
Okay. Outflow gradient.
Outflow, mean outflow gradient less than 30.
More than 30 millimeters of mercury. Okay, so that is how it is graded. And how do you decide prognosis?
Sorry, ma'am.
How do you decide the prognosis of these women? Depending on these grading risk assessment systems. Ashish, you can pitch in, please.
If zero score 1 and 5, 1 and 2. If 0 and
so mild, moderate grades.
So tell me if your patient is a case of mitral stenosis, which is a very common cause of heart disease in pregnancy in India. Am I audible?
Yes, sir. Yes, sir.
Yes, sir. Yeah.
And she comes into your category 2, class 2. How will you go ahead in antenatal period?
Antenatal period, sir, at the time of 30, if it's coming now at 33 weeks pregnancy. Yeah. Sir, first I will admit her. We'll do the whole ANC profile. We'll do ECG and echocardiography.
What do you do in ANC, routine ANC checkups? What advice you give and what extra precautions, I mean, you should take, or you should advise what extra things she should be doing in antenatal? Are the visits routine just like any other low risk, or they are intensive, they are more frequent? And what kind of advice you give? What are the warning signs? How do you teach them? How do you counsel them? And it is just the counseling of the patient or the people who are taking care of her. So that you have.
And some very important preventive strategies. You have to prevent certain complications.
Right. So we don't want infections in this patient. We don't want any kind of fever or all those things that will precipitate heart failure in these patients, right? We just don't know. Though she's great too. Yeah.
Yes.
Sorry to interrupt you, ma'am.
We will advise bed rest.
Short of time. Can we please summarize?
Okay.
No, we haven't. We have been given the podium late. Okay.
Yes, ma'am.
Already 20 minutes late you have given us.
Yes.
So because we have not asked her anything, and then it will not benefit the students who have joined in.
Yes, we have 2, 3 more, but yes, we have to summarize the case.
Okay, fine.
We'll give bed rest. We'll advise bed rest to her. First of all, salt restriction.
Okay.
If should not increase the plasma volume.
No, you won't advise her to do not increase plasma volume. No,
ma'am, not salt restriction, so that the plasma volume and the cardiac output doesn't increase because of salt, because of sodium reabsorption. That's why we'll advise that. And if there is heart failure, then we'll advise diuretic. Furosemide is given. First of all, we'll give counseling. The visits are frequent, not like a normal routine examination. If it's NYH grade 1, 2, then till 28 weeks, it's every monthly. After that, till 20 to 36 weeks, it's 2 weekly, bi-weekly, and in every 2 weeks, and after that, every weekly we. Now, am I audible?
Yes, you are audible. Yashri.
Okay. After 36 weeks, we advise to visit every weekly, so that the signs and symptoms doesn't miss out.
And what are the risk factors which can lead her to cardiac failure?
Yes,
So risk factors you're going to explain to her, right?
Yes, ma'am. If
These
she
risk
develop
factors are
paroxysmal
infection,
dyspnea,
anemia.
If she develop paroxysmal nocturnal dyspnea or orthopnea or palpitation, she should visit the doctor. And first of all, anemia, infection, any urinary tract infection, we should orodental hygiene should be maintained, so that it doesn't increase, infection doesn't increase.
Yeah, excessive weight gain, obesity, hypertension, hyperthyroidism, multiple pregnancies, all these infections, anemias, so these will worsen the condition. So you have to educate the patient about this. Okay. Now, what about this? Your patient is of mitral stenosis, right? Any role of any surgical interventions in cardiac diseases you know of?
Yes, ma'am. If there is a severe mitral stenosis, then balloon valvotomy can be done.
So can it be done during pregnancy? Do you want her to do it in the pregnancy period?
Ideally, it has to be done at 24 weeks. If it's severe, at the time of, if patient come at term, we can also do if the symptoms are very severe. We can do at term also.
What kind of valve you will prescribe her? What are the various kinds of valves? Which one is the best?
Prosthetic valve and mechanical valves are there.
Yeah, so biomechanical are there, bioprosthesis is there. So once if surgery is done, what drug is prescribed and which is must to give this patient who is having a prosthetic valve?
Ma'am, anticoagulants are given, ma'am.
What kind of anticoagulant you're going to prescribe? What is the recommendations?
Low molecular weight heparin.
So tell me, there are oral and there is injectable. Even in heparin, you have an unfractionated heparin, you have low molecular weight heparin. Till what gestational age is warfarin indicated? Is it indicated in the early gestational age?
No, ma'am.
Till how much?
Before 12 weeks. Before 12 weeks, we give heparin and low molecular weight heparin. Till 12 to 36 weeks, we give warfarin, because if we give warfarin at first trimester, there is chances of anomalies in baby. And after 36 weeks,
anomaly, or is it called as warfarin embryopathy?
Warfarin
and
embryopathy.
What are the various things which are visible when you say embryopathy?
What are the things which is okay? Now, frontal bossing can be there, stipple epiphysis can be there, optic atrophy can be there in baby.
Hypoplastic bone, sticking of the bone, IUGR, these are all seen. So how much dose of unfractionated heparin or low molecular heparin you're going to give until what gestational age?
Low molecular weight heparin is given till 12 weeks, and after that 36 weeks onwards.
Okay, there are various recommendations. You can even give the LMWH throughout the pregnancy. It's not that you should do this or that. Right. Okay, and then when will you stop?
Ma'am, till 12 weeks, and after 12 weeks we start with warfarin till 36 weeks, and after 36 weeks we again shift to low molecular weight heparin, and it is continued before 24 hours before pregnancy, before any elective procedure, or at the time of induction, or when the patient is in labor.
Because you said induction, tell me the role of induction in cardiac disease.
Ma'am, generally we don't induce the patient.
So that's why you should not say. Now you tell me what is the role.
Ma'am, generally we don't induce until we allow the patient to go in spontaneous labor.
What are the indications for elective LSCS and heart disease?
Sorry,
ma'am,
Sayukta is
summarize the principles of management, labor management in heart disease. Just summarize in 5 sentences the principles of management in labor.
In labor,
yeah. I mean, how the labor is different from a normal pregnancy.
First of all, we'll give propped up position to the patient. O2 is given continuously. Pulse, BP, and respiration temperature is checked every 15 minutes. And
Right.
will cut short the second stage of labor, ma'am.
Right.
So, yes, ma'am.
What about the management, fluid management? How do
Fluid
you
management,
monitor
ma'am,
fluid?
will
Yeah.
give diuretics, furosemide will be given because
Right.
it doesn't increase the cardiac output, and patients should not go in failure because it's because in immediate post delivery there are high chances of going to failure, cardiac failure.
Which
So we
type
give
of
and
heart
we will
disease
restrict the
you
fluid
keep
to
the
7
fluid
less than
management
75
on the
ml per
wetter
minute.
side?
Sorry, sir.
Which type of heart disease you keep the fluid management on the wetter side?
Sir, aortic stenosis. 125 ml per hour is given at that.
Right. And what about the second stage, third stage, post stage?
Okay, sir. Second stage will cut short the second stage of labor by ventus or forceps delay if necessary.
Third
And in
stage?
in third stage, control cord traction is given and placenta is removed. Will give oxytocin in diluted form. Misoprostol is given. Methergine is avoided, ma'am, because it can cause hypertension and vasoconstriction. So it's avoided.
What do you use for effective endocarditis prophylaxis?
Endocarditis, yeah.
Sir, in developing countries like India, we give infective endocarditis prophylaxis to everyone, every heart disease case, but it's not recommended. It's only recommended in mucosal.
It's recommended.
It's recommended.
It is recommended.
Not
Please go ahead
taken.
and tell us what is
Right.
given.
Sorry, ma'am?
What is the antibiotic of choice?
Ampicillin.
What organisms you are targeting?
Staphylococcus aureus, Streptococcus viridans. Ampicillin is, ma'am, preferred. If a patient is allergic to penicillin, then clindamycin is given, ma'am.
Only ampicillin will help, or you need to give something else?
Ampicillin and gentamicin. Gentamicin, sir. Ampicillin and gentamicin is given.
And it should be given in all patients of valvular heart diseases, all those patients who are operated case, even regurgitant lesions you have to give.
Okay, sir.
Majority of heart disease you have to give.
Family
How many days you will keep her in your ward? And why?
Ma'am,
What is the rule of 5?
Yes, ma'am. 5 in 5 minutes, 5 minutes, 5 hours, 5 days, 5 days and 5 weeks. In 5 minutes, patient can go into failure. And infection can, in 5 hours, infection can occur. 5 hours, heart failure can occur. 5 days, infection can occur, and 5 weeks, there can be 5 months, there can be peripartum cardiomyopathy.
So immediately after the delivery, is she going to go in failure? So what drugs you want to give her?
Ma'am, furosemide is given, diuretics is given, and digoxin can also be given. If it's
No,
not
there are certain indication of digitalization. I don't think the Yukta is staring at us actually to stop.
What about the family planning advice?
Yeah.
Then contraception is necessary. Ideal is vasectomy is
She's
preferred.
primigravida. Your
Oh,
patient.
primigravida, you want to give vasectomize, husband will run away.
First of all, just answer regarding your case, and then you can generalize.
Barrier contraceptive is preferred. Progesterone only pills are given. IUCD is avoided as it can cause infection also. I mean, after primary graviditis, barrier contraceptive is more towards it. And progesterone only pills are
Barrier contraceptive can cause failure up to how much time?
15 to 20% is failure.
So she's going to land up with a pregnancy if you give her barrier contraception. So what is the preferred one? Is a progesterone.
Progesterone
Okay,
only
it could be in the pill, it could be injectable. Now, okay, yeah. So progesterone is it available? Progesterone only pill? So these are the questions, simple questions we'll ask. Because it's not available only, Sirazit.
May I ask you last question?
Yes, please go ahead.
You get a patient who is a critical mitral stenosis. She's obese. She's anemic. She's hypertensive. She landed up in an ICU. So, which is the most important or the most important invasive investigation which we like to do for her, which will tell about her actual hemodynamic status. Invasive, yes.
Transesophageal echocardiography.
Pulmonary artery catheterization.
Catheterization, arterial catheterization. Okay.
Respected judges, on behalf of our PG student, I would like to request you to give a few questions that our student should know or better to know, that will give them edge over other students.
Ma'am, in last 2 minutes for our postgraduates, as this is an academic festival, ma'am.
Yeah, so basically we all know about these simple things which we are going to ask about, effect of heart disease on pregnancy, effect of pregnancy on heart disease, what are the indications for termination. These patients have to be terminated. Then when will you terminate them, early or late? Before 6 to 8 weeks is the ideal, not in the second trimester. Because if you terminate in the second trimester, the risk, or mortality risk, is as if you're going to continue the pregnancy till term. So then again, risk assessment systems, which we have already asked. Now what we are seeing is more and more of congenital heart disease patients and those patients who may have prosthetic valves. So these are the patients who are now coming to us. So probably you will score more if you can talk about pregnancy and with already cardiac surgery has been done. So these patients, how do we manage them? Then you have to talk about their management in relation to the anticoagulants, their doses, what could be the INR which you have to keep, 2 to 3, the INR should always be. What are the drugs which you can give to a patient of cardiac disease? What are the drugs which you should not give? Then if the patient is associated with preeclampsia, how is the risk assessment? And then of course, what are the risk factors wherein the patient may land into cardiac failure, and how to then electively when to admit a patient to your wards? What are the emergency indications for admission to the patient to the ward? Is there any role of induction? If you do an induction, would you do with a prostaglandin? Would you do with a high dose of oxytocin? Would you use a mechanical way of induction? What are the elective indications of surgery in this patient? What are the anesthesia related morbidities in this patient? And all this kind of thing, I think Ashish and Rujita also could add.
Yes, I agree with Surekha ma'am. And then something regarding the pathophysiology and something related to the physiological changes in heart disease. So that
and emergency management of emergency surgical management and management of critically ill patients like Madam Senvaiche, grade 5.
Yeah, prosthesis related. One more question which can give you edge over other people is if she's having a prosthesis and there is a thrombosis of the prosthesis, what you will do? Okay, so heparinization is advised in patients who are undergoing a thrombosis of the prosthesis. One thing is that, and many a times you may even need to do some surgical intervention in these cases also. So you have to read about it in these kind of patients. How what if patient of cardiac disease goes into PPH? Which drug will you prefer? Now you said that I'm not going to give methargin to this patient. So what is the different in management of patient? Many a times we say that PPH may be a little bit advantageous in patients of cardiac disease because little loss of the blood may not harm the patient, but still if she is having more hemorrhage, the amount is more, how to manage? Can you give misoprostol in such case? Then would you use balloon tamponade? So all these are certain, tricky questions in case of cardiac diseases.
Okay, thank you so much.
Yeah, thank you.
Bhagyashree, for
and thank you
for sharing your knowledge and enlightening our knowledge and guiding the Viva right from the basic. Thank you so much, sir. Thank you so much, ma'am. Thank you.
Thank you, NOGS and NKP Salve, for inviting me.
We'll next move to our next session, which is a case presentation on postmenopausal bleeding by Dr. Arya Barve. She's from GMC Akola, and our faculty judges for this session is Dr. Buhariwala ma'am and Dr. Avantika Gupta ma'am.
I welcome Dr. Buhariwala ma'am for this session. She's an honorary professor from Department of OBGYN, NKP SIMS and LMH. We all know Buhariwala ma'am. She is very popular among students. Formerly, she was at NKP and also associate professor at Goa Medical College. She has a special interest in high-risk pregnancy, gynec surgeries, and vaginal surgeries. I welcome you, ma'am, for the session. Our next judge is Dr. Avantika Gupta, ma'am. She has worked for 4 years at JIPMER Pondicherry, currently working as associate professor at a renowned AIMS Institute, 13 national and international publications, and has written 5 chapters in a book. She is a recipient of Foxy Imaging Science Award. I welcome Avantika ma'am for this session.
So let's begin with our this case presentation. Dr. Arya, are you ready?
Can you hear me?
Yes, ma'am, I am ready.
And start presenting your case.
Sure.
Can you hear me?
Yes, ma'am. You're audible, ma'am.
You can hear. Okay.
May I begin, ma'am?
Yes, yes.
Yes, please.
Good afternoon, respected faculty members. Let us begin with our case presentation on postmenopausal bleeding. Here we have a 55-year-old nulli gravida, married since 28 years, postmenopausal since 7 years, resident of Ramdaspet, Akola, who is a housewife by occupation, belonging to the lower middle class according to modified Kupuswamy scale. She had come to us with the complaints of one episode of bleeding per vaginum 4 to 5 days back, which lasted for 3 to 4 days, soakage of 1 to 2 pads per day, not associated with pain nor clots. She had gone to a private practitioner who gave her symptomatic treatment, but patient did not respond. Let us move on to some negative history. No history of vaginal dryness or itching, no history of dyspareunia, no history of vaginal discharge, no history of fever, no history of IUCDs or pessary insertions in the past, no history of trauma to genital region, no history of something coming out of vagina, no history of hematuria or piles, no history of bleeding or clotting disorders, no history of postcoital bleeding, no history of weight loss or loss of appetite, no history of abdominal distension, no history of lump in abdomen, no history of bowel and bladder disturbances, no history of intake of hormone replacement therapy or tamoxifen intake in the past. Menstrual history of the patient. Menarche was attained at 13 years of age. Her previous cycles were regular, painless, lasting 4 to 5 days with an interval of 28 to 30 days with an average flow. Menopause was attained at 48 years of age. Obstetric history. The patient was a nulli gravida. The couple had taken treatment for infertility few years after marriage, but had not conceived. Further details were not known. Past history. As mentioned before, infertility treatment was taken for a few years. No history of diabetes mellitus. Sorry for the interruption. Sorry for the interruption. Past history. Infertility treatment was taken for a few years. No history of diabetes mellitus, hypertension.
Arya?
Yes.
Arya?
Yes.
Yes.
Yeah.
I'm having some problems with my video, I think.
Is there good internet connection?
Yes. I have good connectivity.
If there is any problem, you can turn off your video and present.
Are you able to see my screen?
Yes, it is clearly visible.
Okay.
There is no issue in your screen share.
Okay.
Turn off your video.
You turn off your video, your voice will also get better, you know.
Okay. May I begin? Hello?
Yes, please.
Yeah. Infertility treatment was taken for a few years. No history of diabetes mellitus, hypertension, or thyroid disorders. No history of any medications in the past. No history of breast or colorectal cancer. Personal history, sleep.
We are unable to hear you.
Personal history, sleep, appetite, bowel, and bladder habits were normal. Patient denies any addictions. Family history, no history of breast, colorectal, or gynecological malignancies in first degree relatives. On examination, general condition of the patient was fair. She was febrile. Pulse was 90 beats per minute, regular and with a good volume. BP of 120/80 millimeter of mercury was recorded in the left upper arm. Saturation was maintained on room air. Height 150 centimeters, weight 65 kg with a BMI of 28 kg meter square. There was no pallor, edema, icterus, or lymphadenopathy. Cardiovascular system was normal. S1, S2 heard, no murmurs. Air entry was bilaterally equal with no adventitious sounds in the respiratory system. CNS, patient was conscious, oriented to time, place, and person. Breast examination was normal. Thyroid examination was normal. Now patient was examined in the supine position with her limbs flexed. Per abdominal examination, on inspection, the abdomen was flat with umbilicus inverted, no visible scars, nor any visible masses. On palpation, abdomen was soft, no guarding rigidity or tenderness was noted, no organomegaly, and no palpable masses. Thus, we are confirming our findings of inspection on palpation. Local examination. Patient was now examined in the dorsal lithotomy position. Her external genitalia appeared normal. Sparse pubic hair, no growth or ulceration. Urethra and anal openings appeared normal. On per speculum examination, cervix and vagina were healthy. No discharge, but minimal bleeding was noted. On per vaginum examination, it revealed that the uterus is slightly enlarged in size up to around 6 weeks. It was anteverted, firm yet mobile. Bilateral fornices were free and non-tender, and minimal bleeding was present. On per rectal examination, rectal mucosa was free and no parametrial involvement was noted. My provisional diagnosis here is a 55-year-old, sorry, there's a typing mistake, 55-year-old nulli gravida, post-menopausal since 7 years with post-menopausal bleeding under evaluation. Ma'am, may I proceed with my investigations and treatment part?
Can you hear me?
Yes, ma'am, I can hear you.
Okay. So the patient has been post-menopausal since 7 years, and you told us that her age of menopause was how much? Can you repeat, please?
Yes, ma'am. Patient attained
Her age of menopause was how much?
48 years, ma'am.
At the age of?
48 years, ma'am.
48 years. What is the average age of? Okay, what is the average age of menopause that you know?
Ma'am, in India, the average age of menopause can be said to be around 47 years. But if asked a range, we can say around 45 to 55 years, ma'am.
No, this 47.3 is according to what? According to the studies run by the Indian Menopausal Society, right? And your patient goes according to that.
Yes,
Okay?
ma'am. Yes,
Now,
ma'am.
can you please, at that time my screen had gone off. How much was the bleeding episode? Can you repeat, please?
Yes, ma'am, sure. My patient had only one episode of PV bleeding, which lasted for 3 to 4 days, ma'am. There was
associated with any pain?
No, not associated with pain, nor any passage of excessive clots, ma'am.
And it subsided on its own, or were any drugs given?
Ma'am, she was
Did
given
she receive
symptomatic.
any drugs anywhere outside?
Yes, ma'am. She had received the drugs, which she couldn't tell us actually. But the bleeding had not subsided. And when she came to us, the quantity of bleeding had reduced on its own. She came to us at around 6th to 7th day of her starting of bleeding.
Okay, all right. So, okay, so now how would you like to manage your patient?
Sure, ma'am. Ma'am, I will like to investigate the patient. At the beginning, I will do a routine blood work, including a CBC, RFT, LFT, triple H markers. After that, I will like to proceed with a chest X-ray, ECG. And then for systemic examination, I will like to do a pap smear and a USG A+P, ma'am, which will mainly comment on the uterus, mainly endometrial thickness, endometrium, the growth of the endometrium, and also on the adnexa, bilateral ovaries.
She's having a bit of bleeding. How would you do her pap smear?
Ma'am, actually, when she had come to us, there was slight bleeding, so we avoided taking a pap smear, but we took her pap smear in the next week, ma'am. So at the time of admission, we didn't take a pap, ma'am.
Is there anything special that you would like to tell me about a postmenopausal pap smear, or is it very easy to report?
Ma'am,
Is there anything you would like to mention? Yes.
Sorry, ma'am, can you please repeat the question?
Is there any difficulty in interpreting a postmenopausal smear? Or does it really require an expert to do it correctly? We get misguided sometimes by the smear reports that we generally get.
Right, ma'am. Right. Ma'am, when a patient is in the postmenopausal phase, there's obviously a lack of estrogen, which leads to a very atrophic changes in the cervix and the endometrium per se. So on a pap smear, we might get maybe an inadequate sample or lots of dry cells, which won't be able to comment on a normal milieu of the ectocervix, ma'am. So we will need an expert for the reporting of the exfoliative cytology.
Inadequate, even an expert will not be able to recognize the cells. But what are the cells generally in a postmenopausal smear? What are the types of layers of cells? Can you tell me?
Parabasal cells, intermediate cells,
and
superficial cells, ma'am.
So in a postmenopausal smear, what cell layers would you expect and percentage? Maximum will be what? What cells? As she advances in the postmenopausal age, what will be the percentage of these cells? Will you have parabasal cells in plenty? Will you have intermediate cells in plenty? Superficial cells in plenty? Tell me. Will there be superficial cells in the absence of estrogens?
No, ma'am, there won't be. So we will have a majority of parabasal cells, ma'am.
So can you tell me the maturation index?
Ma'am, 0, 0, 100.
0, 0, 100? That is 100%. Okay, to save time, I'll explain to you. Parabasals will be the majority of the cells. They'll be almost 85%.
Okay.
Intermediate will be 15%. and there will be hardly any superficial cells. Now the debate is this, that can we misinterpret parabasal cells? How do they look? Can you attempt to tell us? How does a parabasal cell look? Intermediate, you know very well, flattened with vacuolated nucleus, basophilic, etc., etc. But how does a parabasal cell look? Parabasal cell? If you don't know, tell me. We'll save time, dear.
I'm sorry, I don't know, ma'am.
Okay.
I haven't read.
So the nuclei are larger and there is lesser cytoplasm. All right. They are not flattened cells. They are more rounded cells. And therefore, by an unexperienced eye, they are recognized as dysplastic cells. Is that clear to you? And you will be misguided in the smear. Is that understood? You will think that this is some kind of a CIN and you may progress on those lines. So a post-menopausal pap smear is a challenge to be reported correctly.
Interpret.
Second thing you said, after pap smear, what will you do? You will do a, which sonography would you prefer? Transvaginal or abdominal?
Ma'am, firstly, we will like to do an abdominal sonography and proceed to transvaginal only if we get some abnormal findings.
Is that so? Gynecological with a normal sized uterus. I agree with you that you can scan the lower abdomen, but your real study will be transvaginal, no? So what do you expect to find over here? And how will you interpret it? Do you know the transvaginal report of this patient?
No, ma'am. We had done only an abdominal scan and then proceeded with a CT scan, actually, ma'am, because the finding which we got on abdominal ultrasound, we got an increased endometrial thickness. So my seniors and colleagues.
What was the report of the transabdominal scan?
Ma'am, the transabdominal scan revealed an endometrial thickness of 14 mm and bilateral adnexa were normal with no intrauterine collections and bilateral ovaries and fallopian tubes were normal on that scan.
Okay. So why did you do the CT scan? Can you tell me straight away?
Not straight away, ma'am. After we got this USG report, we posted the patient for an endometrial biopsy, actually, as well as a cervical biopsy.
All right. So then you will tell me after that why you did a CT scan, the reasons. Okay. So you did a ultrasound and then you posted the patient for endometrial biopsy. How was that taken? Can you tell me?
Ma'am, actually, we did not do an office endometrial biopsy. We posted the patient in our elective OT under short general anesthesia, and we took an endometrial biopsy, ma'am.
With what instrument?
From all four quadrants, from all four walls of the uterus, ma'am.
All right. And what is the report?
Ma'am, report was endometrioid variety of C endometrium, ma'am.
Endometrioid variety of
C endometrium.
Okay. Would you like to elaborate on that report? What type of
type?
What was the grade? What was the grade?
Ma'am, grade 1 was noted with typical histological findings. Loss of polarity was noted.
Grade 1, if I will know.
Grade 1.
What do you call grade 1 in endometrial cancer?
Grade 1, ma'am. Sorry. What?
Yes. What is grade 1, grade 2, grade 3? Tell me.
Okay. Ma'am, we are commenting on the stromal invasion, solid components present in the malignancy, ma'am. So grade 1 denotes less than 5% of stromal invasion. And then we move on to
Solid
grade 2, grade 3.
Solid component. Okay.
Solid components. Yes, ma'am.
Yeah. And all right. Okay. And what is 2? What is
2 is up to 6 to 50% stromal involvement, and grade 3 is more than 50% stromal involvement.
All right. So this is a well differentiated endometrioid cancer. All right.
Yes,
okay. So with this report, you would like to proceed. Okay. Now, since you did the age-old DNC on the patient, you did the age-old DNC on the patient. Earlier, we used to do a fractional curettage, right?
Right, ma'am. Right.
Now, how do you know that there is no cancer in her endocervix? You took all 4 quadrants, something you told me.
Yes, ma'am. Ma'am, in the same sitting, we also took a cervical biopsy of the patient, ma'am. And the cervical, it showed normal histology. So we confirmed that the cervix is not involved here. And the carcinomatous growth is restricted only to the uterus.
You did an endocervical curettage, and then you did an endometrial curettage. All right. Yes. And these were separately
sent for histopathological examination. Yes, ma'am.
Showed cancer, right?
Yes.
Okay. So therefore now, how will you further manage her? Supposing there was a polyp, instead of this thickened endometrium, supposing there was a polyp, then what?
Ma'am, after I get the report, I will get consents of the relatives and the patient. With due anesthetic preparation, I will post the patient for polypectomy, ma'am, and send the polyp for histopathological examination.
My co-judge would like to ask any questions on this at this particular junction.
I would like to make few comments on our history and examination part.
Okay.
Whenever you are taking negative history, write the important common negative history first instead of rare things like pain. Trauma is not a usual cause of postmenopausal bleeding. We don't see traumatic postmenopausal bleeding, pain, fever. All these will come at later part. And second thing is, don't get biased if you know the diagnosis. Don't take your history along, like if you know that this case is CA endometrium, don't get biased.
Right.
You have to rule out CA cervix and other causes also.
Right.
So you asked about dyspareunia. I assume that patient is sexually active. And in case she is not, then you have to mention that she is not sexually active. Okay. So if you have asked about dyspareunia, you could have asked about false smelling discharge, postcoital bleeding also.
Okay. Okay.
Okay. And 7 years is big duration. So they may forget any previous episode. You have to ask them again and again. And if this is the first episode of postmenopausal bleeding, then you tell that she never had any other similar episode in past.
Okay. Ma'am, as a matter of fact, yes, ma'am, please continue.
Why do you think infertility history is important in postmenopausal bleeding?
Ma'am, patients with infertility tend to get treated for the same, which includes high doses of FSH, LH, which and estrogens also, which have a detrimental effect on the endometrial milieu. And so these patients are prone for endometrial hyperplasia, endometrial carcinoma. And also the second part being, these patients have a lot of anovulatory cycles, which can also contribute to these factors.
Okay. And in examination, you told patient was examined in lithotomy position. We examine patient in dorsal position, not lithotomy.
Yes.
Okay. Again, like in history, I told you, don't get biased if you know the diagnosis. In pervaginal examination, the comments on cervix are missing. So keep your mind open for all differential diagnosis. In PV also, you have to write what was the feel of cervix.
Okay. Okay. Ma'am, as a matter of fact, when we received this patient, this was the actual course that we followed. I was not biased, me nor my colleagues nor my seniors. This is the actual history of the patient that we.
Problem, that was the impression I got, because you didn't ask about foul smelling discharge, postcoital bleeding. So,
ma'am, I
thought
asked, ma'am. I have mentioned it in my negative history.
Postcoital bleeding?
Yes, ma'am. Yes, ma'am. Ma'am, it's right here. I'm sorry, I'm not able to start my video due to some reason.
So, it's better if you combine dyspareunia, postcoital bleeding, and foul smelling discharge in one line. So, we will get the impression that you have ruled out CA cervix. It is looking like that you have taken the causes and written one by one.
Okay.
And whenever you asked about the investigations, first you have to tell that I will do these investigations to confirm my diagnosis. This stands true for any gynae case. Don't jump to pre-op investigations, CBC, HIV, HBsAg. Why you are not planning surgery right now? First, you have to tell I will do pap smear, TVS to see all these things to confirm my diagnosis.
Right.
Okay. One more thing, cervix didn't have any growth. If suppose you have taken pap smear and pap smear reports squamous cell carcinoma and there is no growth, can it still be CA cervix?
Ma'am, of course it can be CA cervix, but again we'll have to rule out metastasis to the cervix or an endometrial carcinoma extending to the cervix. But we cannot deny the possibility of CA cervix.
How common is metastasis to cervix? Which is the primary which metastasis to cervix?
Are you talking of spread to the cervix of endometrial cancer?
Spread, ma'am. Spread.
Okay, it has come down into the cervix.
Yes.
Okay, if suppose pap smear reports squamous cell carcinoma, how will you proceed with your diagnosis?
Ma'am, I will proceed with the CT scan. CT scan, ma'am, to check the further spread of the CA cervix.
No, first you have to make a diagnosis. You have not made a diagnosis. Pap smear is diagnostic of CA cervix?
No, ma'am. We'll have to proceed for a biopsy.
Pap smear
and colposcopy also, ma'am.
What is the sensitivity of pap smear to diagnose CA cervix?
A conventional pap smear.
Recording in progress.
Will you like to do colposcopy?
Ma'am, I would like to do colposcopy in that case, ma'am.
Suppose you did colposcopy and you took a colposcopic directed biopsy, the histopath report is CIN3.
Okay. Then I will proceed just for confirmatory purposes. I will proceed with a cervical biopsy.
So you have taken colposcopic directed biopsy. There is a lesion, but the report is CIN3.
Ma'am, then I will proceed with a.
You are having an echo. Okay,
The CT scan and an MRI to check.
Please log in from only one device, otherwise it will give you an echo.
Yes, ma'am. Yes, ma'am.
Now go ahead.
Ma'am, if the biopsy is detecting a CIN3, I will like to proceed for a CT scan to check spread and then plan surgery accordingly.
CT scan is not the answer. Even if you have CA endometrium, CT is not mandatory investigation. For CA cervix, is CT mandatory? First, you have to make a diagnosis. Any other PG can tell what is the next step in management. If PAP is showing squamous cell carcinoma and colposcopic directed biopsy is showing CIN3.
Sorry to interrupt you, judges, but we have only 2 minutes left, ma'am. Can we conclude the case?
Hello.
Yes, ma'am.
We have only 2 minutes.
Hello.
We are running
Only
short.
2 minutes.
Can we conclude the case?
So supposing it is endometrial cancer, what will you do? Can you tell us quickly? Madam? Can you tell us quickly?
Yes, ma'am, sure. Ma'am, if it's an endometrial cancer, I would like to proceed for a TAH BSO along with a staging laparotomy.
Staging laparotomy. How will you do that? It is a well-differentiated endometrioid carcinoma. So what are the things you will remove?
I will remove the uterus, cervix, upper, let's say in my case, it was not an advanced CA endometrium. So I would like to remove only the upper 1/3 of the vagina, along with the bilateral parametrium, ovaries, fallopian tubes.
Parametrium also you will remove?
As close to the specimen as possible. Like,
an extrafacial hysterectomy, right?
Extrafacial, yes, ma'am.
What about the lymph glands?
As I said, my case was just a grade 1 case. So
okay, let us say it was a clear cell carcinoma. Then what would you have done?
Ma'am, I would have biopsied the pelvic and paraaortic lymph nodes.
You would have removed, you would have treated her just like an ovarian cancer. The staging of an ovarian cancer with a thorough removal. Okay? So those high-risk cancers have to be treated in a different way. All right? Okay. So this is the answer finally for the management of your patient. Now we were talking of post-menopausal bleeding. There can be lots of other causes. As you said very well, that endometrial carcinoma was in your case, and cancers account for how many % of cases of postmenopausal bleeding?
Around 15 to 20%.
Okay, about 15%, right? And endometrial carcinoma becomes more and more common as the patient grows older.
Yes.
The remaining, it is a more of a non-malignant. Now, there are so many lesions, etc., which can lead. What is the commonest of the non-malignant, where you just have a pinkish discharge? Can you tell me?
Ma'am, atrophic endometritis.
Very good. Atrophic endometritis. You may have just endometrial hyperplasia. Supposing it is endometrial hyperplasia without atypia, what will you be your management?
Ma'am, I will like to give her a conservative management by giving her oral progestins, at least for a duration of 3 to 6 months, and see if she is responding to the treatment.
I agree with you, or you can even put in a Marina or an LNG device.
Right.
That is also an option. If it is a fibroid, do fibroids lead to postmenopausal bleeding?
Ma'am, very rare, ma'am.
How? That's important to understand earlier. Can you tell me how? The postmenopausal bleeding is 7 years, the fibroid is quiet, which was probably there earlier.
Right.
And now there is a bleeding. How does that happen? It's very interesting to understand.
Ma'am, if the patient... Yes, ma'am.
Yes. As what happens to the myometrium after menopause? It shrinks. It shrinks. Have you followed?
Atrophies and even the blood vessels supplying the myometrium
gets driven into the endometrial cavity. All right. And the endometrium over it gets traumatized, gets damaged, and she starts bleeding. So every case of fibroid uterus need not be associated with a cancer, and there can be a bleed for the first time in the postmenstrual period, now in the postmenopausal period. Now, there are so many other reasons, foreign bodies, etc. We won't get into all these things because of paucity of time. You did otherwise quite well, better. But one thing, please remember that you are going to become a consultant. And in the public, what about the socio-medical aspect of postmenopausal bleeding? Even in educated class of society, people don't know that a postmenopausal bleed is a red flag. So it becomes our duty to alert the public about the dangers of postmenopausal bleeding. And if you have a question on postmenopausal bleeding, please mention that awareness of postmenopausal bleeding in the general public is a very, very important thing. Would my friend like to add anything? Avantika?
One question, if you have a pelvic mass with postmenopausal bleeding, what will be your differential diagnosis?
And firstly, I will rule out whether the mass is arising from the uterus, ovaries, or if there is another non-gynecological origin of the mass, ma'am.
Tell me 3 or 4 causes.
CA ovary.
CA ovary causes postmenopausal bleeding?
Sorry, ma'am, can we conclude the case, ma'am?
Just let us finish this little thing.
Sure, ma'am.
Can CA ovary lead to postmenopausal bleeding? Quick answer.
Not always, ma'am, but
tell me one answer which causes postmenopausal bleeding.
Rarely it can. If it metastasizes along the tubes into the fundus of the uterus, it can bleed from there. It can be a misfit tumor sometimes. So such things could be there. Anything else? Can you think of a hormone-producing tumor of the ovary?
Dysgerminoma.
Dysgerminoma will cause bleeding. Does it produce estrogens?
No, ma'am. Hormone producing.
One answer quickly. There may be others. Granulosa cell tumor?
GCT.
Yes.
Yes.
So you have to brush up the causes, which is the basic thing. All right?
Yes, ma'am. Yes.
So, on behalf of my co-judge and myself, I thank you all very much for the opportunity for giving us this time. And I wish all the best to our candidate who has done otherwise well in the Viva.
Thank you, ma'am. Thank you for your good discussion, ma'am. It was really a blessing to learn from you. Thank you, ma'am. Thank you, judges.
Thank you. Thank you for calling us.
Nice presentation, Arya. We'll move to our next session, which is ward round cases. And our first presenter is Dr. Ushma Mishra. She's from MGIMS Sevagram. And our faculty judge is Dr. Shulba Joshi, ma'am.
Yes, I am there. I have logged in.
Ma'am, for the second.
Good afternoon.
Shulba Joshi, ma'am, is professor.
Good afternoon.
LMH Hospital, and she has a wide teaching experience. And we all know you, ma'am. Thank you, ma'am, for joining us. And we have our next, the case given to ma'am is a 60-year-old obese day 2 post-hysterectomy case. Surgery done for vaginal hysterectomy with anterior colporrhaphy and posterior colpoperineuraphy. Surgery was uneventful. So this is the case scenario for Dr. Ushma Mishra. Ushma, are you there?
Yes, ma'am.
Yes. Can we begin with the case discussion?
Yes, ma'am.
Yes. Over to you, ma'am.
Ushma,
yes,
actually about this case presentation, this is included in our obstetric MS examination. And we really do not have clear-cut ideas. Kenkre madam is there, and I think Hemant Deshpande sir, Jaju madam is also there. I want their inputs also, how they are conducting this. Because most of the times when we conduct this exam, we keep the case discussions, and many of the examiners are also not aware what to do in this. And in fact, they have omitted this case, ward round cases. but 25 marks are allotted to obstetric round case and 25 marks are for gynec case. One of my senior teachers had told me how they are conducting this. In this, you are supposed to be the consultant now, and your junior will present the case ward round to you, and you are going to act like us, we consultants, and you are going to ask the student whatever question, means you are the patient, the student JR1 will be presenting the case to you, and you will be like the consultant. Aruna madam, is it so in your?
Yes.
Are you doing the same thing?
Yes, I'm with you.
Huh. No, I just wanted to ask how you are conducting this case.
Yeah, as you rightly said, somebody will present, a junior registrar or somebody will present the case. Like imagine this case has been presented. Now, Usha, you have come for rounds. Now, the consultant who's the examiner will ask you questions with regards to this patient. Now, she's a day 2 post-hysterectomy case. She has had a vaginal hysterectomy, anterior colporrhaphy, posterior colpoperidorrhaphy. Surgery was absolutely uneventful. So she didn't have any blood transfusion. She didn't have any problems during surgery. So Usha, second post-op day, the patient is asking you, doctor, I have a pack inside. Would you like to remove it?
Ma'am, first I will
pack the vagina after a hysterectomy is the first question.
Yes, ma'am. Ma'am, I will examine the patient from first. I will examine her vitals.
Okay. No, answer my question. Don't go. Answer my question. Don't go beating around the bush. You have examined the patient and you are about to go back for the other patient, and the patient is asking you, doctor, I have a pack inside. Would you like to remove my pack? So as a consultant, it is extremely important for you to remember that I have packed the vagina and I need to remove the pack. So you have to make sure that the pack is removed on the second post-op day. Okay. Yes. What about removing the catheter? Would you remove the catheter on the second post-op day?
Ma'am, what? Catheter?
Yes, urinary catheter. She's got an anterior colporrhaphy.
Yes.
So she has cystocele repair. Would you like to remove the catheter on the second post-op day? What is your policy?
Ma'am, as we know, the post-op day 2, there is because we did anterior colpoperidorrhaphy and posterior colpoperidorrhaphy, there is chances of post.
Will you remove the catheter or not is the question.
Ma'am, we can remove after 48 hours.
Okay, so you will not remove the catheter on the second post-op day. Fine. It's a large cystocele. You would like to keep it for 48 hours. Perfectly fine. You will remove the catheter on the second at the end of 48 hours. Okay. What are the instructions that you would like to give to the nurses when the catheter is removed? Sulava, should I continue it or
what I am thinking, Aruna, is supposing now I am presenting this case, what all things she is supposed to ask, what are the things which are missed by me, and she is supposed to ask. That is what I am expecting as a consultant from her. Shruti, this is the patient.
Now, with this history, what would you ask the patient? What would you ask? What would you like to know more about this patient?
Shruti madam, this patient is second day post-op. Vaginal hysterectomy was done. Her general condition appears to be good. Her pulse is 86 per minute. Pallor is present, but her urine output is only 800 cc. She has received 5 units IV fluids and she has received antibiotics. She is obese, so we have started her after 12 hours after surgery. We have started her on low dose, low molecular weight heparin. Patient has passed flatus. Patient's pack has been removed and it is partially soaked. We have kept her catheter, and because of her low urine output, we are worried. Madam, please let us know what to do.
Ma'am, first we send all the first I will see cause of low urine output. It can be pre-renal or can be renal. Means matlab, if there is low not she is agar humne ma'am if we didn't